Well, hello, everyone. I want to thank everyone for coming here today and for everyone who's joining in. For the people joined today, I just want to let you know, thank you first for being here in person. If you've never been here, this is our 16th annual conference here at UPMC Children's. It's quite impressive. This is my first year helping participate. Right now, as of today, we have over 500 and some people in attendance virtually. So this is a pretty big course. A lot of people virtual attendance. We're really excited. We have over 20 some physicians going to be talking throughout the course of 2 days. For those who's going to be staying in person, we got some really good simulations and hands-on demonstrations for Friday. At this point, I'd like to introduce our ECLS Medical Director, Dr. Mario Castro.
So, good morning, everybody, and thank you for being here in this ECMO meeting, the 16th Children's Hospital of Pittsburgh ECMO meeting, started by Peter Werden, then by Dr. Villegas in the last year. So this year is no more different. All the specialties, the PQ, NICU, and the CICU will participate. The ECMO specialist and the palliative care team will be here. So welcome back, everybody, and enjoy this. And for our people that is online, remind you that it's going to be today until Friday. Thank you.
So let's get started. We got a few housekeeping things. This is for the continuing education information. We'll run this throughout the course so everyone knows how to go ahead and access as far as continuing education points. Next up must be completed by October 22nd to get full credit for the actual course attendance. This time I'd like to introduce myself. My name is Michael Anselmi, perfusionist, director of ECMO management here at Children's. I'm going on my first year. My background is perfusionist. I've been here about 25 years. Pediatrics probably been the last 5 years of my career. Really excited, kind of rejuvenated my whole career with pediatrics. Excited to be here with this team and work with them. I learned a lot from everyone here today. As you all have met Dr. Mario Castro. He's been here since 2018. He is our ECMO medical director. He's a pediatric cardiothoracic surgeon. We always joke about if there's an ECMO going on, it's usually Mario one who's doing it. Dr. Luciana De Silvia, she's one of our pediatric thoracic surgeons. We just had, luckily, to have Dr. Richard Tang join us this year. He came from Texas Children's Hospital. We're really excited to see what he has to bring to our team as well. I definitely would have to mention David Palmer. David is actually our senior director for UPMC Pro Circa. Not only does he oversee the perfusion team here at Children's, David also oversees all the pediatric and adult ECMO throughout the UPMC Pro Circa. To give you a scope of what that is, what David oversees, through a calendar year, we probably care for probably about 250 ECMOs between adults and pediatric with UPMC Pro Circa. Last but not least, the person who's got put all this in place, keeps me in line and everyone else in line, and organizes it is Merritt Aspenleiter here in the back. Glad to have her here, and she's been kind of mentoring me along as I start my career here at Children's. Look at a little history of UPMC Children's. It goes way back, over 46 years. If you look at 1979, Children's became the second hospital in the U.S. to offer ECMO clinically. Does anyone out in the audience have an idea about what else was going on in 1979 or close to it? Anyone? Raise their hand, except for Mario. Anyone? Just in 1975 is when Dr. Bartlett and UC Irvine put the first patient on ECMO successfully. So we've been around a long time here at Children's. We have a long history of it. A little forward, we go to 1983. Still a few centers that were performing pediatric ECMO. The big three you see in a lot of literature right now is the University of Michigan, University of Pittsburgh, and the Medical College of Virginia, which is now VCU. Few years, jump ahead 3 more years, 18 neonatal centers start adopting ECMO. I think right there, if you look at all the literature in the past, that was the actual beginning of ELSO, all that data collection. It was those centers, those 18 centers, not just the three I just mentioned, but it was the CHOP, the UCLAs. Those centers were starting to combine information, and they collected data from like 700 patients and outcomes. And that's what really led to 1989, the adoption and the actual start of ELSO. We're proud to say that we became number 2. Right now, when we put our ELSO information is, Children's Hospital of Pittsburgh is number 2 in ELSO registry. Fast forward 46 years, 2025, we're proud members of the ELSO Platinum Designation Award. This is our second year getting it. We have a good talk later in the week about the Platinum Awards from ELSO as well. A little bit more about our program. Our physicians, we have our 3 main physicians I mentioned earlier. All of our cardiac pediatric surgeons can cannulate, but the 3 I mentioned earlier are the ones pretty much we'll put our patients on. And we also share that insertion as far as ECMO cannulation with our pediatric general surgeons. Today, we have 6 general pediatric surgeons. A lot of them will be talking here with us today. A lot of thanks that Dr. Castro pointed out is our medical management from our critical care team, critical care medicine team. We offer ECMO on 3 units, our CI, our PICU, and our NICU. Probably one of the most important things here, near and dear to me, is our ECMO team. We have 8 full-time ECMO specialists and 5 casual specialists, and it's a blend between RT and nursing. Most of them have been trained in-house from us. As also calls that they're primers. Our ECMO specialists can prime, blood prime, initiate ECMO, and they are in-house 24/7. We are a true ECPR center, meaning we will put ECMO on anywhere 24/7. Very, very little delay in getting our patients on. And I'll talk a little bit more about those numbers later on. We do have a supporting cast with us, and it's what we call the ECMO support team. When I look at this model, when I came here, I would say it's an ECMO specialist hybrid model. What I mean by hybrid, although it's driven by our ECMO core team, we do have supporting members. We have an ECMO support team, which are 10 ECMO RNs. We trained them in-house. It was based on ELSO's guidelines of didactics and hands-on training. These nurses are available to us for any time our coverage increases, a high census, or we run 2 or more units. Unfortunately, with the model we have and the number amount of people, we have 3 units we can put ECMO on, but we have to cohort them to at least 2 units. We cannot run 3 at a time. So this is when we pull our nursing team in as well. It's a nice model. It's efficient model. It's financially responsible. I do like it. It just takes a while to get used to seeing it, but it's actually a good model. I do like it a lot. Of course, our perfusion team here in the bottom, we have 6 licensed perfusion. They help with initiation, troubleshooting, education, and they're always available if we need any support as well. One thing about our program here, I got this from David, and I got it from everybody started. We keep it safe and simple and streamlined. We have 2 circuit. We're one of the centers, a few centers that only uses 1 platform. It's the Abbott CentraMag. We don't use multiple platforms, which I'm a big fan of. We use the Abbott CentraMag, 13 kilograms and below. That will get us to 1.5 liters. That's our patient population. We treat on a quarter-inch circuit. We use a PDMag pump and the AMG infant oxygenator. It is probably one of the better oxygenators out there for the space for 1.5 liters of flow. Having really good outcomes from it. The larger circuit is greater than 13 kilograms. Again, it's the Abbott CentraMag system. We use the CentraMag centrifugal pump. We could go anywhere from 13 kilograms to 110 kilograms if we need to. We use the Medtronic Nautilus Smart Oxygenator, which we really like because it decreases the amount of transducers we need because we have the digital readout on it. It's a great tool and great resource. If you haven't seen it, you will see it in our lab this weekend, Friday, if you're here in person. In that same vein, it's simple and streamlined. David Palmer, he's a big advocate of labeling everything. It's kind of an inside joke here, but David likes to make everything simple, streamlined, and very safe for our team. We divide our ECMO circuit, and you'll see in the 3 section. First is the blue line, which is the negative side, which is for monitoring and very little access to it for safety reasons, for air entrainment. The next line is what we call our medication line, the orange line. That's where all our infusions go through, whether it's anticoagulations or medication, especially on our smaller patients. And then the arterial line, very similar to our blue line, very little access to that circuit. And we will go over the circuits verbatim. It'll be very redundant by the time we leave this course. A little bit about our volume. I'll start with, again, we are a true ECPR center. We will put ECMOs on anywhere throughout the hospital. We manage our patients in 3 units, as I said earlier, CI, NICU, and PICU. Our CI was probably, I would say 60 to 70% of our patients are put on in the CI and managed in the CI, followed by the PICU and our NICU as well. VADs, we also do VADs. For us, for our team, we cover the centrifugal valves like the Centromag. If it's a more durable valve, VAD, like a Berlin, we have an artificial heart team that watches those. We do about 70 ECMOs per year, average. All right, last couple slides is just us looking forward. On the far left is our medical director for the NICU, Dr. Burhan Mahmood, accepting the ELSA award just recently. It looks like he's standing up straight. He didn't have too many cocktails for the picture, but and then we have on our side here is our ELSO scores, and the title is Maintain Strength in ELSO, Center of Excellence and Platinum Status. We really look at our report card for ELSO, and that is our foundations, how we move forward. If you look at it, the first 4 sections, I always say the first 4 sections, when you're ELSO, when you're platinum, they really don't move that much. That is your foundation. That is your staffing. That is your model. That is what you do is for your education. It's the last sections that the ones that change throughout the year that are most important. When I look at that, I said, it's great. We're platinum. We crushed it this year. But I look at some of the spots where we have room for improvement. And we're going to have a really good panel discussion tomorrow about this. Put some mouse here. Second thing is education. We really want to invest in our team for education, not just our staff, our bedside providers, but also our clinicians and the whole team as far as our specialists. If you look from left to right, it's impressive. These models here are built in-house. These are what I call the David Palmer models. They are great. They are good for APPs. They are good for physician practitioner skills, whether it's a cervical model or a cut-down model or a groin model. And then if you look on the end is the high fidelity simulation. You know, I think what really sets us apart from a lot of other centers is we move away from a lot of the wet lab, which is still fine, but to more high fidelity simulations where you're incorporating all disciplines and getting them involved. What you're going to see on the very far right is what you're going to see Friday for the people here. We're going to do some of these trainings. We have a lot of good resources as far as education, and that is one of my personal goals this year is to build that out this year. Lastly is our team here. Like I said, it's 46 years. It was 1979. We did our second ECMO here. We have a long, rich history. Number 2 in ELSO registry. We want to continue providing the highest standard of care for our ECMO patients here at UPMC Children's. With that, I say thank you. Enjoy the next couple of days here. Thank you. So I already mentioned his name. Next person up to speak would be Dr. Burhan Mahmood, and he is our medical director for our NICU department.
Thank you, Mike, Merritt, and the organizers for the conference for the opportunity to talk about neonatal respiratory ECMO. I'm going to talk about the management nuances. It's a big topic, obviously, but in the time slot, we'll just focus on the most important thing. It's great to be a neonatologist. Babies always come first, and they make wonderful patients. Do I just use the mouse? Oh, that didn't work. Right here. Okay, I see it. Okay. All right, I don't have any disclosures. So the first ECMO, the first baby with respiratory problems who was placed on ECMO was a long time ago in 1975. And since then, we've been taking care of babies with cardiorespiratory failure who are not responding to conventional medical therapy with ECMO support. But as you can see from this also graph, there is a decrease in the number of neonatal cases being put on ECMO. On average, about 500 to 600 cases as per ELSO registry every year. So the numbers have gone down because our strategies are improved in taking care of them pre-ECMO, and outcomes have improved without requiring that support. But you can also see that there is an increasing number of more complicated, sicker patients, which we call the other diagnosis. They usually have multi-organ failure, multi-system involvement of their disease process. They are on ECMO for longer runs, and they can be associated. They are associated with concerning outcomes, morbidity and mortality. If you look at the last 5 years data, the survival of neonatal respiratory ECMO coming off ECMO is close to 80%, and it goes down quite a bit to almost close to 70%. So 30%, 3 out of 10 babies with neonatal respiratory decompensation may not survive. And the reason is because of these sicker patients. And in my second talk later on today, I'm going to talk about a little bit on those lines. So survival does decrease for all categories, but it still remains the best for neonatal respiratory patients. In terms of the ECMO modes, we have the veno-arterial, veno-venous. Our center at Children's NICU, we use veno-arterial mode of ECMO support. And if you look at, again, the data for the last 5 years from the ELSO organization, you can see that most centers still use VA mode. Almost 20 to 25% of the centers use veno-venous. The thought is that that patients are sicker, so they require more support than just respiratory support with the veno-venous and the veno-arterial mode. It helps them come over from difficult clinical scenarios. But these patients are sicker as well, and they have longer runs on ECMO. As you can see, the overall survival is better for the veno-venous than the veno-arterial support. So how can we, as ECMO caregivers, improve outcomes and improve the morbidity and the mortality that I just mentioned? The management approach. The goal is to ensure that oxygen delivery and perfusion is adequate while maintaining, without avoiding overzealous support. Or the word I used to use is gentle management strategy. So don't overdo because that can lead to problems during the ECMO run. Recognize that each ECMO patient is different and understand the specific management needs to optimize care. So over the years, I have learned that each baby has its own set of problems that you need to address to ensure that they do well with the ECMO management. Provide ECMO in a safe and effective way to minimize complications and improve outcomes, and formulate strategies early to help expedite coming off ECMO support. And it's very important. Every extra day on ECMO increases the risk of complications in a neonate. We have cardiorespiratory criteria that have been around for a long time to determine which baby is going to need ECMO support who is not responding to conventional medical therapy. In the NICU world, we use the oxygenation index that takes into account the degree of mean airway pressure, the pressures that we are using to beat on the lungs, and the amount of oxygen, and how is that affecting, how that is affecting the actual oxygenation levels in the baby to determine the candidacy for ECMO. And when the levels are very high with oxygenation index, more than 30 or more than 40, the risk of mortality goes up quite a bit. So when we reach that point, that's when a decision is made that continuing conventional therapy is going to be more harmful for the baby, and an ECMO initiation is on the cards. Other criteria include acute deterioration, acute hypoxemia, where the oxygenation levels drop dramatically and there's not enough time to do something about it. That may require to go on ECMO support. Severe acidosis, intractable shock, hypertension, situation of CPR. Patients with intractable air leaks, in our history, we've had a few patients who had severe pneumothoraces, multiple chest tubes, and not getting better with even minimized conventional respiratory support, and had to be put on ECMO to remove the barotrauma and the volume trauma that they were getting for them to get better, and it did work. So there are many criteria, but oxygenation index is what we primarily use to make decisions. We also have exclusion criteria. Babies are small; they are at risk for complications, as I mentioned. These criteria have been around for a long time. Some of them used to be absolute contraindications, but now they are considered as relative contraindications. Prematurity, low birth weight of less than 2 kilograms. They are now considered as relative exclusion criteria because centers are reporting that that babies who are between 32 to 34 weeks and little less than 2 kilograms can be successfully managed. Our lowest gestation has been 34 weeks, and our lowest weight has been 2 kilograms who have done well with ECMO support. Patients with lethal medical problems like uncorrectable heart disease, lethal congenital anomalies, lethal genetic diagnoses, evidence of irreversible neuro damage or lethal metabolic disease are not good candidates. ECMO is a treatment for reversible disease process. It's not going to change the underlying problem. And if it is something that is uncorrectable and it is lethal, then ECMO management will not change that, but it may give time for diagnosis to be established. So sometimes we may have to go that route. If there is a suspicion for a metabolic disorder, for example, but we don't know what the outcome is going to be, we don't have a diagnosis, ECMO can be initiated while the genetic testing is pending to decide, whether it was a useful decision or not. In babies, we have to have other considerations as well. They are young, they're small. When they are not feeling well, the disease severity can impact their multi-organ systems. Degree of hypoxemia, acidosis, and the severity of the disease pre-ECMO can impact clinical outcomes. The contact of the blood with the circuit will activate the coagulation cascade. Platelet activation can lead to problems with thrombosis, fibrin deposition, which can lead to strokes and bleeding complications, especially in patients who are also coagulopathic. And then, of course, on ECMO, we have to use anticoagulation. So all these factors in a developing hematologic system in a young baby who is not feeling well can increase the risk of complications. So we have to keep that in mind when we are taking care of babies on ECMO support. The biggest complication we worry about is neuro complication, as I just mentioned, stroke, intracranial hemorrhage, because they can have long-standing consequences for the baby. Renal insufficiency is not very uncommon. Patients can get fluid overloaded. Kidneys are also very young, and in the disease state, they may not function really well. The underlying lung disease, the severity of it can impact the ability to come off ECMO support. Cannulation issues have to be considered. Babies who are small, as I mentioned, babies who are 2 kilograms or young, cervical cannulation can become a problem. The blood vessels may not be big enough to allow for an adequate size arterial or venous cannulas to be placed. So these are all things to keep in mind. Patients with diaphragmatic hernia are a challenge as well from the similar reasons. We use a centrifugal ECMO pump system in our center, including in the NICU. You can have flow issues, especially when you have smaller cannulas in babies. So we have to keep that in mind because it does increase the risk of hemolysis, and hemolysis, which leads to presence of plasma-free hemoglobin in the system, in the body, can damage organ systems, especially kidney function can be adversely affected, and hemolysis also increases the risk of thrombosis and intracranial hemorrhage in babies. So these are all real issues that you have to keep in mind whenever you're putting a baby on ECMO. The complications, as I mentioned, are not just related to hemolysis and strokes and neuro issues. You can have neck vessel injury, especially in small babies. Damage can occur to the neck vessels during cannulation, during ECMO. At the time of decannulation, cardiac injury can occur. The heart is a very small organ system in a baby, and these big cannulas are sitting there, and they can certainly cause cardiac injury. Air leak, effusions, hemothorax are known to happen. Babies who have chest tubes in place and they go on ECMO and they are on anticoagulation can certainly develop bleeding complications. So these are all things that you have to keep in mind. Fortunately, at our center, our complication rates are low because we pay very close attention to all these details. And the topics that I want to discuss for this talk are just going to focus on these main management categories when you're taking care of babies on ECMO. I'm going to talk a little bit about ECMO cannulation and how we optimize hemodynamics. That is very important to ensure a successful ECMO run. The nuances of ECMO pump management, respiratory care strategy, that is very important. That has to be implemented as soon as the baby goes on ECMO. How do we manage anticoagulation? Anticoagulation is needed on ECMO to avoid clotting in the circuit. Coagulopathy therapy. Most of our patients, almost all, have some degree of underlying coagulopathy that is going on, which increases the risk of complications. So monitoring it and managing it aggressively is very, very important. Transfusion decisions are important. Studies have shown that too much transfusion can increase the risk of thrombosis and can be negatively affected with outcomes. So you have to weigh risk versus benefit about what level of hematologic labs you want to chase to avoid, say, for example, platelet counts are low. Should I give platelets to avoid the risk of bleeding? Too much platelet transfusion, studies have shown, can be associated with problems as well. So it's a decision that has to be made at the bedside on a regular basis. Neurologic monitoring, very, very critical because, as I mentioned, babies are at risk. Their ability to maintain their perfusion in the brain is compromised. Autoregulation systems are disrupted because of the disease process, as well as they are immature even in a full-term baby. So there is a risk of complications. So monitoring is very, very critical. Daily management and reviewing what is the game plan for the day is very, very important as well, because plans can change, plans may need to be adjusted, and the goal being to see what can be done to get the baby off ECMO safely and sooner than later. And then sometimes adjunct therapies are needed to facilitate that process. So for the cannulation, when a baby comes in and you're thinking, okay, there's cardiorespiratory failure, the oxygen index is 40 or 30, it's not getting better, the lungs are being damaged with the conventional medical therapy, we're on 100% oxygen, we need to go on ECMO. But at that time, it's also very important to ensure that there are no other major contraindications. As I mentioned, some of them are absolute, most of them are relative. Obviously, if there's a big bleed in the head, putting a baby like that on ECMO is going to just make things worse. So you have to look at all those things and discuss with the family, discuss with the cannulating surgeon. Echo is important to make sure there's no serious congenital heart disease. Patient may be cyanotic because of cyanotic heart disease versus severe pulmonary hypertension. Having said that, there are situations where even in the setting of congenital heart disease, patients may be in extremis and severely hypoxemic, and ECMO is their lifeline, and that should be initiated, and then echo can be done, cardiac cath can be done after the patient goes on ECMO support. So it's not a requirement to be done before ECMO is initiated in a baby, but it is something that is preferable. Head ultrasound, obviously, to rule out and make sure there's no severe intracranial hemorrhage. Discuss the urgency, timing, and talking to our cannulating surgeons is very important. Earlier conversation is always helpful. So when the time comes to make a decision to go on ECMO, everybody knows what's going on. Discussing cannula size, very important in babies. As I mentioned, the neck vessels are small. It's all about venous drainage from the patient, from the baby into the circuit, and we want to make sure that that goes smoothly. We all prefer a venous cannula for the veno-arterial support of at least 10 French. If you have a smaller venous cannula, then you run into problems with blood flow, and it can lead to turbulence and damage to the red cells and increase the risk of hemolysis. It is difficult to maintain the goal flows. What are the goal flows in a baby for veno-arterial? 100 to 120 cc's per kilogram per minute. So if you can imagine a 3-kilogram baby, that's about 350 to 400 cc's per minute. But in order to maintain that without causing damage to the red cells, you need a good venous size cannula, at least a 10 French. 8 French arterial cannula. We always review the heparin dosing with the surgeons. Heparin is needed at the time when the cannula is placed in. The typical dosing is 30 to 50 units per kilogram. In a baby who's oozing, who's coagulopathic, who has got some bleeding issues going on, we will err towards on the lower end of the dosing to avoid that issue. Let me see, here we go. Ensuring correct cannula position is very important. So we do a chest x-ray, we get an echocardiogram that is recommended because that's the only way we can ensure that the venous cannula is in the right atrium and the arterial cannula is just outside the aortic arch. Sometimes it can happen. A patient is placed on ECMO. Again, because of the small size of the heart and the small size of the patient, you can have some malpositioning of the cannula, and that can lead to poor flows, inability to generate venous drainage from the patient, high negative pressures. which means that there is a difficulty in extracting the blood from the patient and increasing the risk of hemolysis. So when that happens, evaluating with repeat echoes is always a good idea, and then adjusting the cannula position after discussing with the surgical team. As I mentioned, venous drainage is the key thing for all ECMO patients, especially in babies. And if it is poor, then it will cause difficulty in maintaining flows. Poor venous return can cause the circuit to even shut down in the centrifugal circuit that we use, the centrifugal pump that we use. The causes can be due to the patient or can be due to the circuit. It can happen at any time. It can happen at the time of cannulation because the cannula may not be in the right spot, or it's a small cannula, or it can be during the ECMO run due to hypovolemia, which is a very common reason for poor venous return due to the patient, which can be somebody gave a dose of Lasix to the baby, or a big diuresis, and now preload has gone down and the flows are coming down. Acute blood loss, unfortunately, if that happens in a baby, then that can lead to similar issues. Pneumothorax, effusions, hemothorax, that can also impede venous return from the patient, and it will be due to the Tamponade effect. Obviously keeping an eye on the pump is very important as well, because you want to make sure that you are providing adequate support on the ECMO system to generate the flows. But if the level of support on the pump is adequate, your RPMs are appropriate without increasing the risk of hemolysis, and the flows are unable to be generated, then there is a problem. Is it a baby, or is it something going on with the cannula? So your best friend in this situation, when that happens at the bedside, is give volume. When you give volume, you'll tank up the preload. It will give you 10, 20, 30 minutes to figure things out. So give volume. It will correct the problem for the short period of time, increase the support is needed, and then evaluate for the cause of what is going on. Optimizing hemodynamics is important. Hypertension is not very uncommon when babies go on ECMO. It could be pain related. It could be because the baby was on vasopressor support or is on hydrocortisone, which is very not very uncommon pre-ECMO. So discontinuing those supports are very, very important. Hydrocortisone is sometimes continued because it can help with a lot of things inside the body, with decreasing capillary leak, optimizing cardiovascular function, as well as improving urine output. But sometimes it has to be held as well for the same reasons, because hypertension increases the risk of thrombosis and stroke and bleeding inside the baby's brain. Optimizing sedation is important. Evaluating for seizures. If the baby is sedated, say muscle relaxed, and is hypertensive, it could be a neuro issue for that. And getting an EEG is always a good idea, especially if there's a pre-ECMO concern of some neuro injury. Hypotension can lead to poor oxygen delivery, end organ damage can worsen even on ECMO. Flow issues can be a problem. So again, give volume. Sometimes it may be required to give some vasopressors to optimize and stabilize things, and then check cannula position. Hemodynamics can be assessed by urine output, perfusion, cap refill, acid-base status. If all those things are getting better, then you are doing a good job on ECMO. That means that the oxygen delivery and perfusion is appropriate. Mixed venous saturation is monitored on veno-arterial ECMO mode, and goal is 70% and above, and the mean arterial pressure for a term baby for a goal of 40 to 50. Sorry. Evaluating pump settings, optimizing ECMO flows, monitoring pump pressures, avoiding high RPMs. And there's, the blood pressure is on the lower side, the flows are low, the tendency is to turn the RPMs, but that can be detrimental. It can lead to hemolysis. So always give volume, figure the reasons out, and plan for a gentle ECMO support, which is flows of 100 to 120 cc's per kilogram per minute. And that will avoid unnecessary increased requirement of RPMs. Goal for venous pressure, which is what we measure on centrifugal pump, is anything less than -30. If you are more than -30, then it increases the risk of hemolysis. If it's staying high negative venous pressure, then there's a problem. It could be hypovolemia, as we discussed, or it could be something wrong with the cannula position. Avoid high RPMs. Goal is 2800 to 3200. No need to increase flows and RPMs if there is acceptable hemodynamics and adequate oxygen delivery. Ventilator-wise, we discontinue nitric oxide for most of the patients. Once in a while, if there is difficulty coming off ECMO, we may restart nitric to treat an intractable or refractory pulmonary hypertension to expedite coming off ECMO. So it can be used as an adjunct therapy. Rest bend settings are initiated, and these are the settings that we use. Peak pressures in the low 20s, PEEP of 8 to 10 and a rate of in the mid-20s. The goal is to keep the lungs open as much as possible without causing injury or further damage to the lungs. On occasion, for refractory air leaks, we have even used CPAP or even no pressures at all on ECMO, like the endotracheal tube is just open to air. A gentle vibration, changing position, suction will help in keeping the lungs open. The main issue with ECMO for all patients, especially for babies, which is a big problem, is exposure of the blood to the circuit, which activates the coagulation pathways, platelets, inflammatory pathways, turbulence of the flow, especially with small cannulas, and shear stress in the tubing and the pumping can lead to damage of the cells and the hematologic cells and activate platelets. Fibrinogen and clotting factors, they bind to the circuit. There's tissue factor exposure. Tissue factor leads to thrombin generation. Thrombin generation will lead to presence of clots. So going on ECMO produces a hypercoagulable state that requires anticoagulation for all patients, especially in babies as well. The problem is that anticoagulation is a challenge in neonatal ECMO. It's an imperfect and complex situation because of developmental differences in babies as compared to adults. The goal is to avoid clots, reduce bleeding, and maintain optimal circuit flows. We use heparin, but there's no one test that accurately assess the effect of the heparin. PTTs, ACTs, they're unreliable, they're inaccurate, show poor correlation, and the tests are affected by many factors, including temperature, infection, hemolysis, low platelet counts, etc. Our center uses anti-10A because it gives you direct correlation of the heparin activity. Heparin indirectly promotes the activity of the natural anticoagulant antithrombins. We follow antithrombin levels as well, just to make sure that we are in the we are not too depleted in that. If we are having normal anticoagulation goals, then we don't need to replace antithrombin 3. But in situations where the heparin requirement is going up and the anti-10A levels are subtherapeutic, that is something that we monitor and treat. The anti-10A goal that you see here, 0.3 to 0.7 is what's recommended by ELSO. In our center, we use 0.2 to 0.5 as a goal, and we use a lower goal, 0.1 to 0.3 for patients at high risk for bleeding, especially patients with HIE who are being cooled. Collecting underlying coagulopathy and low platelets is very, very important. The next slide shows our guidelines. That's the table that we follow, and we adjust the heparin based on the actual level that is coming up in the baby. Transfusion goals, and we try to keep the INR less than 1.5, platelets 80 to 100. First 24 hours, our goal is 100. And after 24 hours, we keep it around 80. Fibrinogen goal is more than 150, and a hematocrit in the low 30s. High platelet count and high fibrinogen level goals may be required for patients with bleeding risk. If there is a bleeding issue going on, especially at the cannula site or surgical site, say in a diaphragmatic hernia who was repaired on ECMO, hemostatic agents are used, transfusions are used to correct and aim for higher platelets and clotting factors. Amicar can be used as an antifibrinolytic to help reduce bleeding complications. And these are all bedside decisions in consultation with our surgical teams. Hemolysis, as I mentioned, increases the risk of thrombosis and underestimates anti-10A. Diuretics and hemofiltration increase heparin loss. So something to keep in mind that you initiate that and urine output is going up and your anti-10A level is coming down. It could be that you're losing a lot of heparin. So keeping that in mind and adjusting the heparin infusion is always a good idea. The neurologic risk factors are many in a baby. They can be patient factors, hypoxemia, acidosis, pre-ECMO, hypotension, shock, impairment of autoregulation in the brain. And then while going on ECMO, the cannulation, putting the cannulas into the jugular and the carotid increases the risk. VV ECMO is protective. Studies have shown that it does improve neuro outcomes, but most of the babies do require veno-arterial because of their cardiac dysfunction along with the respiratory issues as well. On top of it, you're on anticoagulation, and that can lead to problems as well. We follow neurologic guidelines to monitor head ultrasound daily for the first 7 days. The greatest risk of bleeding in the brain in a baby who is on ECMO is in the first few days. head CT portable or in the radiology department as needed. If seizures are suspected, get an EEG, treat aggressively. And then if there is unfortunately presence of severe bleed or severe neuro injury, then ECMO may be discontinued. MRI is obtained in the brain and with neurodevelopmental assessment post-ECMO. Cooling can be done safely for hypoxic ischemic encephalopathy on ECMO, but we follow lower anti-10A goals of 0.1 to 0.3. This NICHD study in 2018 looked at, hey, how come we cannot just cool every baby on ECMO? And they showed that it does increase the risk of bleeding in neonates. So that's why it's not a standard of care for neonatal ECMO, and we only use hypothermia for HIE. The daily management goals, obviously keeping the baby comfortable, optimizing sedation. We do want the babies to be awake and moving around. Muscle relaxation is only used if you're having a lot of flow issues or cannula issues, restricting fluids, avoiding fluid overload. We follow daily chest x-rays, baby gases, pump gases to make sure that everything is optimized. Sweep gas, which is your oxygen that is going through the circuit, that is adjusted to maintain normal PCO2 level, like in the 40s and the low 50s in babies. Optimize flows and tissue oxygenation for the goal mixed venous saturation, anything above 70. As long as you're not developing metabolic acidosis, urine output is good, creatinine is not rising, blood pressures are maintained, no need to chase all that. And as long as your mixed venous saturation is more than 70. And that's the gentle approach of ECMO in the baby, and it will ensure good outcomes. And then keep assessing the readiness to come off ECMO. The adjunct therapies that we consider, as I mentioned, steroids, inhaled nitric oxide steroids may be considered in severe lung disease. The patient is failing clamp trials and cannot come off. Surfactant can be given, bronch can be done, plasma exchange in the setting of sepsis. Sepsis carries a very high mortality in neonates, almost only 40 to 50% survival. So early initiation may improve outcomes, treating coagulopathy, and then it will also help remove plasma-free hemoglobin from the system. CRT, hemofiltration for fluid overload situation, to try to avoid that situation, because studies have shown fluid overload increases mortality in babies as well. So early diuresis or early renal replacement therapy or hemofiltration can help improve outcomes. And then we do surgeries in some patients with severe CDH on ECMO as well. Weaning, when the time comes, lungs are open, hemodynamics are stable, patient is showing good gas exchange. You start cutting down on the flows. Our goal is to go towards 100 mLs per minute, which is very low flows, increase the respiratory support, and ensure the patient is awake and breathing and has good lung compliance. And we are not back to the same settings that we were pre-ECMO, because if you are, then the patient is not ready to come off ECMO. So if you're on low to mid-level settings, as you can see from this table, then it's time to consider an ECMO clamp trial, where we clamp, we go to the low flows, and then we assess clinically, is the baby desaturating, is there any shunting developing, how are the hemodynamics, and get an echo. Echo is very important during the clamp trial, because it really tells you what's going on with the degree of pulmonary hypertension and cardiac function. And if the echo is pristine and the baby tolerated the clamp trial, which is usually done for 15-20 minutes, we get 2-3 blood gases, we work with the perfusion team for that duration. And if all that is good, then that's your window of opportunity to get the baby off ECMO support. You don't want to wait another day and have a risk of complication developing in the baby. So baby, the neonate must show adequate gas exchange and oxygenation and consistent hemodynamic stability on non-toxic cardiorespiratory support assessed clinically and on echocardiogram. But if that doesn't happen, then the baby is not ready. If there is shunting going on, echo shows pulmonary hypertension, decreased function. It does happen. As soon as you clamp, the blood pressure starts going down, the SAT start going down, and you know that the baby is not ready. It could happen within seconds, or it could happen like 5 minutes later, or your blood gases show that there's developing acidosis. So tomorrow is another day, and it does happen that things may get better in the next 24 hours. Unfortunately, in some cases, when there is evidence of multi-organ damage or severe neurologic injury, a new bleeding complication, ECMO sometimes has to be discontinued to redirect care or to withdraw care. And ongoing counseling is very, very important with families and parents throughout the conduct of the ECMO course. So to summarize, ECMO has saved lives of newborns with the most severe forms of neonatal cardiorespiratory failure. ECMO use has decreased, and it's now being used for more sicker patients that carry a high risk of morbidities and risk of mortality as well. As you saw, the survival is about 70%. Efforts to eliminate complications are important for favorable outcomes. A strategy of gentle ECMO management can reduce complications and perhaps improve patient outcomes. And that's where all the work is going on every year all over the country and all over the world. So if you have any questions, thank you so much for the opportunity. Went over a little bit, sorry.
Okay, we had one question that came in the chat, and it says, any thoughts about low flow trials in Neo ECMO?
I prefer not to do that. We do go down on the flows, as I mentioned. So when you're weaning the ECMO, it can be on the day when you're doing the clamp trial, patient is on 100 mLs per kilogram per minute, and you say, well, lungs are open, everything looks good. Let's just turn the flows down towards clamp trial. Or you may turn the flows down slowly by 10 to 20 cc's per kilogram per minute every day, moving towards the very low flows or idle flows of 100 mLs per minute. Leaving at low flows, and it's been said by the experts, increases the risk of thrombosis and clot formation. So in a baby, it is very, very important who has very small cannula. So I prefer not to do that. The baby's ready, he's ready, lungs have to be opened up. And once that has happened and patient is not fluid overloaded, that's your opportunity to do the clamp trial.
Okay, one more question. Thank you for that. What do you use as an alternative when high suspicion of HIT or non-responsive, or when a patient is non-responsive to heparin?
Yeah, it's a great question.
Anticoagulation goals.
Yeah, it's a great question. Heparin resistance, or when we cannot use heparin. HIT is something that I've not really encountered in my experience of 15 plus years of taking care of ECMO patients, which is heparin-induced thrombocytopenia. But heparin resistance can occur for many reasons. We recently had a patient who had a hyperinflammatory response, who was on a heparin of almost 50, 60 units within 24 hours. And we, in that situation, would go to direct thrombin inhibitors. And then the one that we use in our center, we don't use it in our NICU as yet because there are no clear-cut guidelines in babies, is Bival. And bivalirudine is a direct thrombin inhibitor. Again, the issues with that is that there's no standardized guideline for use in babies. Some centers are using it. And nationally, if you look at the children's hospitals, almost 30% of the centers are using Bival. Most of the centers are still using heparin, but that would be our go-to treatment. But for that to be accurately reflected in terms of your management, you need a test called dilute thrombin time. And that is something that is very, very important at centers to be able to do, because typically with Bival direct thrombin inhibitors, we use PTT, and PTT has shown poor correlation and not very good correlation, even not only with heparin, but also with Bival. So, but that's something that may happen in our center as well moving forward as guidelines are more established for the use of direct thrombin inhibitors. All right, thank you very much.
Okay, our next guest will be joining us virtually from the PICU is Dr. Nama Kim Campbell, and she'll be joining us in a discussion about patient management in the PICU.
All right, hello. Guess I'm waiting for slides.
Doctor, do you need assistance sharing your slides?
Am I supposed to upload my own slides?
Yes, that is ideal. We do have them here as a backup if necessary, but it'll work better if you share them.
Sure, I can open it. All right, let me see if I can share this.
We see them.
Okay, all right. So I'm on a computer in the unit, so it tends to be a little slow. So if the slides don't advance, please let me know. Okay, well, thanks very much for inviting me to give this talk. I am a pediatric ICU intensivist, and I will be discussing respiratory failure in the PICU and ECLS ECMO support for that problem. So ECLS, ECMO for respiratory failure, is indicated when you have cardiac and or respiratory support deficiencies where gas exchange is not life-sustaining. Also, when you have risk of ventilator-induced lung injury because of the pressures that you're requiring to provide this kind of support. Conventional therapies that aren't working, and this includes not only ventilator strategies, but adjunctive therapy strategies. If you have a high predicted mortality based on whatever underlying condition is occurring. And then thing to remember about ECMO in general is that it's not really a cure. It's just giving you extra time for your lungs and or cardiopulmonary system to recover. So the most recent Pediatric Acute Lung Injury Consensus Conference, so the PALIC-2 conference in 2023, suggests that patients with a potentially reversible cause of severe pediatric ARDS should be evaluated for ECMO when lung protective strategies result in inadequate gas exchange. Let me get rid of this. Sorry. Trying to get rid of that window. Okay. And then they also suggest that serial evaluation as compared to a single time point of assessment should be used to guide decisions about ECMO eligibility. So it's really kind of just the trend in what's happening with your patient and how their lung disease is progressing. So what are the kinds of things that we look at to determine whether or not you have respiratory failure? I'm sure Burhan talked about this already a little bit, but just to review and to give you some equations. The one that has traditionally been used quite a bit is oxygenation index. I remember this equation as basically what you give, which is your FiO2, your mean airway pressure, divided by what you get, which is your PaO2. An OI greater than 40 is associated with higher mortality, and this will increase over time. That cutoff of 40 is what is in the literature of where people generally as a consensus think it's about time to go on ECMO. But in reality, people put on children that are much lower than that, with OIs much lower than 40 onto ECMO, depending on what the overall situation is. There's also the PF ratio, so PaO2 divided by FiO2. The official definition of acute lung injury is with a PF ratio less than 300. And acute respiratory distress syndrome is a PF ratio less than 200. The adults will talk about sometimes a Murray score, which I show there, basically taking into account the PF ratio, the chest X-ray, the PEEP, and the compliance, with the understanding the higher numbers score higher, more indicated to think about something like ECMO. So if you look at the ELSA guidance, generally, you should be really thinking about ECMO. And some people could argue that it's a little bit too late if you already reached these parameters to be thinking about ECMO. But if your OI is greater than 40, your PF ratio is persistently less than 60 to 80. If you're really not having any response to conventional mechanical ventilation and other rescue therapies or adjunct therapies, or if what you're needing to achieve adequate gas exchange is very elevated, so high mean airway pressures on a conventional vent or on your high frequency oscillator, or if you have a evidence of iatrogenic barotrauma. Other things that people do look at, maybe not quite as frequently as the other two, which are much easier to calculate, is your AA gradient. Basically, it does give you an insight into how bad your diffusion or your VQ mismatches is. With higher gradients, more predictive of death. And then intrapulmonary shunts. So basically, a shunt is in a respiratory failure in some place like pediatric ICU where there are a lot of infections. Generally, it's an area that may be perfused but not ventilated, which you will see in consolidated alveoli. And so this calculation just seems very complicated, but it's actually quite easy. And so basically what you're just looking at is the amount of oxygen that is actually added to your mixed venous blood divided by the amount of oxygen that should be added to your mixed venous blood. So you can do these calculations based on your oxygen content equations and that'll give you a shunt fraction. If you have a shunt fraction greater than 30 to 50% requiring high FiO2, that would be another indication. The other category, instead of oxygenation failure, is ventilation failure. So if you have a very poor compliance, or if you're very hypercarbic and so I'm thinking of patients with things like status asthmaticus or in adult patients, really bad COPD. That's why you would have hypercarbia, and so which results in a sustained respiratory acidosis despite ventilator and patient management. So who needs ECMO? And people will say this in every talk you ever hear about ECMO, that it needs to be a bridge to something. If you can't see what's on the other side of the bridge, you should maybe be considering not placing your patient on ECMO. But the bridge, the other side, is just very simple. It either has to be something reversible that you know has potential to recover, or it doesn't, but you also know that your patient is a transplant candidate. So it's kind of very simple parameters to think about whether or not you should be considering someone for ECMO. And that being said, there is no actual specific criteria, and you'll hear this later on this afternoon when people discuss cannulations and ECMO candidacy, and you'll hear people discuss this a little bit more in depth later this afternoon. All right, contraindications for all ECLS. Everyone always wants a black and white list of who is a good candidate, who isn't a good candidate. In reality, as time goes on, the contraindications have become less absolute and more relative. So people are just balancing the risks versus the potential benefits of using valuable resources. And there are some like hard stops, you know, if you have a lethal chromosomal abnormality, or you have really poor CNS status, end-stage malignancy, like those are the obvious ones. If the family and the care team think that whatever impairment is going to result from the underlying condition or ECMO even is unacceptable despite survival, that would be another reason. The age and size of patients, some people consider, although we don't really use that as a criteria of any sort. And then the idea of futility. So if your patient is too sick or too moribund, have been on conventional therapy too long and has a fatal diagnosis, like those are people that you might not want to consider for ECMO. All right, so when we talk about ECMO in general, I'm going to throw some physiology at you. The most important thing you must understand is oxygen content, and this is probably the most important equation that you should know. And so I usually tell our fellows, if you know one equation, it should be this one. So your oxygen content of your blood is your hemoglobin times your percent saturation times this 1.34 constant plus PaO2 times 0.003. So if you look at that equation, you can tell that the biggest contributors to oxygen content are hemoglobin and percent sat. So PaO2, you know, has a role, but it's very small relative to the other two parameters that you should be looking at. And so basically what this means is that for a given PaO2, if you have a higher hemoglobin, you will have a higher oxygen content of your blood. And so this is one of the reasons why in a lot of places or a lot of units, you know, we actually aim higher for our hemoglobin. So we don't settle for the 7, which a lot of pediatric ICUs uses or cut up for transfusion. In an ECMO patient, we generally tend to push it a little bit higher just because we would like more oxygen content and thus oxygen delivery. So the simple way to think about ECMO in general is basically the oxygen delivery you're providing and whether or not that can account for the oxygen consumption that your body needs. So oxygen delivery is this oxygen content of arterial blood based on that equation I just showed you times your blood flow. So your oxygen content times your cardiac output, that is your DO2. Your oxygen consumption is how much oxygen your body needs in whatever state it is. So in a normal healthy person, this will increase with exercise, with catecholamine, and then in sick patients with catecholamine use or sepsis or any state of high metabolic demand. And so the normal oxygen consumption for an adult at rest is about 120 milliliters per minute per meter squared. It becomes higher for a child and even higher for an infant. So the children tend to need more than an adult would. So the ratio of VO2 to VO2 in a normal healthy person at rest is about 5:1. So at rest, 20% of the available oxygen that is provided in your circulation is used for metabolism, with 80% left in your venous blood. And this is what's you can notice in your SVO2. So you ask why people are looking at their SVO2, it's because you're kind of looking at this ratio, right? So if you have a decrease in your DO2 because of whatever condition, so hypoxemia, anemia, low cardiac output, Or if you have an increase in your VO2 because you're in shock or you're septic, have choline use, this ratio will decrease. So when the ratio drops from 5:1 to 4:1, 3:1, 2:1, then goes below 2:1, generally this is where the oxygen supply is inadequate to maintain aerobic metabolism, and this is where you end up with acidosis and organ failure. So you're just trying to prevent that from happening. And so that's basically the idea of ECMO. So when you can't maintain this adequate DO2, VO2, that's when you use ECMO. Or when interventions are needed to maintain this adequate ratio that are damaging or have high risks, then that's also when you might want to consider ECMO. So these are things like high airway pressures or your high FiO2s or high doses of vasoactive drugs. So there are two general forms, and there's a lot of hybrids nowadays, but the two general forms are VA ECMO and VV ECMO. And so the important thing to remember in respiratory ECMO is that VA ECMO provides both respiratory gas exchange and circulatory support. So blood taken from the venous circulation returned to the arterial, and that it also increases afterload on the left heart because of this configuration. So this can lead to LV failure, which can lead to pulmonary venous hypertension and pulmonary hemorrhage. VV ECMO can provide efficient respiratory gas exchange, which is probably the preferred method in patients that are large enough that can have cannulas that support VV, because it is isolated onto the venous side. So blood is withdrawn and returned to the venous circulation. It offers no direct hemodynamic support, so it does require a functioning native heart. But the benefits are that it avoids the use of a major artery and potential systemic embolism. So the Pellet Conference, they also suggest the use of VV ECMO over VA ECMO in patients with pediatric ARDS who have adequate cardiac function. So in terms of patient management for patients that go on ECMO, your goal is simply, like we discussed, adequate tissue oxygenation and cardiorespiratory support. So the things that you look at generally when you have patients admitted to your ICU, that you're looking for adequate perfusion, adequate oxygen delivery, still hold true. So your lactates, your pHs, central venous sats, your arterial oxygen saturation. And the clinical examination is also similar, so the same. Vital signs, your urine output, how well are you perfused, you have a normal neurologic exam. So in VA ECMO and VV ECMO, there's just a few differences. So in VA ECMO, you do want your blood to enter the native pulmonary circulation. And in the pediatric ICU respiratory failure world, this is actually more important because our ECMO runs tend to be longer. So they're not generally a few days. They tend to be much longer, sometimes weeks. We've had children on for several months as well. So you want to make sure that if you're having a run that you are anticipating to go much longer, that you are able to maintain an arterial pulse pressure of at least 5 to 10 milligrams per mercury. And this is because it allows blood to enter the native pulmonary circulation. For VV ECMO, saturation can be a little bit lower because you're going to have some mixing of the blood, and even saturations below 80% may be tolerated. And so I have a couple slides at the end of this talk to kind of explain or demonstrate why this is acceptable. All right, so in terms of blood flow, for cardiac support and VA ECMO, we generally aim for a blood flow in pediatrics starting about 80 cc's per kilo per minute and going up as needed. Goal SpO2s of normal and being flow maintained at about 80% of your venous return. And again, because you want to avoid stagnant flow and clotting in the pulmonary vessels and chambers of the heart. For respiratory failure, you could do either VA or VV. Some centers are more used to using VV and will do that primarily. Others are still transitioning, and for some, VA is still the most common mode for respiratory failure. And in VV ECMO, your O2 delivery and CO2 removal have to be at least equal to normal metabolism. So in pediatrics, you want an oxygen delivery of about 4 to 5 cc's per kilo per minute. That translates to, in neonates, a blood flow of 120 cc's per kilo per minute, and that goes down as you get older. So in pediatrics, it might be closer to 100 or 80, in adults even lower, to 60 or 80. CO2 produced by metabolism A blood flow rate of about 10 to 25% of your cardiac output is actually adequate to decrease your CO2. It is highly efficient. The ECMO circuit is highly efficient to decrease hypercarbia. So that is something that we'll mention later as well. Again, throughout this whole talk, I will be showing this equation everywhere so that by time you've listened to this, hopefully you'll have remembered this equation. The sweep gas, most of the time the sweep gas is 100% oxygen started at a flow rate equal to the blood flow rate, and usually that's where we start. It controls the CO2 clearance, and that can be titrated at the bedside. We touched a little bit on why we need pulse contour in respiratory ECMO. It's because a non-functional heart can be a problem, especially if it's for a long duration. So when your venous blood drains into the circuit with no arterial pulse contour, your left heart can actually gradually fill with blood from both the bronchial and the Epiphysean venous flow. And so that results in an increase in pressure on the left side, the LV/LA, and then as well as the pulmonary circulation. So this can lead to pulmonary edema and over-distended LV. So this is why you'll sometimes see people thinking about a atrial septostomy or placing an LA drainage cannula or a pulmonary artery drainage cannula because of this problem. The blood, if it's stagnant in the cardiac chambers and pulmonary circulation, will clot eventually, even if you do use higher levels of anticoagulation. If your pulmonary circulation becomes too stagnant, then this is one indication to go from ECMO to a VAD. All right, so cardiac support and respiratory ECMO. So, historically, a lot of our respiratory kids would end up on VA ECMO, and it's mostly because they needed a good amount of cardiac support. So they would be on various vasopressors and require fluid resuscitation. And so the thought was, well, they've got some kind of cardiac involvement of their sepsis. But actually, in just pure respiratory failure, a lot of times the cardiac support that's required is really related to the hypoxemia and acidosis that affects the myocardium, as well as the high airway pressures that are used in severe respiratory failure. And so when you end up on ECMO and you decrease that the ventilatory pressures and provide more support to the myocardium in terms of oxygen delivery, all of that tends to go away. So the patients that needed inotropic drugs prior to ECMO, they will have on ECMO have a reduced mean airway pressure, improved venous filling, improved RV afterload, improved oxygen delivery, just by decreasing the high airway pressures and providing oxygenated blood. And so you will find often that they do not need the inotropic drugs once they are on, if you place them on ECMO. Hypertension is actually very common in patients with respiratory failure. In VA ECMO, these patients that used to need inotropic drugs all of a sudden need nicardipine because the reduced cardiac filling pressures from the diversion of the venous blood can actually cause a baroreceptor response, and you get reflexive tachycardia or increased cardiac output. The non-pulsatile flow you can sometimes get on VA ECMO will increase the renin-angiotensin from the kidneys. And this is where, we will reach for esmolol, or they'll use nicardipine trying to decrease the afterload on VA ECMO. In VV ECMO, if you have hypertension, you can treat that almost as if the patient was still on a ventilator. So you do things that you normally would look at, such as volume overload or increased systemic vascular resistance, secondary to agitation or pain, or things of that nature. For treatment of hypotension, so on VA ECMO, you can increase your flow, you can give fluids, some inotropic support. VV ECMO, the hypotension is going to be dependent on your native cardiac function because VV ECMO does not provide any cardiac support. And so it is based on hemodynamics cardiac performance. So on VV ECMO, if you still have poor myocardial performance, that would be an indication to switch to VA. So I always show this slide because it's a little counterintuitive to people that are learning ECMO, but in VV ECMO, you actually get higher saturation in the coronary arteries than you would in VA. In VA ECMO, your coronaries are perfused with the lower saturated blood that's ejected from the LV. So, just coming off from the aorta, the blood that is being ejected from the heart is in respiratory failure, it's going to be less saturated. And so your coronaries will actually have lower saturated blood. Whereas in VV ECMO, your oxygenated blood is infused directly back into the RA or the IVC. And so as it circulates through the pulmonary system and back to the left side, is actually more oxygenated. So your best coronary oxygenation is in the femoral atrial cannulation configuration. All right, so ventilator management. And this is also kind of a gray box as well, because there are some suggestions, and these are just suggestions. And for some patients, it'll fit. Some other patients, you might need to adjust them depending on what their underlying congenital problems are. So ECMO doesn't cure the underlying pulmonary disease. It just provides gas exchange until the pulmonary recovery occurs. And the goal is to minimize your barotrauma, oxygen toxicity, and promote lung healing. So we discussed that high ventilator pressures, oxygen concentrations can damage your lungs. So some people use what they call rest settings to something that is considered non-traumatic. So a low rate, a long inspiratory time, plateau pressure is less than 25, FiO2 is less than 0.5, PEEPs, somewhere around 10 to 15, maintain some lung expansion, but not use high pressures. Especially in VV ECMO, if you use really high PEEP, you'll inhibit venous return, and that will have a negative effect on your hemodynamics. In some situations, you could, if the patient is cooperative enough, actually extubate them, allow spontaneous breathing with the patient awake. We've done that a few times over the years. Or in the event of a major pulmonary air leak or interstitial emphysema, sometimes people will actually shut the ventilator off for a period of time until the leak seals. This has become less popular in general, just because sometimes with significant atelectasis and lung collapse, the recruitment that's necessary to reopen some of those alveoli can be really difficult. So in general, like I personally, with my management, don't usually let lungs collapse completely. There is an acute inflammatory stage after cannulation that often happens after ECMO. And during this inflammatory stage, it's probably best to wait a period of time before you start lung recruitment maneuvers or trying to do some more pulmonary therapies. Other things that help on ECMO, you can use your ECMO to take advantage of being able to do things like surfactant or bronchoscopies or lavages, things that they did not have the reserve for prior to ECMO. Okay, so if you have hypoxia on ECMO, how do you manage that? And so one of the best ways, or just a simple way to think about it, is just you want to increase your oxygen delivery. How do you increase your oxygen delivery? So you increase oxygen delivery by increasing the oxygen content of your blood and also increasing the cardiac output, right, or the delivery of the blood. So you can give a red blood cell transfusion that increases your oxygen content. Or, conversely, you can decrease your VO2. So if your DO2 is kind of fixed, then decrease your VO2. So you reduce your O2 consumption and metabolic demand. So this is where a good deal of sedation, maybe some paralytic, if you keep their temperatures low, cool them a little, that might get you where you need. For VA ECMO, this also involves increasing your flow. You can give volume, optimize your cannula placement. If you're limited by your venous outflow in terms of how much flow you can provide, this is where you might want to think about additional venous drainage cannulas. In VV ECMO, increasing your flow has a limit because the higher you go, at some point, you're going to increase your risk of recirculation. So you may have to accept lower O2 saturations. And you already have some mixing. That's the whole idea of VV. So you're never going to get perfect 100% sats. And if that is happening, then you should really be considering whether or not you need to be on ECMO and how much your lungs are actually participating. So your infused blood mixes with systemic venous return 3 to 1 in typical blood flows. You want to monitor for adequate perfusion when your sat's a little bit lower. So the things you monitor anytime you have perfusion issues or concerns about oxygen delivery. So lactates, you can use cerebral NIRS, look at your urine output, look at your perfusion. If you are stuck on VV ECMO and you're on rest settings and you do need a little bit more oxygen delivery, you can ask your lungs to participate more. So you typically want to maintain non-toxic ventilator support, but if you have some room, you could try to recruit a few more alveoli to participate and to help with your oxygen diffusion. if inadequate oxygenation leads to hemodynamic failure, so you're not winning on VV, that is also an indication to convert to VA. So I have a few points about cannulation in terms of things to look out for. So your venous drainage needs to be adequate for maximum ECMO blood flow. So the obvious things like right size and position, you might need to do some volume replacement. If your venous drainage is still inadequate, you can add additional venous cannulas. And then you always want to make sure that the cannulas are in the right position. You could do this with chest x-ray, sometimes POCUS at the bedside, most often echocardiography or fluoroscopy to basically make sure that the cannulas are in the right position. And then if you're using something like a bicable, that the outflow is directed at the right place. If you're doing cervical arterial cannulas, you need to make sure they're not directed at the aortic valve because you don't want it to either damage the valve or interfere with the emptying. Femoral VA ECMO, one of the things that you really need to look out for is this two circulation syndrome, also called upper body hypoxia, north-south harlequin. And this is where this is on VA ECMO, this is where your native cardiac ejection will actually preferentially support the upper body. And that's because in FEM, where your venous cannula and your arterial cannulas are in the femoral vein and artery, it results from the inadequate mixing of blood in the aorta when you have an ejecting heart. So here on the right, you can see actually in a contrast study where the ECMO blood is bright and the blood ejecting from the heart is dark. And you can actually see the demarcation where this mixing is happening in this particular patient. So why does this matter? So if you have an aortic valve that's completely closed and have no mixing of arterial blood, then you can see how if you have a femoral arterial cannula, you'll have oxygenated blood go all the way up the arch. As you have a heart beginning to recover or a heart that's actually functioning on VA ECMO and have LV ejection or more LV ejection, or if you have a lower ECMO flow, the location of the mixing point will change depending on the degree of your LV ejection. So this is where if you have really poorly functioning lungs and you're on VA ECMO and you're tachycardic or hyperdynamic because patients septic or whatever the condition is, like you might actually have a pretty significant upper body hypoxia. And this is concerning because if your brain is getting 60% saturated blood, then that's really not delivering the oxygen that it needs. So this is something to keep an eye out for and consider. So with this differential cyanosis, you really want to monitor for the adequate oxygen delivery. So you need at the very minimum an upper extremity pulse ox. A NIRS in this case might be useful. You always want to make sure you're able to assess your neurologic exam. If you continue to have a problem, this is where you can insert a cannula in the IG or the RA and have ECMO return incorporated via like a Y connector. So that would be a veno-arteriovenous configuration. So you're just delivering oxygenated blood back into the venous side so that you have less deoxygenated blood ejecting from the LV. All right, so recirculation is another situation that you can see pretty frequently on VV ECMO, and it's basically when the blood that's being drained is actually coming from the circuit. So the oxygenated blood that's being infused from the circuit just goes back into the venous drainage cannula. And so this just decreases the efficiency of your ECMO. If you start having falsely high SpO2s on the ECMO circuit, that could be due to recirculation. So basically this is showing how, the drainage cannula is actually just draining blood that's coming from the infusion cannula. So in clinically significant recirculation, basically if your pre-circuit sat becomes close to your post-circuit sat, all this equation is showing you is as they become closer and closer to each other, you end up closer and closer to 100% recirculation. And so if there's clinically significant recirculation, there's several strategies you could try to do. You can try increasing the distance between your cannulas. You can add an additional drainage cannula. You can try to decrease your blood flows and have less negative venous pressure. You can manipulate the reinfusion cannula, or the bicable dual lumen cannula if it's actually placed correctly can usually lead to less recirculation as well. One of our perfusionists actually sent me this video because this is a visual of the recirculation, and you can just see in terms of the color difference between the two cannulas that you don't even need any numbers. You can tell that there's a significant amount of recirculation going on there. Let me see them played again. So you can see how the drainage cannula is quite red. All right. All right, so just to run through a little bit of management things. So in terms of infection, there's actually no indication for prophylactic antibiotics, but you have to maintain a very high suspicion because your ECMO circuit actually controls body temperature, so they will not mount a fever. Trends in your CRP can be useful. You should have a low index of suspicion for an infection, and so cultures and appropriate treatment with antibiotics is really important. Acute kidney injury is very common in ECMO, so maintaining a strict fluid balance and knowing what your fluid balance is, avoiding overload or hypovolemia is important. If you need help with the diuresis, you can do pharmacologic with your loop diuretics or any other diuretic you typically use. You can also do renal replacement therapy, which we use pretty regularly here. We usually put our patients on CRT if they need fluid removal, and they also do have the inline hemofilters that you can just ultrafiltrate with. Nutrition. If you don't have enteral feeding for a long period of time, you can end up with hypoplasia of your intestinal villi. So this actually increases your risk for bacterial translocation and risk for TPN-associated cholestasis, which is one of the reasons why, if able, you'd really want to try to establish enteral feedings in your ECMO patients. It is shown to be safe and effective. At least trophic amounts should be used to maintain your gut integrity. So to maintain those villi, you don't need to be on full feeds. And it's also, if you're done carefully, you can easily place a post-pyloric, like nasoduodenal or nasojejunal tube if your gastric motility is impaired. There is a phenomenon with pharmacology where hemodilution or adherence to the ECMO circuit will decrease your circulating drug levels. You may see this with your sedation drugs or some of your antibiotics or some of your neurologic or AEDs, your anti-epileptics. So when able, you should follow therapeutic drug level monitoring. So if the drug that you're using has an ability to do this, it should be done when available. For sedation, in pediatrics, it's a little bit different than the adult side because we typically end up using more than they probably would, they usually do on the adult side, mostly because we need to maintain patient comfort and also maintain the safety of the ECMO circuit. So you do want to prevent, problems with venous drainage or inadequate blood flow, based on agitation, movement. Sometimes if a patient is coughing quite a bit, that can have issues as well. The traditional approach years ago was to keep kids heavily sedated, maybe even paralyzed. There is a recent move, especially in some of our older patients, to allow them to be more awake. And so we've had some awake ECMOs, especially in the teenage population. A lot of them can tolerate that pretty well. For neuro, so patients are at a high risk of both stroke and bleed. And so, typically you want to have a high index of suspicion for any changes in your neurologic status. That's why a clinical exam is very important. You're looking for asymmetry, you're looking for focal deficits. A number of institutions also use the Mears monitor, EEG, which we use quite a bit here in the Children's Hospital of Pittsburgh, just looking for asymmetries or changes or anything that looks like seizure or abnormal slowing that is very sudden onset. And obviously CT if there's a concern for bleeding or infarct. In terms of survivors and post-ICU care, all survivors should receive at some point a CT or MRI prior to discharge just to identify any abnormalities or flag them for early intervention programs to improve their neurodevelopmental outcomes. For weaning and decannulation, you're looking for signs of clinical improvement. So anything that suggests to you that the lungs are improving. So resolving edema, improving lung compliance or tidal volumes on your vent, like increasing breath sounds or end titles are showing actual registering values indicating gas exchange. Obvious improvements in your chest x-ray or your SpO2s. Any of these things, or PO2s, your SATs, kind of indicate that your lungs are starting to improve. So once your pulmonary function is improved, in terms of weaning and decannulation for VA and BV, they're just a little different. For VA, you would decrease your flows and monitor your SpO2s. And then when they get to a low enough flow, you can consider doing a clamp trial. And then decannulating if it's going too well. So you will have to clamp the circuit, periodically flash it to make sure it becomes not stagnant or clotting. And at the same time, put your patient on the vent settings you would like to decannulate them with. For VV ECMO, I often think about VV ECMO as almost a giant ventilator. And so it's been very useful when you have really severe lung disease or patients that you're not really sure could tolerate coming off. We had a teenager not that long ago that ended up with a lobectomy from very severe flu and bacterial pneumonia, necrotizing pneumonia. And so, it was very helpful to be on VV ECMO because we weaned her off her sweep gas, actually, and then just capped her or clamped her gas supply to the oxygenator and left her on that for several days just to make sure that her lungs could handle the gas exchange, especially when she was awake and moving around. And so VV ECMO for respiratory failure, I would say that's another reason why it's very helpful. Unique patient populations, there are several, but the one that I just put up here in this slide is for selective CO2 removal. So in pediatric world, that's usually something like status asthmaticus, refractory to conventional therapies. And it's useful to achieve long rest settings. And you don't really need much in terms of blood flow. So you can actually deal with hypercarbia pretty easily with pretty low blood flows on ECMO. And so because you're running at a low blood flow, if you have hypoxemia, you can actually just use your ECMO to improve your oxygenation rather than using a ventilator until things improve. Conversion from VV to VA and vice versa. So VV to VA conversions are indicated if you have inadequate support or increased pulmonary vascular resistance, pulmonary hypertension, or right heart failure. You obviously need some more cardiac support. But if your patient's improving, but you need to have ECMO for a long time and they do not have any cardiac deficiencies, it is always beneficial to convert to VV for a long ECMO run, just because the risk of complications on VV is much lower. And so these are just a few slides here at the end, just to, for those of you that like math, I just wanted to show you why it's actually okay for patients on VV to be satting sometimes very low, like even like low 80s. So oxygenation is a bigger problem for a membrane lung than CO2 removal. So blood flow is planned for VO2 at rest, not for CO2 removal, because you'll automatically get the CO2 removal because it is just more efficient for CO2 removal. So you're planning for VO2. When you mix the two blood flows in VV ECMO, you have mixing in the right atrium and the RV with the blood flow from the venous return through the circuit and also venous return through the native heart and lungs. So the PO2 and the percent SAT is determined by the ratio of the circuit flow to the total venous return. You typically in VV ECMO, we usually aim for 60 to 80% of the venous return to go through the circuit. So assuming, so these equations I'm showing you is just for theoretically, so you can see, that people have these numbers actually make sense. This is based on an ideal situation where you have no lung function and no recirculation. So this is like, an ideal situation for these calculations. And in this situation, your systemic arterial oxygen content is the average of the amount of oxygen in the two blood flows. So here I labeled it flow from the circuit and flow native, meaning the blood that's coming from the body. Your oxygen content times your flow rate. And so this is the overall equation for the two blood flows. And so based on the idea that total flow is the flow through the circuit plus flow through the native circulation. So if you look at this equation, you actually know everything in this equation except the flow coming from your native circulation. So doing some algebra and just rearranging things and solving for total flow, you can calculate your cardiac output, your total flow cardiac output, and then your native flow. And so this is important. I'm just showing you here so that you know that this is possible. I actually did this math myself, so it is true. The fundamental concept of VV ECMO is that you must always avoid hypoxia. And hypoxia refers to inadequate oxygen available. There's inadequate oxygen available to support your aerobic cellular functions, which is very different than hypoxemia, because hypoxemia just is talking about the inadequate oxygen saturation in the blood, but it doesn't always result in tissue hypoxia. So you do want to avoid hypoxemia, but it can still allow adequate oxygen delivery. So an 80% sat is hypoxemic, but it might not be hypoxic. Okay, so why is it okay to have lower sat? So here you have a picture. This patient has no lung function. There's no recirculation. I did all the math for you in terms of the numbers and your cardiac, your oxygen content. So your systemic oxygen content is 12.3, your native here is 9, and from the circuit, which is flowing at 4 liters per minute, is 14. Your VO2 here is 200 milliliters per minute. So this is based on your circuit flow. Based on this, the O2 delivery of a membrane lung. So your VO2 is 200 milliliters per minute, or sorry, the O2 supplied is 200 milliliters per minute, milliliters of O2 per minute. Your cardiac output, based on that calculation we did in the previous slide, is 6 liters. So your oxygen delivery in this particular patient is, if you do this math, all my little things are in the way so you can't see. It's actually well above 2 to 1, and so it's good. I can't move sorry, I put my pop-ups right over the math. But if you do the math and you do the calculation of the DO2, the VO2, so even though your SATs are 88% in this particular patient, your DO2-VO2 ratio is well over 2 to 1, so that is acceptable, and that's why in this particular type of patient, you can tolerate lower SATs. If you do this repeatedly in different scenarios, especially when your hemoglobin is a little bit higher or an anemia, you'll calculate that sometimes even being lower than 80%, it's a little bit more rare, but it's still acceptable. So how do you increase your systemic oxygen delivery? You can increase your hemoglobin concentration. We talked about that, to increase your DO2, increase your circuit flow, paralyze or cool your patient to decrease VO2, or give more sedation to decrease your VO2, add another membrane lung to increase the gas exchange surface. And this is obviously limited by your blood flow. During ECMO weaning, VV ECMO weaning, so this happens actually not infrequently, and so I just wanted to mention this at the end, that you can have this transient hypoxemia during weaning, and during this time you might want to increase FiO2. So I don't know if anyone's noticed this, but during weaning, or when you've disconnected your sweep or clamped your oxygenator for clamp the gas supply to the oxygenator during decannulation of VV, that sometimes your patients can desat pretty significantly. And so why does this happen? And this is partly because your hypoxic vasoconstriction is abolished during ECMO because of the increased SVO2. So your decrease in SVO2 allows the return of this physiologic hypoxic vasoconstriction. And so the pulmonary vasculature, though, however, and the lungs in general, they're kind of slow. They take a while to adapt. And so you'll have this transient worsened functional shunt. And this is where, capping oxygenator or clamping the gas flow to your oxygenator and weaning off sleep completely for a period of time sometimes helps this phenomenon from happening, so you don't have to be so nervous about the desats when you're decanning. So you do need to allow time. This helps you allow time to restore your physiologic hypoxic vasoconstriction and optimizes VQ matching or mismatching that occurs during this transition. And so just to be aware that this can happen. It doesn't mean that your lungs are getting worse in that period of time. And then the last slide that I have that I feel like is, I think most people will discuss this, but especially in respiratory ECMO, just because it's really hard to prognosticate sometimes or predict how the lung injury will go or how it will recover. And sometimes it can take weeks to months for recovery to happen. So it is very important to have a conversation with the family prior to starting ECMO about the things that would make you determine that it's futile. because you don't want to be having this conversation at the point where you're going to take them off ECMO, because it's very, very difficult for families to have to face that after a very long time on ECMO. So I usually have a conversation with them about what will limit ECMO and then what would make us decide to take a patient off ECMO in the absence of complications. And so it's usually the determination that there's nothing else that we can offer, that determination that there's really an irreversible process that doesn't show any signs of recovery. And in this setting, there's nothing on the other side of the bridge. There is no transplant option. There, and so sometimes we have to call several centers just to make sure that nobody has an option for this patient before we make these kinds of determinations, or severe brain damage, or some kind of catastrophic brain bleed or stroke or something like that. And then, so those kinds of things, like, they should be aware are reasons that you would take someone off ECMO, and that needs to be laid out before going on. Okay, well, thank you for your time.
Nama, we have one quick question that came in. I'm going to read the question, and then I'm just going to give a quick comment. And then if you have anything to add, let me know.
Okay.
So the question that came in says, has your institution ever considered trying PRCTO, which is patient-controlled retrograde trial off, weaning for VA ECMO instead of a clamp trial? So basically decreasing RPMs and allowing circuit flow backwards. We are considering this at our institution. So I personally have never heard of this. It seems kind of dangerous and wouldn't really be something I would consider for pediatrics. So I don't know if you want to go ahead and comment on it, and then maybe if anybody here in our live audience has heard of this or have experience, maybe you could also comment. Go ahead, Nama.
Yeah, I also have not heard of that. I think, like, we generally, like, VV ECMO is newer enough, especially in our institution, that the way I manage VV ECMO, I really do kind of think of it as a giant ventilator, and I feel like it's been like very easy to just wean sweep like you would a ventilator, and give the lungs time to kind of readapt and reset its auto regulation. That's what I call it, and that seems to be working very well. So I haven't needed to deviate from that practice because it works so well. But I'd be curious to hear why that is being done in other places.
Yeah, somebody else put in the comments that there was a study that just came out. It wasn't an adult study. So I'll see if I can find the link to the study and then post it in the chat for everybody. And it's saying it's specifically for VA ECMO. So I'll go ahead and see if I can find that literature and post it in the chat. Oh, here, Alyssa is saying she can post it. Or there we are. There's a few. So there's some resources in the chat so we can all look at that. That'll be an interesting discussion. But thanks, Nama. I know you're on service and it was difficult for you to get here. We'll see you again this afternoon.
Okay.
Thank you.
Hello, how's everyone doing? Hanging in there? Getting close to lunch? It's a pretty quiet group. Got some good chats coming on. There is a little change on the schedule of the agenda. Tomorrow, Joan Sanchez de Toledo will be speaking tomorrow at 4:15. So right now we're going to move Dan Ross up, and his is Pediatric DCD NRP program setup and considerations. So at this time, I'll introduce Dan Ross, one of our perfusionists here at Children's Hospital.
All right. Good afternoon, everybody. Try to make it quick. I know everybody's probably hungry, getting excited to go to lunch. So like Mike said, my presentation here is on DCD NRP program setup. A couple people asked how this ties into ECMO. I would say it ties in greatly because it's saved a couple kids that would be on ECMO still with a bridge to transplant. They'd still be sitting in our ICU waiting, and a couple of them are now home with their families. So it's been a great addition. Anybody that's been in the medical field for a couple of years knows it's pretty exciting when you get to do something new. So this is something we just started doing this year. Here we go. All right. So I'm not sure if everybody knows, but there's a difference between standard donation and donation after cardiac death. So standard donation, the patient declared brain dead by multiple physicians, and then they're declared a donor to donate their organs, they're brought to the OR like any patient, and then they can proceed with incision and then cross clamp and everything after all the surgeons have made their dissections for the organs that we're procuring. DCD is a little bit different. So the patients don't meet all 6 brain death criteria, but they're not going to obviously live, and the family wants to donate their organs still. So the patient is extubated, allowed to die naturally, and after a certain amount of asystolic time, donation can proceed. And that's when NRP comes into hand. NRP is normothermic regional perfusion. So basically, we put these people back on bypass, clamp out their head vessels so we don't reanimate the brain, and bring everything else back with a perfusion pump, a bypass pump. So we heparinize before they extubate. We give them a full dose of heparin. We always round up just because they are going to be asystolic for a few minutes. So that blood's going to be stagnant. You don't want it to clot whenever you try to go back on pump, or clot in the coronary or something to make the organ unuseful. The head vessels are clamped to prevent any reanimation of the donor's brain function. And then cannulation and initiation of bypass are performed pretty emergently by our surgeons. And then the evaluation of the organs made after about 30 minutes on pump. We have excellent surgeons here, so we've been able to get on pump in about 5 minutes from the standoff time every time, which is pretty good. All right, so why the need for DCD NRP programs? Everybody knows that works in children's hospital, there's an organ shortage in the United States. It's always a growing deficit as well. And then the adoption of a new donor pool with DCD will bring in could increase the availability of hearts by 10 to 30%, which means hundreds, if not thousands, of transplants per year. In pediatrics, patients waiting for a heart transplant are a little bit higher mortality rate than adults. We can't put VADs in quite as often as they do in adults, and just space limiting factors. And the mortality in children requiring a VAD is 15%. So we're trying to think of ways to prevent this, get them organs faster. All right, so we were approached by our surgeons and cardiologists with the idea. We actually had a huge step up because our adult center over at Presby had already started an NRP program for about a little under a year. So we got to go watch, observe how they do things on the big patients, made a couple of adaptations, and then developed our program here. If anybody knows my boss, David Palmer, we thrive on simulations here. And I have to say, doing a couple simulations with him before we actually went on the big one, it helps a lot. So, and then we developed our protocol using those simulations that we still use today. So here's a look at our equipment. This is it all packed up, ready to be picked up by the airplane. And then this is it set up, ready to go in the OR. We use a Levanova centrifugal pump. We have to bring a heater cooler because in the adult world, they weren't bringing them. Their patients don't passively cool with your blood in the OR being on pump down to 32 degrees where a patient would have the chance to fibrillate. In the adults, if you have like a little 2-kilogram patient, they cool much faster, if anybody knows. So we had to make a little adaptation and bring a little heater cooler with us. Another adaptation we had to make for pediatrics, E-cylinders come, the lowest sweep on them a lot of times a half a liter. If we put a little 2-kilogram patient on bypass with a half liter, you'd be so alcoholic, your CO2 would be minuscule. So we had to get some micro dials that attach to tanks, and we can control it down to 0.05, I believe. So, all right, and then we had a little bit of an issue compared to the adult centers. We have to be able to have our pump have a huge range of patients, so anywhere from 2 kilograms to 150 kilograms with the same equipment. So we did a little math. We also cheated off our bypass cheat sheets. So we use the same size parameters for our 1/4-inch loops and 1/4-3/8 loops, and then the oxygenator size depending on the size patient. So normally with our patients here on bypass, we'll use a roller head for anybody under 15 kilograms. We only have a centrifugal head here, so we had to make some just size reductions with straight connectors to be able to recreate that here. So we have some 1/4 straights, 1/4-3/8 straights that reduce this 3/8 and pump head here down to 1/4-inch connectors for our oxygenator. And then it's very important, you do need if you're using the centrifugal head, you need a retrograde flow protector because we utilize venous drainage on our reservoir. If you hook that up, you could pull air into the whole circuit and then pump air to the coronary. So you need that retrograde filter, which is right there. It's just a one-way filter, prevents backflow. All right, so this is the cannula selection we use. We were starting with our right angle standard bypass cannulas, and then Dr. Castro found that this is a combination of speed and best drainage, is this Licehouse tip. So a lot of times they'll throw a black silk around the auricle, the atrium, and just stab and poke right there, just so we can get them drained right away and get that blood moving again. We do go on bypass, normally bigger cannulas than we would in a standard case, just so we get excellent drainage. This is an example of an arterial cannula. We put that in the aorta after we establish drainage with the venous cannula. And then this right here is our aortic root vent, and that's how we deliver the preservative at the end. I can't remember. They used to call it Perfidex. I can't remember what they call it now for hearts. But they basically cardioplegia delivery to stop the heart, and we can put it on ice and deliver it back. Next here, this is just an example of our checklist that we bring for every case. You never want to show up to a hospital that doesn't do hearts and be ready to go on bypass and don't have something the surgeon needs. So we tend to bring more than we need, but anybody who travels for medical purposes, you realize you bring everything that you could possibly ever need. We have it broken down in here, size differentials too, based on what we bring. And then another thing we had to go through was getting drugs from the pharmacy. When we approached them at first, like, we just need a bag of drugs and we're gonna take them to another hospital. They were a little hesitant, but once we explained the whole situation going on, we talked to our anesthesiologists, and they gave us like a dosing curve and everything. So the pharmacy sets up go bags for us every time. We just go bring a patient sticker, drop it off, and pick up everything in there. And then, like I said, micro temp under 25 kilograms, flow meters, all the stuff we would use. All right. So the initiation and conduct of bypass for an NRP, like I said, the right atrium's cannulated. We drain out, and while they're cannulating the aorta, we're getting everything ready. We do load or pump up with more heparin as well, just in case the downtime, no clots can form. We only run blood gases there because we over heparinize them so much. Every ACT we were running was out of range high, so we just, after about 10 trips, we decided we don't need to run ACTs anymore. A big thing in the kids that we noticed compared to the adults, when we went on the adult trips, they were given pressors to keep the blood pressure up, just phenylephrine or something. We noticed when we were going to bypass, these kids were super hypertensive. And we did not bring our isoflurane vaporizer from the OR. So first time in my career, I got to use nicardipine, and just took some trial and error dosing wise, but it's better than keeping them hypertensive the whole time. Blood flow, the adult target flow is about 2.4 to 2.6 index. Kids, we always try to shoot a little bit higher than that. If they're taking the liver or kidneys or anything, they'll have us trend the lactate, make sure we're getting adequate perfusion, and bringing those organs back so they can be successfully transplanted. Blood pressure map, in the adult world, 60 to 80. Kids, basically based on the age range. Anybody, neonates, we keep them around 30. Toddlers up to about 40 to 50, and then adults, anybody teen and adults, we keep them 50s to 60s. All right, so once you're on and flowing, the organ evaluation can take place. So we'll make sure all our blood gases are well. EKG looks normal that they're running. And then the surgeon will actually have a handhold TEE or TTE, transthoracic, and directly hold it on the heart. We'll come to half flow, let the heart fill up, eject. They'll make an evaluation if we're going to accept or not, and then call home to the team here and tell them to bring the recipient in the OR. A lot of the times we're seeing, like, we'll accept the heart first, and then the other teams who are accepting like the liver or something, they'll want us to stay on bypass for about a half an hour just to trend the lactate down, make sure everything's okay. And it takes a little longer for them to dissect out like a pancreas and liver and everything. So we end up waiting. We're always like the first one's ready, first one's on pump, and then we have waiting for the other teams. So like I said, the adaptations for neonate donors. We have to blood prime every time pretty much. And it can be a hassle reaching out to these centers when we're going in the middle of the night to get some blood from their blood bank. But it hasn't been too much of an issue. And then, like I said, we needed to add a heater cooler just to prevent them drifting down below 32 and fibrillating, and then ruining our chances of getting the heart. And then a big thing we were doing on the small patients, we had to reevaluate how we were using our pump suction. they have such small blood volume, and we were already getting 2 units of blood, and then just from using the outside sucker, and during the case, they would suck it to the Neptune, and we'd be out of volume, and our hematocrit would be falling. So I'll show you on the next slide, we made a little adaptation. We couldn't keep our reservoir under full vacuum, or else it would cause suck down with the venous cannula and everything. So we got a whole separate vacuum setup with a little cell saver reservoir and had all our suctions returned to that, and then we bleed it down into our other reservoir. And then also the micro blender attachments just for alcoholic patients. So right here, this over here, if I can show, this is the actual reservoir we set up. This has all our suckers go to it, and then we bleed it down into our reservoir where our other pump suckers would go. The challenges we faced were we had to create a setup that we could repeat every time that could be used on a donor from 2 kilograms to 120 kilograms. We do hemofiltrate every time. Like I said, the pharmacology adjustments with hypertension, no fluorine vaporizer. Let's see, vasopressors. No, yeah. That's just the pharmacology stuff I went over already. We haven't been using too many inotropes, just vasodilators and constrictors. But there's Dr. Castro, our all-star there. We've saved a lot of kids, him starting this program here, so he deserves a big thank you. Next here. All right, so these are our numbers so far, and actually we've done a couple more since I've created these slides. So we've had 15 offers, 12 pump runs, 10 successful heart transplants, and 2 declined, and then our lowest weight was 2.1 kilograms. And this is the Sherpa Pec that we utilize for every patient undergoing DCD coming back. It's kept at 4 degrees. There's a lot of technology behind that. That's the best temperature to transport heart for maximum results. Here's just the little pool we have. Again, I'm missing a couple patients on here. A few have needed VA ECMO post-transplant, and I believe 6 of our patients have gone into the OR on ECMO or have had pre-DCD heart transplant. Like I said, the ischemic time, it matters like how far away we fly, where we go. And this one here where we use the cooler and the 111 minutes was an in-house donor. So that's why everything's a little shorter. But they've all done pretty well. We did 2 last week and the kids are already upstairs ready to go home. So it has been a great success for our program. So the limitations in children, small sizes aren't suitable for ex vivo OCS. Believe it or not, a lot of centers don't want NRP done at their facilities yet. It's still new. They don't want the chance of anything bad happening and a patient coming back to life on the OR table. So the innovation that we're coming up next with is instead of going on bypass with the full body, we'll actually let the patient excise just the heart, put it on the back table in like a bowl or a setup, and then just perfuse the heart to bring it back. Right here, they would use like either a head vessel or this. Normally, they'd keep more of the arch and just cannulate a head vessel and clamp the other side. We'd perfuse the coronaries down here, and then it just drains into this bowl passively, back into our circuit, and then back to the patient. So I see that being the future. Again, pretty similar. Might take a little bit more time just to excise it, get it out. But that's what I see happening next. And then I just want to say thanks to our team. It takes a huge effort. Everybody involved in the hospital. I think I read something one time. A patient that undergoes a transplant sees over 10,000 hospital workers during their stay. So I know I'll probably miss somebody if I try to name everybody, but I want to thank everybody and appreciate your time. Thank you.
Dan, you have one question that came in the chat, and it says, does the DCD NRP process interfere with family presence during the allow natural death process?
So every hospital is different with that as well. Some hospitals have like a room down the hall where they extubate the patient, let them pass. And the families are allowed to be with them until they're asystolic. When they agree to donate organs, they know that they walk through the whole process with them. But every hospital we've been to is very accommodating with the families and try to make it as easy as possible, the difficult situation they're in. So. Thank you, guys.
All right. Right now, we're going to go ahead and take a quick 5-minute break. If you guys want to go out and get a restroom or anything, then we're going to come back. We have one more speaker. He's going to be calling in virtual from UPMC Presbyterian. We're gonna give him a few minutes to get teed up, and then we'll have his talk, and then we will take the break for lunch, the afternoon lunch session. Any
Mike, we have,
questions so
we have
far?
one more question that came in the chat for Dan.
Okay.
And it says, what's your technique for reducing lactates?
Just adequate perfusion. Flown at a 3 index marker and treating bicarb and doing a good job as a perfusionist, I guess.
Thank you, Dan. Okay, does everyone want to go ahead and take a 5-minute break? Then we'll come back and hopefully Dr. Gavin Hickey will be here with us. Thank you.
Can you hear me okay?
Okay, everyone, we're going to go ahead and get started. We got one more speaker before lunch. We have Dr. Gavin Hickey coming from UPMC Presbyterian right across the town from us. We'll go ahead and let him get started, then we'll go ahead and take a quick break. Thank you, Dr. Hickey, for joining us today.
I always love to be the last person before lunch. Can you guys hear me okay?
Yes, we can hear you.
Excellent. Okay. So this is called VA ECMO with a side of Impella. It's a pleasure to be speaking to you all today. I learned a lot reviewing this, so hopefully you can as well. Can you see my slides okay? Okay, perfect. So
You can see your slides, yes.
Awesome. So we're going to talk about the hemodynamic effects of VA ECMO. We'll talk a little bit about recent literature on VA ECMO and cardiogenic shock, which there's been a explosion of that. Provide updates in temporary mechanical support, and talk a little bit, hopefully time for questions and discussion. I have some cases as well. So basically, you know, when we talk about VA ECMO hemodynamics, I'm not going to sit up here and pretend like I'm an expert in VA ECMO, because I'm not. But I have friends who are, and this is what they tell me, what the literature shows, is that using VA ECMO increases afterload on the heart, increases left-sided filling pressures, which leads to LV distension and risk of thrombus formation. And then that can lead to increased pulmonary capillary wedge pressure. That leads to LAA distension, which then can lead to pulmonary edema and hypoxia and congestion, lung failure. And that puts a lot of pressure on the right side of the heart, and then you end up with right-sided heart failure. I love this slide. I think it's a beautiful figure showing the hemodynamic effects of VA ECMO and cardiogenic shock. So starting with the left side of the heart, the LV, you can see that when somebody is placed on VA ECMO, what you see is an increasing LV end diastolic filling pressure. That leads to increased left atrial pressure, which then backs up to the lungs, and you see that high wedge pressure and the high PA pressure related to that. And again, increasing right-sided pressure, unloading with the ECMO device, obviously the right side, but it certainly is putting pressure in the lungs from the pulmonary congestion as we try to decongest the right side, with the venous cannula here. But we can see that for patients who are in cardiogenic shock, the goal is perfusion and unloading. And here, what we're doing, unfortunately, with VA ECMO alone, is that we're also loading the heart. So when we talk about LV distension, it happens about 10 to 60% of VA ECMO. And that's a wide range, but that's the data we have. And it causes increased myocardial oxygen demand. So as we're talking about somebody who's in cardiogenic shock, we want to decrease myocardial oxygen demand, either person who is in shock due to an MI or somebody who's in shock due to heart failure. We want to decrease the myocardial oxygen demand, and that decreases ischemia. And when we have LV distension, we also have decreased stroke volume and decreased cardiac output, decreased pulsatility, and the clinical complications that occur in that setting is thrombus formation and also development of arrhythmia. So as the LVDP increases and you get some of that ischemia, you're going to put that patient at risk for ventricular arrhythmias. And based on the data I have, the pediatric patient population is even at a higher risk for these occurring. So as I go through the literature on venting and LV decompression in VA ECMO, I just want to have this disclaimer that there are no large retrospective clinical trials or match comparisons that show clear evidence of a mortality benefit, but these are methods that clinically lead to alleviation of LV distension, reduced pulmonary congestion, and I'm going to show some data that it probably leads to native heart survival as well. So indications for venting. I found this table to be very helpful. So We talk about hemodynamic parameters that would help us determine timing for venting. So wedge pressures greater than 18, especially in the MI patients. Those patients are not going to tolerate wedge pressures higher than 18. In your chronic heart failure patient, they might tolerate a little bit higher pressure than that, but our goal is under 18. And then a lack of pulsatility with a pulse pressure less than 15. Again, that's a clear sign that this person is, probably has a lot of afterload and is not, is going to need some help unloading. And then echocardiographic evidence. So when you see increased LV dimensions, so LV end diastolic diameter increasing, when you see stasis of blood within that LV cavity, it's going to put that patient at risk for thrombus. When you see active thrombus, when there's absence of aortic valve opening, well, the LVOT VTI is less than 10. And then clinically, the development of pulmonary edema, so looking at your chest x-rays and you're seeing signs of hypoxia in the patient, or if you have ongoing ventricular arrhythmia, that patient also is somebody who you're going to think about venting. So timing of venting. It's interesting when you look at the trials that are ongoing, they talk about the timing of venting or indications. So again, the lack of pulsatility on the A line, aortic valve not opening, VTI less than 10, and signs of LV distension. I think this is a little bit subjective, but that's kind of what they use for the protocol for the shock trial. And then the Euroshock protocol is site specific. They don't even have direct parameters. So I really think those indications I've shown on the prior slide are a little bit more objective. Okay, what are the strategies when you talk about a patient going on to VA ECMO? What are the strategies for venting? So obviously with the VA ECMO therapy, we discussed that you're getting retrograde aortic flow, you're increasing left-sided pressures and LV distension, causing pulmonary congestion. So we're talking about venting here. And so obviously someone who goes on central ECMO, they're going to do direct venting most of the time in the LA. But for somebody who's not on central ECMO, and this is most of our patients that we deal with, the non-surgical patients, there are a couple different options. So balloon pump, certainly useful in some of these patients. So is providing a little bit of afterload reduction. And then you have the VA ECMO plus Impella, which I'm going to focus on today in this talk, or ECPella as we call it. And then the VA ECMO and LA drainage, which I talked about. And I'll just make a comment about the ECMO and LA venting is that there are a fair number of complications that occur with the direct venting. So one is, catheter obstruction, 2 is drain malposition, 3 is cardiac perforation, 4 persistent, left to right sided shunts after decannulating, and then bleeding. Bleeding is one of the biggest concerns, I think, when you talk about, central ECMO and direct venting. So, and then long-term risk of infection is, of course, as well. So, again, venting in VA ECMO, we are going to focus here today on left ventricular unloading with percutaneous devices. So, again, continuous or pulsatile devices that can be percutaneously implanted here. And so what does the venting actually do for the hemodynamics? So again, on the left side of the heart, we know that VA ECMO is going to increase afterload. So active LV venting hopefully is going to decrease the LVDP. It's going to decrease the pulmonary capillary wedge pressure, decrease pulmonary artery pressures, and then unload the right side of the heart. So hopefully with active LV venting, what we are achieving is decreased left ventricular end diastolic pressure, decreased myocardial oxygen demand, and decreased pulmonary congestion. How do we do that? So Impella has, very specific hemodynamic effects. So this is a percutaneously placed, Impella device that goes in the left ventricle. And, we have the CP, which is most commonly utilized for in the periphery. And then we have the 5.0 or the 5.5 that can be surgically implanted, typically through the axillary artery. And this can generate either up to 3.5 liters per minute of flow or 5 to 5.5 liters per minute of flow. And they go in and they actually can increase cardiac power output, increase MAP, so you can decrease your inotrope and pressor usage, and most importantly, unload the ventricle. So many, translational science papers and clinical research papers that have looked at how you can unload these ventricles and improve native heart survival. So here with these Impellas, what we're trying to do is decrease wall tension, myocardial oxygen demand, decrease microvascular resistance, decrease ischemia, and increase coronary perfusion. And so this unloading is the process that's going to potentially allow our patient to eventually recover. And we know that, you know, utilizing mechanical circulatory support is a better option than just increasing pressors and inotropes. As you increase pressors and inotropes, you get increased mortality and typically, again, increasing lactate levels associated with mortality. So ideally, you know, we want to reduce the pressors and inotropes, and instead we want to use mechanical circulatory support for these patients. So this is a paper, you know, written in 2022 that described the effects of an Impella 5.0 on inotrope and pressor score. And so with the 5.0 device, you can see prior to implant, a very high VIS score, high CE score, which then decreased at 4 hours post-implant and continued to decrease over time. So using, you know, an Impella device in patients with cardiogenic shock is associated with significant reduction in inotropes and pressors. What about cardiogenic shock and AMI? What is the hemodynamic effect of this insult? So I think, again, this is a really nice illustration. This is from 2021, looking at the aortic pressure, LV pressure, and RV pressure for someone who gets placed, and I'm sorry, this is kind of small on the screen, but so here's your initial shock. Here's somebody who goes on ECMO. Here's somebody who then gets an Impella placement, and then here's ECMO plus Impella. So what you see is in the shock state, putting someone on ECMO increases that left ventricular pressure significantly. And then somebody who gets an Impella, you actually see a decrease in the left-sided pressures. The aortic pressures remain the same, but the Impella doesn't unload the right side of the heart. So what do you need? The combination of left-sided unloading here, you can see the LV pressures remain low with the Impella, and right-sided unloading with the ECMO. And so the combination of these two gives us our best option for improving hemodynamics. Now, as far as, you know, use of Impella in acute MI and versus ECMO, they did a translational study, okay, looking at in a pig heart and LAD occlusion, okay, and they did either no device, peripheral VA ECMO, or ECMO plus Impella. And they looked at stroke work, infarct size, pro-survival risk pathway, immunoblot, apoptosis, and mitochondrial function. The key here is when you look at infarct size. So VA ECMO alone actually increased the infarct size, driven by, of course, increased LV pressure, increased myocardial oxygen demand, you know, and not unloading the heart here, and you see an increased infarct size, okay? And so that's the key when we talk about recovery in these patients, is that we want to continue to unload the ventricle to allow for less infarct size, less ischemia, and promote recovery. Okay, so other data that we have available on ECPella. So this is from 2016, 157 patients that received VA ECMO plus or minus Impella. So 123 received VA ECMO only, okay? And they propensity matched the VA ECMO alone versus the Impella 2.5. Okay, so the Impella 2.5 was an earlier version. The CP now is 3.5 that we use, okay, plus VA ECMO. And what they found was in patients that had early VA unloading at or near time of ECMO initiation, the Impella 2.5, mortality rate was 48% in the Impella group versus 74% in the VA ECMO alone. And the weaning rate, also 48% in the Impella group versus the 28% in the VA ECMO alone. So your ability to have native heart survival, so not just survival, but native heart survival, was much higher in the Impella group. What about other studies in AMI cardiogenic shock? So looking at patients who were on VA ECMO and then versus Impella. So if you look at this, what you see is a cumulative survival improvement in patients who are on VA or on Impella compared to VA ECMO at 30 days. And this was, again, a kind of a smaller study, 2019, published in a SIO. Okay, but what we see is a significant improvement in the patients who went to ECPella versus ECMO. Now, additionally, I mentioned the importance of reducing inotropes and pressors. And so if you look at patients who had ECPella versus ECMO, day one, you see a higher inotrope score initially for the ECPella group, but by day two, a significant reduction in inotrope and pressors, and that continued to day three, whereas the ECMO group had less of a drop. In fact, by day three, wasn't a lot of change in the pressor and inotrope requirement. So again, why are we able to reduce, the inotrope score here? Because we're using our mechanical support tools to unload the heart and improve cardiac power output. Okay, so other ECPella data, they called it ECMella here in 2020. This group did VA-ECMO plus or minus unloading with ECPella, and 70% were CP, but 17% were 5.0. So now we have some ECPella 5.0 data coming in. Again, they propensity matched 255 patients. The mortality, the 30-day mortality was lower in the ECPella group compared to the ECMO group. Complications, however, were higher in the ECPella group. So this takes into component of, yeah, survival is great, but we also want to reduce, comorbidities. And again, I'll point to the fact that 70% of patients had CP. We know that CP, which is usually peripherally inserted, has higher rates of hemolysis than the 5.5. It has higher rates of bleeding, higher rates of limb ischemia. So what about the UPMC Presbyterian ECPella data? So we looked at patients, this is done by Dr. Modi, Dr. Ramanan, among others. We looked at data from 2020 to 2023, 44 patients, okay? 20 had AMI shock, 24 had heart failure shock, which is really an understudied, population in the ECPella world here. And what you see again is that, survival probability didn't really differ between the MI and heart failure. Part of this driven by the fact that some of these, heart failure patients went on to advanced therapies. And especially if you look at the de novo heart failure patients, right, they had really good survival with the strategy. And so what we found was patients with VA ECMO and concomitant percutaneous VAD was feasible at a 55% 90-day survival. There was no difference between either MI versus heart failure. And then in patients with AMI, supported initially only with ECMO, they had a higher mortality. So in the MI patients, certainly ECMO alone led to a higher mortality. So now we are in the era of ECPella 5+. And so if you look at, patient outcomes, initially VA ECMO, and then you compare that to ECPella, so that's either the CP or 2.5 with direct LV unloading, that reduced mortality. And now looking at the data we have access to, the ECPella 5+, with increased LV unloading, decreased access site complications, decreased need for inotrope therapy, what we see is earlier de-escalation from VA ECMO and enhanced myocardial recovery. And this is just published here in February of this year. So what are our contraindications for use of a percutaneous ventricular assist device with ECMO? LV thrombus is an absolute contraindication. Mechanical aortic valves, because we have to cross the aortic valve. Severe PAD. And again, we're talking about typically it has to be, for a 5.5, would have to be peripheral arterial disease in the axillary arteries, okay, which is not as common. So there's very few patients that are unable to tolerate it. Even aortic valve disease really isn't a true contraindication, because even patients with, severe aortic stenosis, typically we can cross, and patients with severe AI, we can actually cross. And if it's central AI, believe it or not, using these ECPella devices actually works very well, because they kind of plug and reduce that insufficiency and also create that kind of increased cardiac output. I'll put one other plug in here. So Mohammed Abdullah is one of our cardiac surgeons here who puts a lot of our ECPellas in. He has done BSAs as low as 1.16. So even very small patients can accommodate an ECPella 5.5 device. Okay, other risk of complication, major bleeding. Again, this is more of a concern with the CP or 2.5. Hemolysis, again, way more common in the CP or 2.5 compared to the 5.5. Limb ischemia, again, mostly if the CP is placed peripherally. I think many of these complications can be obviated by the use of the Impella 5.5 device. And I'm going to show some data on just how great this 5.5 tool can be, and even greater than 14-day runs. So how do we surveil these patients who get Impella? When is it time to decannulate from ECMO and maybe just de-escalate to Impella? Or how do we know when we have to use the Impella? So chest x-rays, obviously, PA catheter for hemodynamic data, very important. I'll talk a little bit about that in a moment. A-lines for pulsatility, echoes looking specifically at LV distension, thrombus, or VTI. Okay, PA catheters, how do they help? Well, we know that PA catheters for exam is about a coin flip. So if you compare exam versus hemodynamic assessment, it's a coin flip, 50% or less that you're likely to get concordance. So we know that PA catheters can be very useful for early identification of cardiogenic shock. And then for monitoring in cardiogenic shock as well, patients who get a complete assessment with a PA catheter versus those who get no or incomplete assessments, the patients who have complete assessment with a PA catheter have better survival. So this is data from 2020, Cardiogenic Shock Working Group Registry, and looking at patients, these are good numbers, over 1,200 patients, right? And as patients got sicker, and they went to SCI D or E, the survival benefit actually improved. So we know that PA catheter, specifically in cardiogenic shock, is a very useful tool, reduces mortality. And the reason is because it's not just putting them in and getting appropriate hemodynamic data. It's also when you monitor these patients, a lot of them respond differently than you would expect. So again, patient one, someone with a really high wedge pressure of 30, getting a percutaneous left-sided device and unloading the patient actually unloaded the right heart too. And so this patient developed normal hemodynamics with just a left-sided support tool. Now, patient two, the right heart's a little bit sicker, the CVP is a little higher. You put in that percutaneous left-sided support like an Impella, you improve the wedge pressure, but the right-sided pressures are still high. Now you diurese that patient, and that patient becomes normalized through hemodynamics. And then patient three, this is somebody who has actually pretty profound right heart failure with a right atrial pressure greater than 20 and a wedge pressure less than 20. If this person is supported initially with an Impella device, yeah, you unload the left side, but look, the right side gets worse. Now you need percutaneous right side support. So this is somebody who maybe you've gotten Impella first and then ECMO, right? And now you're decongesting the right side, you're filling the left side, and now that patient can be diuresed to normal hemodynamics. So the use of the PA catheter for these patients is really ongoing hemodynamic monitoring and appropriate timing of intervention with the right device. Just putting a plug in for our cardiogenic shock team. So you could see that the cardiogenic shock activations have increased year over year. Part of that being due to ongoing outreach efforts, education, recognition, okay? And implants of the 5.5 have also increased year over year and by quarter. And last quarter, we did 25 Impella 5.5 implants, okay? And what you see is that as we become more and more familiar with the Impella 5.5 devices, what we're seeing is a drastic increase in the recovery section. So here's recovery over here, 23% in 2023, as opposed to 36% deaths. In 2024, 39% patients went on to recovery compared to 31% deaths. And if you look at 2025, we're doing even better. So we now have 47% of our Impella 5.5 patients going on to recovery, 20% going on to transplant. Still have that 30% or so mortality. Okay, that's kind of on par with literature in general. But if you look over here again, 56% recovery, native heart survival. All right, and these are patients that never would have been able to recover previously without the advent of this technology that allows these patients to de-escalate, get them up, walking around, mobile, decrease complications of hemolysis, bleeding, infection, right? And so what we're seeing is this great use of this tool and improvement. So again, we measure everything in our cardiogenic shock program because if you can't measure it, you can't improve it. And here, what we see is overall cardiogenic shock team cases from 2022 to 2024. We see an increase in those patients that are discharged to home. We see a decrease in patients who are dying in the hospital. We still see, the heart transplant numbers still around 5%. Our VAD implant numbers have gone down, partially due to native heart survival. So over about 1,000 patients over the last 4+ years, what we see is a mortality, low mortality, 25%, right, compared to your typical mortality in cardiogenic shock of 40 to 50%, and a discharge home rate that is rising and hopefully will be over 40% very soon. Yes, we still have to do transplants. Yes, some patients are still going to go home with palliative care. We're still going to do VADs in some of these patients, but the question now is, how many hearts can we recover, and how many patients can we get to home? So one case, I'll be brief. A 24-year-old woman who's intubated, it's a cardiac arrest. Obviously, she's acidotic, her lactate's super high. She's Sky E. She's hypoxic. There's a POCUS done. Her EF is 10%. Okay, so this is clearly cardiogenic shock. It started and goes up on norepi to 0.7, and dobutamine is added, milrinone's added, epinephrine's added. Okay, and we said, hey, can you get a PA catheter in? And the ER doc puts a PA catheter in, or assisted, I think, by the ICU doc as well, and transfer the ICU with PA catheter in place. Super sick young lady, right, on multiple pressors and inotropes, mortality greater than 70%. So the shock team is activated. Okay, and here's our algorithm. I'm not gonna belabor this point, but we have a med call. The CCU attending takes that call and activates the team. We get our surgeons and our critical care docs on the call, heart failure docs, interventional, right, and we talk about what we can do for that patient. And in this case, we put the patient on ECMO and transfer to Presby. So the patient arrives, from pretty good timing, a little over an hour. A little over 3 hours, shady side Presby, maybe a little delay there. Support on ECMO and epi, okay, without pulsatility, and the plan is for Acapella. So here's an echo. What you see is stasis, aortic valve is not opening, okay, and low pulsatility. So multiple indications for a patient to get unloading with a left ventricular, percutaneous left ventricular assist device. The Impella, seen here, is placed in the left ventricle. You can see this is a small heart. This is not acute MI. It's a 24-year-old lady, right? But it's an acute de novo heart failure. Impella goes in place in the left ventricle. And what do you see? You see clearance of pulmonary congestion. So this person, gets her CP, gets her 5.5 following commands. We initiated a transplant VAD evaluation. We added milrinone because their afterload significantly increased with the Acapella support. We repeated an echo 3 days later, and the EF goes back to 65%. She was decannulated from ECMO, removed the 5.5, transfer the floor. We did a cardiac MRI, and there was no LGE. The EF was 69%. Just impressive recovery by this young lady due to timely intervention. So in summary, VA ECMO has potential for increased afterload LV distension, which puts patients at risk for development of thrombus and arrhythmia. LV unloading with Impella improves outcomes and observational data, and probably, based on the data we have, enhances myocardial recovery and weaning, especially with the use of the 5.5 device because of the ability to ambulate and de-escalate from ECMO. So the Acapella 5+, looking at more and more data on this. And then we do have to understand the potential complications associated with the devices, right? And we have to know the contraindications, and we have to have end the game in mind. But the Acapella, 5+ era is here, and I think is going to provide our patients with great success. So that's all I have. Happy to take any questions, and I will stop sharing.
Thank you. We have a couple of questions that came in the chat. So the first one says, what are your thoughts on using a right-sided Impella to unload the right side?
So in patients who are not ECMO candidates, or we think are going to be maybe quick recovery, such as your acute MI patients, certainly use of the Impella, RP devices or Impella Flex can get patients through. Oftentimes in your patient who has had an arrest or is having ongoing arrhythmia, or very low PAPI score, high inotrope scores, or a hypoxic ECMO is your best initial bet, because it's going to be able to get you quickly unloading that right heart and support the map for patients who are having that arrhythmia. But the key is that if you put the patient on via ECMO, you should at least be thinking about whether or not that patient needs a vent. In patients who are maybe non-acute MI or not as sick, who have right-sided issues, or maybe they're not ECMO candidates, I think using a right-sided Impella tool can be very useful, especially if there's an end game in mind. So I would say shorter duration, maybe not as sick right hearts, and then in some of those patients, you do still need left-sided support tools as well.
Great, thank you. We have two more questions for you. The next one is, could the unloading effect of ECPella be twofold in regard to mitral regurg as well, since most mitral regurg associated with cardiomyopathy is functional and results from LV dilation?
Absolutely, we have used these tools in mitral regurgitation, especially when it's chronic heart failure and functional, as you mentioned. I will say that if somebody has an acute mitral valve injury and they have a small left ventricle, that some of those patients do better with maybe a balloon pump. But for your patient that has a dilated ventricle, very low EF, these unloading devices and tools definitely improve mitral regurgitation and can decrease the pulmonary congestion. So so I think it's an indication for some of these patients.
Okay, great. And it's two more questions. So the next one is, what is the lowest age, weight, or artery size to use for the Impella?
I think it's completely, based on the size of the patient as opposed to age. Now, Mohammed, again, Abdullah, just a fantastic surgeon here. He has done very, very small vessel size, less than 4 millimeters. I think 7 millimeters is kind of what the FDA or the IFU says on the Impella, but we've done less than 4 millimeters, and the BSA size was 1.16 in that patient that we did. So, and he went on to transplant and has been doing very well. So I would say that we don't know what the lower limit is, but certainly we've done them in very small patients.
Okay, thank you. The next
smaller patients, sorry, just to add, some smaller patients don't need 5.5 liters of flow, right? So if they're smaller and maybe they just need a little bit of unloading, a little bit of support, some of the the CP could be utilized via the axillary artery to get a little bit of support.
Okay, thank you. And then the next question that's up, I'm not sure it's for you. It came up earlier in the chat and I forgot to address it. It says, what's your ABG frequency after cannulation and how often do you run the Fick equation? So I'm going to answer that for us here at Children's. I think we typically do our ABGs after cannulation. We do them right when we go on, and then if it looks good, I think we usually go every 2 to 4 hours and then space them out according to the patient's response to ECMO. And we don't run a Fick equation, do we? I can't remember the last time I calculated a Fick equation, particularly on ECMO. VA ECMO, it's a little difficult to run a Fick equation on because you have the circulation in the pump plus whatever the patient is contributing. Does anybody else have anything to contribute for that question?
Okay, that's it.
Oh, wait, one more question. Is Dr. Hickey still on there?
I'm here.
Okay, great. So the next question is, some ventricles need to be better unloaded for recovery, aside from widening the atrial septal defect in a left atrial duct. What do you recommend to speed up recovery?
I will put a huge plug in for guideline-directed medical therapy on device. So one of the things that has been, I think, understudied, and there are ongoing now national trials that are looking at this, was the use of guideline-directed medical therapy while the patient is on support. And understanding that you can utilize some of these devices to keep the MAP elevated and to unload and to keep perfusion so that you can initiate some of these tools. And I would say typically we start with a spironolactone or an SGLT2 inhibitor, And then we try to add on, if they have higher afterload, we try to add on an ARB, and we try to add on a low-dose beta blocker. And even in the setting of a low-dose inotrope like milrinone, we can still utilize the GDMT to get them off support and allow recovery. One thing I always tell my heart failure residents is that it takes only 15 days from the time you start an SGLT2 inhibitor to survival benefit. So the quicker you can start some of these medications, the quicker you're going to have myocardial recovery.
Okay, thank you. One more question, and then we are going to go ahead and break for lunch. So the next one is, what would be the management strategy in ECMO when there is a mild to moderate aortic injury without yet criteria for valvular change?
So I think that getting an echocardiogram for a patient who's on ECMO is really useful, because you can see if there's LV distension stasis. You can see if there's valvular regurgitation. If there are signs that you're putting increased afterload on that valve, right, and you're showing these other indications for venting, I'll make a plug for this use of the 5.5 device or an Impella device that actually can go through that aortic valve and unload the ventricle while you're trying to bridge that patient to a definitive therapy. So we had a patient, a 48-year-old man, who came in with severe AI, probably from a bicuspid valve, and he was in profound shock, 3 pressors. So we got him to a 5.5, and we're able to wean off the pressors. And then what we did was we actually put in a VAD and replaced his aortic valve. And in 2 years, with his VAD and GDMT, we were able to keep him unloaded. He actually recovered. And so EF of 45, 50%. We explanted his VAD. He's now about 1.5 years out from his VAD explant and doing very well. So I think these technologies can be used as a bridge to next therapies.
Sure.
Okay, and I was wrong again. We have a couple questions coming in. So one more for you. So how do you assess the unloading effect? TEE, TTE, or clinical presentation?
I think the best way to determine that is actually, having a PA catheter in and looking at PAD is very useful. And then chest X-ray, daily chest X-rays, and looking at ABGs and vent requirements. So if you're properly unloading, PAD should be coming down, chest X-ray should be clearing, they should require less oxygenation, and hopefully eventually extubate as well. So I think we don't typically follow with echo once we get the device in. I think we use our hemodynamic parameters and our imaging with the chest X-ray as our kind of key signs for that. Because I think the problem with the echoes is that obviously it can be hard to get a lot of echoes frequently, just for putting pressure on the on the echo techs and demand on the system. But also oftentimes we know clinically if that patient's improving or not based on things like pulsatility. We certainly, measuring SpO2 is hard in ECMO, but certainly looking at some hemodynamic and hemometabolic parameters like lactate. So I say there is mostly clinical and a combination of hemodynamics and hemometabolic assessment, along with assessment of end organ function improvement. So not just the lungs, but liver, kidney, etc.
That's it. Okay, Dr. Hickey, always a pleasure to have us, and we appreciate all your input you had. Excellent discussions. And once again, thanks for having joined us today.
Yeah, thanks for having me. I really appreciate it. Thank you so much.
So we are going to go ahead and take a break now for lunch and reconvene at 2 o'clock. So if you guys want to walk around, get something to eat, stretch your legs, but we'll reconvene back here at 2 o'clock. Thank you. Okay, everyone back, and how was lunch? Good? Okay, it's our pleasure to introduce Tim Caslitz from UPMC Presby and Children's. Tim splits time with a critical care team from both our adult patient population across the street and here at Children's. He's going to be talking a little bit about respiratory ECMO, a model process. Everyone, Dr. Tim Caslitz.
All right, thanks, Mike. All right, so let's see. First off, only disclosures. I received some teaching honoraria from ProCirca. No other disclosures there. So what I'm going to talk about for the next 20 or 30 minutes or so is a process that we've developed over many years at UPMC Presbyterian for respiratory ECMO selection in adults. Now, I put VV in parentheses because by and large, 99% of the time when we're talking about medical respiratory ECMO in adults, we're really talking about VV. So a little bit different than pediatrics in that way. What I think we can accomplish over the next 20 minutes is that we're going to briefly review the indications and contraindications for respiratory ECMO. I'm going to talk about our current selection process at UPMC Presbyterian, and then the importance and benefits of a formalized selection process. All right, so respiratory ECMO, you guys have probably reviewed this already so far in the conference. The principles, though, I'm going to keep coming back to. The goals are you're replacing native lung function and allowing time for lung rest. Okay, earlier is likely better if you follow the literature. Does not treat or cure anything. This is really important. You're not modifying the disease process in any meaningful way. You may be able to mitigate some of the ill effects of ventilator-induced lung injury, but aside from that, again, you're not modifying the disease process. You're allowing for lung rest, and at least in adults, it's not for all comers. The indications: refractory hypoxemic respiratory failure and refractory hypercapnic respiratory failure. Now, by and large, 95% of the time, it's hypoxemia that gains you an indication in the adult world. The diagnoses that we're going to focus on is pretty much everything that causes ARDS. There's a whole other list of other diagnoses there, but I'm not going to focus on them. When we get consulted to deploy respiratory ECMO in adults, over 90% of the time, it's for acute respiratory distress syndrome, okay? The most recent ELSO guidelines describe ECMO candidates as having a potentially reversible cause of their respiratory failure that's refractory to conventional management, and that there is no formal contraindication. So contraindications at UPMC are relative. So importantly, ELSO does not list any absolute contraindications, and there's a good reason for that. Here are the list of relative contraindications that are present in the ELSO literature and that we've deployed at UPMC Presbyterian. So older age, requiring mechanical ventilation greater than 7 days, chronic lung disease requiring home oxygen, and active malignancy without curative option. So that can be surgical or chemotherapeutic. A non-recoverable neurologic injury, there's a lot of gray area there. CNS hemorrhage, end-stage liver disease, acute uncontrolled bleeding, immunosuppression, multi-system organ failure, and then a moribund patient at the discretion of the ECMO team. And obviously DNR would fall underneath that as well. And that's just reviewing it in the ELSO guidelines for VV ECMO selection. And you can see a similar list there. Now I highlighted older age, because I think that's really important. We don't need to deal with this in the pediatric world, but it becomes very, very important in the adult literature. So it's probably the single most important risk factor, because every decade of life that you increase, there's a linear relationship in mortality. So this was a study by Fernando et al. That came out of ICU Medicine in 2024. So chronological age at the time of possible admission was the primary exposure in this study. Okay, this variable, the researchers categorically listed there in an approximately 10-year interval, starting from age 18 all the way up through greater than 80. And they have a forest plot demonstrating the adjusted odds of possible mortality with each increasing age decile. When it was further parameterized in a spline, you can see that linear relationship there. Of the relative contraindication, the other major risk factors for poor outcomes in adults are prolonged invasive mechanical ventilation and immunocompromised status. So if I could pick the three most important ones, it would be those three. And observational data bears that out. I've highlighted the three most important ones there. Notably, body mass index, which oftentimes when we're getting consulted, the consultative facility will say, this patient has a really high BMI, so we don't think they're a candidate. Interestingly, up to a certain point, it's actually protective. And if you're interested in learning why that is, I'm happy to discuss it after. All right, so what numbers do we actually base our selection criteria on? So most of those cutoffs actually come from the OLEA trial. So to date, this is probably the best evidence we have for how to select patients. So it was, to the letter of the law, a negative trial, but because of over a third of patients had crossed over from the control arm to the treatment arm, they did a post hoc Bayesian analysis and determined actually that there was a high likelihood of ECMO providing benefit. Now, the interesting thing is you still had a number needed to treat of 10. So if you took the absolute risk reduction of about 10%, that means for every 10 patients that you put on ECMO, you're really only saving one. But nevertheless, you can see in the Kaplan-Meier curve there is an early separation. It's persistent throughout the duration of the study. So the inclusion criteria in the trial were mechanical ventilation with an FiO2 greater than 80%, PEEP of at least 10, and a tidal volume of 6 per kilo. So practicing lung protective ventilation strategies there. If you had a PDAF ratio of less than 50 for about 3 hours, or less than 80 for 6 hours, or you met the hypercapnia criteria there, then you met inclusion criteria for being enrolled in this trial. All right, so pragmatically, how does this play out? So the first thing, obviously, you're consulting the respiratory ECMO team. So at Presbyterian, it's a little bit unique. The CCM team owns respiratory ECMO 100%. There is very little to no involvement from the cardiothoracic surgeon, which is somewhat unique, actually, around the nation. I updated the picture. So like I said, this is somewhat unique. So we're involved in basically every single phase from receiving the consult, screening, selection, cannulation, weaning, and decannulation. And there's the whole team there that you can see. So patient selection, we actually break out into 3 different phases. There's the review of the patient, a consensus process, and then ultimately providing recommendations to whoever's consulting us. It's team-based, so no single individual is making a decision. The case is reviewed by at least 2 ECMO team members. So in the CTICU, we have 2 attendings on at any given time, okay? And if we need more people, we can actually put out an ECMO bat signal in the sky, which is really just a text message, and anyone else that is available can get on a FaceTime call and we'll discuss the patient. So the patient has to have a reversible condition, as I mentioned, optimized medically. I'm not going to get into what all that means, just for the sake of keeping it within the scope of the talk. Demonstrate objective failure of conventional management, and then making sure that our inclusion and exclusion criteria are reviewed and met. For the people that like flow charts, this is kind of what we do, right? So there's your initial indication and inclusion criteria. We strongly recommend, unless contraindicated, prone positioning, a trial of neuromuscular blocker, high PEEP strategy as well. So a trial of open lung ventilation. They don't need to have a PEEP of 10 or 12 at the time of consultation, but at least needs to be attempted. Interestingly, you'll know that inhaled pulmonary vasodilators are considered but not required. And there's good reason for that I'm happy to discuss after if people have questions. And then you can see the inclusion criteria. And then we review contraindications and then ultimately recommend ECMO. So this is the consensus process. So we try to keep it completely consistent, transparent across team members. The last thing we want is doctor shopping, which can happen. Whether or not a patient is offered ECMO should absolutely not depend on who the attending is on service. And then if there's any other conditions that require extra scrutiny, we consider that too. So sometimes there are social situations that can get in the way. If the patient is quite functionally limited, a lot of times if they're dependent for ADLs or IADLs at home, we discuss those things with the family member, with the primary care physician before making a final decision. And finally, phase 3, when we make a decision, the recommendation could be ECMO, but it may not be. So we provide as realistic of an expectation of survival based on the data and the recovery process. We talk about duration of support being offered. So in VV ECMO, it's not uncommon for patients to be supported for 2, 3, 4 weeks, or sometimes multiple months, as long as there's no accrued complications. And then we also discuss, okay, so what indicates success or progress, and then what indicates failure as well. We talk about anticipated subsequent procedures. So this is typically tracheostomy, but can include other surgeries as well, especially for patients that have any pleural process that's concomitant with the respiratory failure. So if they need chest tubes or VATS or something like that. And of course, we obtain consent when possible. We always talk to the families when they're available. So a lot of times the patients can't consent themselves, as you can imagine. So if criteria met, then we initiate transfer. This talk was actually part of a broader talk. Before I edited the slides, we're not going to talk about transfer for these acutely sick patients at this point. This is a really important point. So I always say this when I'm teaching this process to our fellows. Evaluation continues right up to the moment of cannulation. So sometimes things do happen in that intervening period when the patient arrives in your hospital, and you have to make decisions to perhaps abort the procedure if they no longer are meeting inclusion criteria, or if a contraindication or exclusion criteria becomes apparent. So a lot of this work was done by Dr. Ramanan, who is the ECMO director at UPMC Presbyterian. This culminated in a document with highlighting patient selection guidelines. This was in April of 2025. So this is a bigger lift than you can imagine. He basically got all of the UPMC hospitals that cannulate for ECMO or manage ECMO to sign off on this document. So this is a institutional agreed upon best practice guideline. So talk about the benefits, at least what I think are the benefits of having such a formalized selection process. So what's the goal? The goal is to make ECMO available to patients who have the potential to benefit. So if you were to stratify that, I mean, some of these seem ridiculous, right? All hypoxic patients, no. All patients with poor lung compliance, no. What about patients that could conceivably in some world benefit from ECMO? Probably not. But patients that are at the discretion of the ECMO team, more likely than not to derive a significant benefit over and above conventional management. So the main benefit is that this is informed decision-making, right? You have established inclusion and exclusion criteria. It's team-based. No person is feeling like they're the arbiter of life and death, right? It's a team-based decision model where no decision falls on a single person. Okay, this reduces practice variability and doctor shopping. It also helps avoid this bridge to nowhere that is so dreaded, right? Nobody wants to be in this position where you have a patient on extracorporeal cardiopulmonary support, and they have a really low likelihood or no likelihood of recovery, okay? You have some emerging evidence that when you do formalize the selection process, patients benefit, but recognizing that there is no crystal ball, right? We're gonna make mistakes on both sides of this. I think the care becomes more effective, equitable, and ethical. So again, the criteria are objective, they're transparent to all parties. You can mitigate bias related to demographic and financial characteristics, which is really important. There's evidence that these things actually do influence clinicians' decisions and who they offer ECMO to. It facilitates a shared decision-making with the families as well. So if you have, I'll give you an example. We partner with our MICU all the time because most of the time ARDS patients are found in medical ICUs. So when they call us, they've now been made aware of what we look for. So we get called earlier. And when the answer is no, they understand why, because it's completely transparent to them, because they know what we're basing our decisions on. Similarly with families, if you have this all laid out in advance, you can have an informed discussion with them, which becomes really important when their loved ones are really sick. It helps them understand if you are offering ECMO, what they can expect, and if you're not, what's the reason why not. No surprise, ECMO is very resource intensive, it's very expensive, and sometimes those resources are limited. When I was a brand new attending, it was during the height of the pandemic, and we didn't have enough pumps to put all the people on that we wanted to put on. So this is actually what spurred all of this discussion of formalizing the selection process in the first place, because we had to make some difficult decisions about who we were going to offer support to. So when you have a formalized selection process, it can really help in these unprecedented times when difficult decisions need to be made. I'm going to skip over this. This is the preset score. It came out of a group in Germany in 2017. Again, I'm going to skip over it in the interest of time. All right, so for recommendations, always you need to operate within the construct and confines of your ECMO program's experience, expertise, and resources. So if you're going to have this process, you need to have people that know what they're doing with ECMO, right? If they're not experienced in making these decisions on a regular basis, they don't have a lot of experience taking care of ECMO patients, you're only going to be good as those people. And then obviously you have to have the support of your institution or your hospital and the resources to be able to roll it out. The program should develop a clear set criteria for initiating as well as declining ECMO. You must ensure consistency between the cases. Again, it can't depend on who happens to be the attending on service. So when you do it this way, it minimizes pressure to just say yes, especially when you're staring down the barrel of a really, really sick patient that otherwise, quote, will die without ECMO, right? You still want to be making informed, thoughtful decisions and not just say yes because you're scared. And this is ultimately the dilemma that we find ourselves in. I know I still find myself in this situation, right? Just because I have the support of a larger team in making complex decisions, it doesn't mean that we don't feel these things, right? We're taught to never give up, and yet we want to avoid futility. So sins of commission, omission, I say this a lot. As the patients become sicker and sicker, we're willing to try more and more things, right? Despite the risks and despite the potential harms. And ultimately, we all have to sleep at night. So what actually feels worse? These are both really bad. They feel bad to anybody. But I would argue that it feels worse to withhold a potentially life-saving therapy than it does to have complications related to that therapy, right? That just psychologically feels worse. But functionally, it's the same thing. It still ultimately has to do with your decision. The difference is, in the former case, it's attributed directly to the clinician. In the latter case, it's just considered bad luck because it's a complication of the therapy. But really, it's the same thing. Again, you often hear this statement, well, if I didn't put them on ECMO, they surely would have died. This results in underestimating risks and overestimating potential benefits. This is actually called the affect heuristic, when decisions are swayed by emotional reactions instead of deliberations about risks and benefits. It leads to underestimating the risks and overestimating the benefits. We have proof of this. So this will be my last couple slides. This is a study that came out of the Paris group, the Paris ECMO group, that actually looked at patients that were declined for ECMO during the COVID-19 pandemic. And it turns out, if you had actually surveyed those clinicians, they thought all of them surely would have died, right? Because they're generally saying, they said no to those patients because they were really, really sick. They were considered to be too far gone. And yeah, their mortality was worse, but about 20% of them survived. we had the same experience. So this was a paper published by one of my fellows. Similarly, don't pay attention to the green and the yellow phase. All of these patients were patients that were declined for one reason or another. The green or the yellow just refers to where we were in our resource limitations. So we had green, yellow, and red based on how much resources we had. And despite that, again, a significant percentage of patients that we said no to, the overwhelming majority of which we said no to because they were felt to be too sick for ECMO, a percentage of them still survived. So lastly, ECMO can help save the dying, but cannot save the dead. I think, am I done on time? Okay. All right. I have some cases, but I was going to ask the group what you'd do, but if we're out of time, that's fine. Sure.
Okay, so the question in the chat is regarding criteria. Do you track how often the criteria are used as firm inclusion, exclusion versus guidelines? Does your center experience occasions when the patient does not meet criteria, but they are put on anyway, such as size, weight, used to be a criteria, but now we see smaller and smaller patients going on ECMO? This was done in spite of size being an inclusion-exclusion criteria and has contributed towards successful runs in smaller babies.
Yeah, so I can't comment so much on the pediatric part of that, but usually the size for adults is on the other end of it. I can tell I was actually, so I had some insomnia last night, so I got up and that bat signal actually went up at 1 a.m. And the attending that was on overnight was like, who's available for quorum? And I happened to be available. And this patient had a BMI of 68 and was not on home oxygen, but had some chronic respiratory issues and actually came in with COVID-19 pneumonia. We actually haven't seen a COVID-19 pneumonia ECMO consult probably in 2 years. So this is the first one in 2 years. And this guy didn't fit the, this is the whole point. There's no cookie cutter approach to all this. I mean, we don't have an upper BMI level because there's good evidence that patients with BMIs upwards of 50 or 60 actually have the same survivability as patients that have a BMI less. They become difficult to cannulate and difficult to support, but if you can get past that and you can support them, they actually have very similar outcomes. So I mean, this is getting back to the bias part of it, right? If you follow the data, then you can pick better patients. This particular individual, he was very tall as well. So we did have a question of whether or not we could support him. He was actually 520 pounds. And when we talked to the family, it turned out he really wasn't very ambulatory for more than 10 steps or so. So it wasn't thought that he would be a good candidate. But it was a very difficult decision, right? Because they didn't fit the bill. This was a total outlier. So we just applied our best clinical judgment with the data that we had and ultimately made the decision. But again, that kind of a decision, you can imagine making that alone, it becomes very difficult. So we had 4 people on the call and there was a variety of opinions, but ultimately, we supported each other and I think came to the right decision in that particular instance.
Thanks, Tim. We don't have any other questions.
I can, if people are interested. This is like we can also engage. This is like ECMO, yes or no. These are all adults though. So yeah.
Since you've deployed it, but it hasn't been that long in this process, what are some of the, or if there are any balancing measures or sort of negatives of it so far? Like if people talked about or thought about it, are there any potential, there's obviously pros and cons to anything you do to having this process.
Yeah, I think one of the cons are it takes a lot of time. So I didn't show this in the presentation, but we actually use REDCap forms to follow every single clinical data point. So that allows us to review cases in a much more granular way. We have monthly ECMO M&Ms where we present a respiratory ECMO, a cardiac ECMO, and then a transplant ECMO. And so we actually review these in depth, and it's institution wide. So I think actually Children's is invited to those. But they lead to some really good discussions because we have that data, but man, it's a lot of work to fill out that form. It's very time consuming. There is a little bit of paralysis by analysis, so sometimes you can definitely overthink it as well. And the real con is, some people are purists and they really apply to the letter of the law what the criteria are. So a good example is the mechanical ventilation greater than 7 days. I had a case where I had a trauma patient that was really intubated for their brain injury, and then they ended up getting a pneumonia and ARDS 4 days later, and they called us on disease day 5, which meant that they were intubated for 9 days. And it's like, well, that's not really in this. For me, I try to say, well, what's in the spirit of that rule? And it's really the duration of mechanical ventilation from the point of lung injury. But I have partners that disagree with me on that. So that's definitely a con. And we don't have ironclad. I mean, this is where the art of medicine comes in. There's not like ironclad data to say you should do this or that in certain cases. All right. Should we wrap it up or a case? Okay. No problem. Thank you. Mm-hmm. Thank you, Tim.
Okay, staying right on track, I'd like to introduce our next guest here in person. It is Dr. Paul Waltz, MD. He is a physician here at Children's.
Thank you. Good afternoon. So I'm one of the pediatric surgeons here, and I've been tasked with talking about congenital diaphragmatic hernia and ECMO. So what I'll do is try to review ECMO and CDH, and then go into some considerations for procedures on ECMO and repairing CDH on ECMO. So congenital diaphragmatic hernia, pretty much what you would expect, is a defect in the diaphragm that results in herniation of the intra-abdominal contents into the thorax. The result of this is pulmonary hypoplasia or an impact on lung growth, abnormal pulmonary vascular development and pulmonary hypertension, and then also cardiac dysfunction. Overall, this results in about 30% of the neonatal respiratory ECMO runs. Last year in the ELSO registry for the United States, the average runtime for CDH was about 254 hours. And the overall mortality for CDH on ECMO remains high. It's still 50%. And I'll show you some trends on that. This is looking at neonatal respiratory ECMO starting in the 90s and going up to last year. And the dark blue here is CDH. So you can see a slight downtrend over the past 10 years, but still hovering around 200 to 150 ECMO runs for CDH in the United States. The next, also from the ELSO registry, I know there's a lot of numbers up here, but the far left column is just the year. The far right is percent surviving to discharge or transfer. And as I said, really no dramatic change over the past 2 decades in overall survival. So again, the pathophysiology, or what's at play here, as I mentioned, that the viscera herniating into the chest cavity, resulting in hypoplastic lungs on both the ipsa and contralateral side, abnormal pulmonary vasculature development, and then abnormal cardiac function. And all this can result in pulmonary hypertension and a very sick baby. Now, a lot of these can be detected prenatally on the anatomy scan around 20 weeks. And what that then will prompt will be some ways to try to measure the size of the defect with the hopes of perhaps risk stratifying these patients, with the thought being that measures showing a bigger or concern for larger defect would perhaps be a more severe presentation and thus higher likelihood of ECMO at time of delivery. So one of these parameters is what's called the lung-head ratio. That's what's depicted down here in the cartoon. So various ways to try to measure the size of the long contralateral to the side of the defect, and then standardizing that to the head circumference. Severe LHR would be less than 1, a mild would be greater than 1.4, and then moderate somewhere in between. More recently, that's been standardized for what's the observed to expected LHR, which is a way to try to standardize for gestational age. And again, a severe defect less than 25%, mild greater than 35%. Other things that you can look at, one of the more common things would be is this liver up or liver down. Again, just a sign that maybe a bigger defect allowing for the liver to be up in the chest, making you concerned for a more severe manifestation. And so when you look, let's just focus on the right side first. So this is ECMO utilization, and this is stratifying based on the O to E LHR. The spotted bar graphs would be for liver up or more severe, and the solid is liver down. And this is very helpful because, as I said, this is depicted prenatal or detected prenatally, and then will also generate a prenatal consult, usually to the neonatology service and to the pediatric surgery team. And so when you have this information, it can try to help set the stage for the patients as far as the families, as far as what to expect after delivery. But what's important to note here is that even for these mild, favorable, liver down populations, there's still a 15% chance of ECMO. So, any one of these prenatal consults, I'll spend some time discussing ECMO with the families, even if I think it's a very mild defect. And I think that's unlikely. There's 15% is still, not insignificant. When you go to the other end of the spectrum, a liver up severe defect, about 50% need for ECMO. And then on the left here, this is just survival. Again, as you would expect, liver up, mild defect, fairly high rate of survival. On the other end, the severe, anywhere from 40 to 50% survival. Most centers will also obtain a fetal or prenatal MRI. This can help, one, look for other associated anomalies, but then also give you some other numbers to help risk stratify. Probably the two most common would be what's the total lung volume. So you have a nice three-dimensional picture here. That's what I'm trying to show. This is a fetal MRI. You can see the lung tissue here, herniated viscera here. And so you can get a volumetric analysis of how much lung tissue is actually there, and then again standardize that to gestational age. And then you can also get a percent predicted lung volume. That's measuring the thoracic cavity, subtracting the mediastinal volume, and then trying to get a sense of how much lung is supposed to be there and how much do you actually have. And then again, as kind of goes hand in hand with the LHR data from ultrasound, more severe numbers have worse survival and higher incidence of ECMO. So what are kind of indications, contraindications? Well, the short of it is a kid that's failing maximal respiratory ventilatory support. Your next option is ECMO. So putting that on paper, what does that mean? Oxygen index is greater than 40 for 4 hours. Bad PaO2s less than 40, respiratory acidosis despite maximal ventilatory management, high vent settings, high PIFs, high MAPs on the oscillator, and refractory hypotension. Some contraindications to consider, lethal chromosomal disorders or severe associated congenital defects may be a contraindication for going on ECMO. As with irreversible brain damage or severe IVH, grade 3s or 4s, and then uncontrolled bleeding for whatever reason elsewhere obviously isn't going to get better on the circuit. Relative contraindications, and I know there's a question to Tim about sizing, less than 2 kilos, less than 34 weeks. Some of that plays into just having vessels that are big enough to get cannulas into. And then, prolonged mechanical ventilation, again, relative. Getting into a little more of the details on birth weight and gestational age. This was a study titled Cannulating the Contraindicated. So, what was thought to be contraindications for cannulation. And while possible, what the study did find is that there was a high risk of death for those with a low birth weight, less than 2 kilos. But for gestational age alone, less than 34 weeks, there is no apparent mortality difference. However, there were higher severe neurologic complications in that small gestational age or low gestational age group. Getting into VA or VV ECMO, here we tend to favor VA ECMO. That tends to be, I think, what is most common throughout the United States. But this study was a retrospective review of the ELSA registry, a little bit older, but the trends actually still kind of hold for the past decade. But here, looking at 4,000 infants with CDH, about 80% were managed with VA ECMO, 20% with VV, with a conversion rate of about 20%. So failing VV and converting to VA about 20%. These two groups were were very similar as far as risk factors such as gestational age, birth weight, pre-ECMO hemodynamics. And here's just numerical graph showing VA in blue, VV in red. And again, when you look at more recent trends, it's about the same. As you'd expect, while the mortality wasn't different, the complication profile was a little different, higher risk of neurologic complications in the VA group compared to VV. Interestingly, higher risk of renal complications in the VV group compared to VA. When you look at reasons to select VA over VV, this study is sort of a Likert scale, polling intensivists and surgeons. And really, the top issue was the size of the neck vessels for both surgeons and intensivists, being concerned that they wouldn't be able to get a larger VV cannula into a internal jugular vein. This is a relatively recent study out of Nationwide. They just detailed their experience with the Crescent RA, which is one of the VV cannulas available. They reviewed several cases of pediatric ECMO managed with VV with the Crescent RA, but within this, they did have 2 CDH patients, fairly robust size. The first one was 3.9 kilos, 40 weeker. The second one was 3.7, 38 weeker. But they did have successful management with the Crescent RA cannula. This is just a chest X-ray, what that cannula looks like. The benefit here is that you don't have to be in a bicaval position. You could be in the right atrium and get good flows. So now changing gears a little bit, now that you end up on ECMO with a CDH, what do you do now? Should you repair within a couple days after cannulation? Should you repair several days into the cannulation, or should you try to decannulate the baby, get through the ECMO run? This is a bit of a debated area, and there's no clear-cut answer. There's been a host of recent studies that have looked into this, and I think the bottom line is that there definitely is a population that's going to benefit from an early repair on ECMO, and there's probably a population that ends up on ECMO and would be predicted to get through that ECMO run and then get repaired after ECMO without the inherent risks of bleeding and dealing with the circuit. This recent study out of Michigan has what they have what's called this hybrid approach, which some other centers also follow. And the short of it is you go back to those prenatal predictors that we talked about earlier. And if you have a really severe defect, there's probably a high likelihood of ECMO, and there's a good chance that that's going to be a long ECMO run. And so that cohort may benefit from having an early repair on ECMO so that the CDH is addressed. You now have space in the chest, and hopefully now you can just focus on trying to manage the circuit and wait for the lungs to get to a point where the baby's going to be able to come off ECMO. At the other end, if you have one of these more mild defects, as I said, even the most mild liver down, still 50% chance of being on ECMO. That baby may still have enough lung tissue, for whatever reason, they flipped into a pulmonary hypertensive crisis that you couldn't break and you got on ECMO. But now they've settled out and are improving. Well, maybe you can get through the run of ECMO and then repair them after. how to repair on ECMO or how to do any procedure on ECMO. Well, obviously, you're balancing this risk of anticoagulation and bleeding because you don't want to have clots in the circuit, but at the same time, you're operating on a patient and you want to have clotting in the patient. And so how do you manage that? Obviously, it's going to take a buy-in and discussion from all the stakeholders. There's not enough hands here and there's not enough labels for who all's involved. But you need to make sure that the surgeons, the anesthesia team, the intensivists, the family, the pharmacy, nurses, perfusion, respiratory, everyone's all on the same page. And what the plan is before the surgery, how you're going to manage the circuit, what you're going to do intraoperatively, and what you're going to do postoperatively. Here we have a protocol that we've typed on the paper and that we can print out and pull up anytime that we're embarking on this, so that it's clear what to expect for these patients. Some options or ways to manage anticoagulation on while repairing on ECMO. This is out of Cincinnati. Really, the point of this study was actually to compare their bleeding complications between two different ways to repair CDH, autologous muscle flap versus a prosthetic patch. But what I like about this paper is that they nicely detailed their management of heparin preoperatively and intraoperatively. And so they shot for a goal of platelets over 100, 10A of 0.3 to 0.7, fibrinogen greater than 150, and an INR less than 1.5. They commonly used Amicar, which we'll talk about, and then they titrated their heparin based on bleeding intraoperatively. And what they showed here, no difference between bleeding between the two ways of repair, but also overall kind of a low risk of reoperation for bleeding, 7 to 12%, and no difference in blood transfusion between the groups. So what is Amicar? It's a fibrinolysis inhibitor. This was the early report on this, looking at using this as an adjunct to help minimize bleeding, comparing Boston Children's to the ELSA registry. And basically what they found was when they utilized Amicar as a bolus and then as a drip throughout the ECMO run or the perioperative phase, there was significant decrease in surgical site bleeding, and this was really apparent in cardiac patients. The other agent that you may see utilized is TXA, or tranexamic acid. It's another fibrinolysis inhibitor. This was one of the initial studies on that, again, showing a decrease in intraoperative and postoperative transfusion requirements for those patients that required that received TXA. Outside of heparin, some centers have had very good results with bivalirudin. I just put this here as a reference in case that's what your center uses, and you want to see what some protocols may look like for that, for embarking on procedures on ECMO with bival. But again, pretty good results here. They have a major bleeding of 15 out of their 38, but they categorize that as a hemoglobin drop of greater than 2 within a 24-hour period. But no one had fatal bleeding, no one had non-surgical bleeding in a critical area, and no one required re-intervention for bleeding. So pretty good results here with this protocol for bival. So again, what are some tips? I'll try to wrap up here, just for embarking on procedures on ECMO or CDH repair on ECMO. Well, one is, can you come off ECMO, and how urgent is the procedure? Obviously, if you don't have to deal with the circuit, get rid of it. If you are about to do a procedure, assess the circuit, make sure you have a baseline for any clot burden, how the oxygenator looks, how your cannulas look. Do you have a backup? Do you have a circuit ready for exchange if you need to? Again, have a plan to adjust the anticoagulation. Are you going to use adjuncts like TXA or Amicar? Make sure you have blood products available. Intraoperatively, there's a variety of topical agents that can be used as adjuncts for hemostasis. Consider leaving the chest or abdomen open so that you can detect and address any bleeding, and obviously monitor the patient postoperatively very closely. So again, it's a balance between keeping the circuit happy and keeping the surgical field dry. So again, just to conclude, CDH is a common indication for respiratory neonatal ECMO, and there remains a high associated mortality. CDH can be repaired on ECMO. Consider stratifying this based on severity. Make sure you have a plan before embarking on any procedures while on ECMO. That's it.
All right. Thank you, Dr. Waltz. We appreciate it. Our next speaker, you've seen her, I guess, virtually. Now she's in person. It's Dr. Norma Kim Campbell, and she's going to talk about pediatric ECMO patients, respiratory. Thanks, Norma.
All right. Well, thanks for having me again. So this topic, I thought actually was a really difficult topic to talk about because patient selection for respiratory failure, it's pretty well documented what we consider to be really severe respiratory failure, and, might not be that difficult to decide who goes on. It's more difficult to decide if a person should be a candidate if you look beyond just the numbers of pediatric ARDS. So that question is actually really difficult. So I'm going to start by showing you this slide. So here, these are 3 real patients. All 3 of them qualify for pediatric ARDS. And so if you looked at these x-rays and you looked at their reason for having pediatric ARDS, look at their event settings, can you predict, looking at these x-rays, who would survive ECMO or who would survive to hospital discharge? So it's a very difficult question, right? Because all of these x-rays, some of them actually don't necessarily look terrible, but some of them do. And does that mean that these patients are not a good candidate because they're sicker when at the time of going on ECMO? So these x-rays are all their last x-ray prior to cannulation. These are all their gases just prior to cannulation. So this first one, they all meet criteria for pediatric ARDS. This first one had rhinoenterovirus and a staph epi pneumonia. Pretty high vent pressures, 41/13, FiO2 of 1. SATs are in the 70s. They didn't have, this patient got cannulated right when they got admitted, so did not have an arterial line at the moment. So you have a VBG with a CO2 of 101. And if you calculate the OSI, it meets criteria for severe PARDS. So OSI is a different way. If you don't have an arterial line, you don't have a PO2, you can use SATs. You can calculate an OSI. So an OSI of 30 is severe pediatric ARDS. The second one, again, also qualifies as severe pediatric ARDS, influenza, necrotizing MRSA pneumonia. Vent pressures are also high, little high peeps. This one's on nitric. SATs are also 70s, 80s. This one has an EBG. Again, pretty acidotic with an OI of 36 and PF ratio of 55. And then this last one had human metapneumovirus infection, status asthmaticus, SIMV, pressure control again. And these pressures are not that huge, 30/6, FiO2 of 1. SATs are in the 80s, ABG with the pH of 719. This OI is 18, PF ratio is 72. So is this like a trick question? Did all of these patients survive, or did all of them not survive? What if I told you that this first patient is a 17-month-old male with a history of tetralogy repaired, with cerebral malformations, a low conus, seizures, an optic nerve hypoplasia, central hypothyroidism, a volvulus repair that made him G-tube and TPN dependent? So that's a lot of comorbidities. Is this a good patient? Should we put this patient on? Or the second one, she X-ray doesn't look that great, but her history is only, I can't get this forward, give me a second. She's a 4-year-old female with just asthma. She's previously healthy, just had asthma. So is this, with her history, no comorbidities, no matter what it is, do we put someone like that on? And then the third patient, 4-year-old male with a history of Prune belly syndrome, he had some chronic kidney disease, some mild pulmonary hypoplasia, but he also had the lowest vent settings. So which one of these patients, should they all be on ECMO? Can you predict at all? And if you can't predict, then should we be making that decision at all? So that is the question that is, I think, difficult for most people. Right, I cannot get this to. All right. So the ELSA registry, if you look at this is, I just pulled this yesterday. Just kind of looking at where are we in pediatric ECMO, there we go. Pediatric ECMO. So, survival rates for pediatric pulmonary ECMO are actually not that bad, 63%. And it's actually better than cardiac, better than ECPR. And across the board, whether or not you're a neonate, pediatric, and adult, pulmonary patients tend to do better. So this is just a review because I talked about this earlier in the day. So there's a few slides just to remind you about ECMO, why we're doing it, and the criteria to meet for respiratory failure. So ECMO for respiratory failure, really you're just trying to support gas exchange. You're using too high vent pressures, you're failing your conventional therapies, you have a high predicted mortality. And then the PALIC conference in 2023 basically say that if you have a reversible cause of severe pediatric ARDS, you should be evaluated for ECMO. And you should look at people as a serial evaluation, not just a single time point. So the goals of ECMO is, again, very simple. You're trying to bridge to recovery or lung transplant. You want to try to prevent an irreversible hypoxic or hypercapnic injury, and you want to reduce your ventilator-induced lung injury. So it's really three simple kind of concepts we think about in pediatric respiratory ECMO. So the things that you can use to calculate, like how bad are these lungs? Oxygenation index, which you hear people talk about all the time. An OI greater than 40 is associated with higher mortality. But severe pediatric ARDS, the criteria to meet that is an OI of 16, just so you know. So you don't really have to be that high for people to consider you for ECMO. And then the PF ratio. So you have acute lung injury, less than 300. If your PF ratio is less than 300, you meet criteria for ARDS if your PF ratio is less than 200. So also criteria, again, OI greater than 40, PF ratio less than 60 to 80, lack of response to mechanical ventilation, elevated vent pressures with high mean airway pressures, or evidence of barotrauma. So we talked earlier about the A gradient that kind of shows your diffusion defect, the shunting, where you may have consolidated alveoli that are perfused but not ventilated, your shunt fractions that you can calculate to determine how bad this situation is. So the pediatric ARDS, so I'm focusing really just on respiratory patients. We're not talking about patients that need ECMO for cardiac indications or hemodynamic compromise or ECPR or any of those things. It's just literally patients whose lungs are not working that need some extra support. So the pediatric ARDS, this is the summary of the second international guidelines of the diagnosis management of pediatric ARDS, the PALIC 2 guidelines. And so basically, to meet criteria for having severe ARDS is you need to be greater than 1 week of life, less than 18 years. You have to have an onset within 7 days of this condition of a known clinical insult or worsening respiratory symptoms. The edema that you have on your X-ray have to be secondary to respiratory failure, not just cardiac failure or fluid overload. There's new infiltrates consistent with parenchymal disease, not just like pulmonary edema. And you don't really need bilateral opacities anymore to qualify for severe pediatric ARDS. You have mild, moderate, and severe pediatric ARDS. Most of them are listed there by OI, so OI greater than 16. They don't have, actually, I didn't put it in here, it was OSI. And so an OSI greater than 10, I believe, is a severe pediatric ARDS with a PF ratio less than 100. You do not need to be mechanically ventilated and invasively to meet criteria for pediatric ARDS. You can meet that criteria just with non-invasive ventilation. So as long as your PEEP is greater than 5 and your SF ratio, so instead of PF, they use SATs, and FiO2 less than 264 defines your pediatric ARDS. This doesn't count chronic lung disease exacerbations, cardiogenic pulmonary edema, congenital abnormalities interfering with your lung parenchyma. Again, like for these criteria, you can use OSI and the SF ratio, which is different than some of the ARDS criteria. This is for patients that don't have an arterial line. And then the severity assessment is made in the first 24 hours after meeting your pediatric ARDS criteria. Despite all this, there's actually no evidence to support strict criteria for the selection of patients who will benefit from ECMO in pediatric ARDS. And so that makes patient selection a little bit difficult. So people have been I forgot I put this in here. So ventilation failure as well. So this is also another reason to go on ECMO for respiratory failure if you have a compliance issue or hypercarbia and acidosis that goes along with it. Okay, so good practice statements from the Pellet Conference. When it comes to ECMO, they tend to be very vague, not very directed. But basically, if you have a severe pediatric ARDS that with a potentially reversible cause, you should consider ECMO. When your lung strategies result in inadequate gas exchange, you should be evaluating your patients serially and not just in a single time point. And then your decision to institute ECMO should be based on a variety of things. And it shouldn't be a single person, it should be an expert team. You have evaluation of your institutional case history and what you're comfortable with and your experience. There are some centers that will put on patients that are sicker than other centers would, but that's just an institutional kind of comfort. And then they also suggest that you use VV ECMO over VA ECMO in patients with isolated pediatric ARDS who do not have inadequate cardiac function. All right, contraindications. This is where we kind of go into where I started looking into, are there patients that we should be saying should not be offered ECMO because of whatever criteria they have that will portend like a poor prognosis, maybe use of resources that maybe should not be offered. And so the difficulty I think with respiratory failure is that a lot of these patients end up on ECMO for a long period of time. So if you have true ARDS, sometimes you can be on ECMO for weeks, sometimes months. So it's very difficult to determine who that patient will be at the end of 2 or 3 months that will be able to decant from ECMO and survive hospital discharge. So when you look at contraindications that people consider, they're more relative nowadays than they are absolute, where you're balancing risks versus the potential benefits of using these valuable resources that we have. So some of the more relative to absolute contraindications are when you have unacceptable physical and mental impairment despite survival. We have pre-existing conditions that affect the quality of life, and that would significantly be impacted regardless of ECMO. So lethal chromosomal abnormalities, poor CNS status, and end-stage malignancy, bone marrow transplants with chronic pulmonary infiltrates. The age and size of patient, and this one I think is also very relative, depending on your institution and how comfortable your cannulators are in getting cannulas in patients of various sizes, or futility. So if a patient's too sick or been on conventional therapy for a really long time or have a fatal diagnosis and you don't really see an endpoint to ECMO, or they're already kind of, as Tim was telling me before, like moribund, he likes that word, the moribund, the adult world uses that word quite a bit. Those are being things to make you pause about whether or not you should put a child on ECMO. So unfortunately, there are no pediatric randomized clinical trials of ECMO just because we just don't have the numbers. But there are a lot of guidelines and observational studies and various prediction models that people have looked at and tried to validate. So some of the things that have come across as predictors of poor outcome, and these are all associations. None of these are, randomized trials. So you have to take that with a grain of salt. But if you have a pre-ECMO cardiac arrest, mechanical ventilation greater than 14 days, if you have severe acidosis, a multi-organ failure, so either renal, hepatic, any other organ would fit under this category. If you have a really high OI, greater than 40 to 50, primary immunodeficiencies, chronic immunosuppression, hepatic, hematopoietic cell transplants or bone marrow transplants, sepsis, fungal pneumonias, pertussis, like those kinds of conditions. And then also if you have a low institutional ECMO volume. And this is actually kind of interesting because this one paper suggested that in neonates and adults, that seems to be a factor, but not in pediatrics. So, I mean, again, these are all observational studies, so that's probably why you have that. All right, so the one things that I did want to talk about a little bit to maybe this is really more not to direct whether or not you determine if someone's a candidate, but it's just a risk stratification strategy. So prediction scores to basically give you an idea of what is the risk of mortality for these patients. So there are two scores that are used and validated in pediatrics. One is and this is only for pediatric respiratory failure. So I'm not talking about any of the cardiac scores, the other scores, it's just respiratory. The PPREP, and the population for that is patients greater than 7 days, less than 18 years. Key variables are ECMO mode, ventilation duration, hypoxia diagnosis, comorbidities. And this one actually takes into account multi-organ failure, which Ped Rescuers, the original one, does not. So the Ped Rescuers is pediatric respiratory ECMO, not including neonates. And then certain variables such as pH, PCO2, intubation hours, center hours, ventilator, MAP, Milner diagnosis. The original Ped Rescuer score, the one that was published in 2016 that was validated, doesn't include multi-organ issues and had a very interesting association of higher CO2 with better outcomes. And so they kind of redid it. They haven't actually validated or published it as a prediction measure that can be used, but they redid it in 2019 and they added liver failure and lactate. And with that, they had better AUC or discrimination. So the problem with these scores, why you can't use them for ECMO candidacy, is because their discrimination is not very good. It's like moderate. So your AUC is only 0.69, 0.68. So it just shows that there's a lot of factors that they're not taking into account when they're making these prediction scores. So just going over them a little more in depth, because they are kind of useful though, if you look at them, because some of the things that they're categorizing are things that you would consider about when you're thinking about your patient, whether or not they would be a good ECMO candidate. So in the Ped Rescuer score, and this is the 2016 version, not the 19 version, if you're less than a year, you get positive points. So positive points is bad. The higher your points are, the higher your mortality risk is. If you're immunocompromised for any reason, it's actually a very markedly higher risk. If your primary diagnosis is sepsis, pneumonia, aspiration, then you get more points because obviously that's going to be more problematic than asthma or trauma. If your pre-ECMO pH is very low and you have severe acidosis, if your PCO2 is greater than 100, which is refractory hypercapnia, if you have a very high mean airway pressure, which very much indicates that you have some severe lung injury, if your FiO2 is greater than 0.9, that means your hypoxemia is pretty severe as well. If your duration of mechanical ventilation before ECMO is greater than or equal to 7 days, I think nowadays people think of 14 days as kind of the cutoff of poor prognosis, but prolonged ventilation just means you have sicker lungs. If you have vasoactive infusion use of any kind, that shows that your respiratory failure has led to cardiovascular instability. And then obviously if you have any kind of neurologic dysfunction, which just means that your neurologic reserve is not very good. When they redid the score in the 2019, this one is actually published in ASAIO, but it's not validated, I believe. They added renal, hepatic, and neurologic dysfunction. And with that, the discrimination improved to 0.76. So that and the lactate that they improved really helped the calibration of the score. So multi-organ failure has a pretty significant role. And then the PPREP is a pediatric pulmonary rescue with ECMO prediction, scoring, and mortality. And this is the one that includes indicators that more represent comorbidities or multi-organ failure, so such as renal or hepatic dysfunction. So you get more points if you have more comorbidities or more organ dysfunction, and anything greater than 2, you get the maximum amount of points. Similar types of things, so pre-ECMO cardiac arrest, your ventilation duration, oxygen index, your diagnosis, ECMO mode. So here is also their derivation, external validation is also not very good, it's 0.66, so you have to take these with a little bit greater salt as well. So when to use the ECMO mortality prediction scores, And so these are, it's kind of interesting, like people will use these when you do ECMO research. It's one of the like measures that you can look at to just stratify people. But the PEAS rescue score is calculated right before ECMO initiation. So it's a one-time score that you calculate and you collect your variables within 6 hours of cannulation. So it's more of a risk assessment score. The P-PREP score is calculated right after ECMO initiation, so post-cannulation within the first few hours of ECMO. This is a little bit more of a prognostication score. But then again, you know, the AUC is not that robust. So again, there's definitely factors that they're not taking into account. And so this just kind of really highlights the fact that we really don't know who's going to be a great candidate. And we don't know who won't necessarily. You might have some ideas, but it's kind of difficult when you don't have any benchmarks to make that decision for a patient. So I'm going back to these patients. Again, these are real patients. So if you were to look at these, I should have had like a audience thing, but the one that people I think most of you would say, you know, would definitely put on and might have a chance of survival is this one in the middle, right? Because she's just 4-year-old female with history of asthma. It was unlucky, got the flu and pneumonia. And so I would say you're right. I mean, that one's predictable, right? She survived a hospital discharge. Then the other two, the one on the left, she's really high vent pressures, has a bunch of comorbidities, you know, has a volvulus, is like a short gut, TPN dependent. This is definitely an organ dysfunction, obviously has some neuro baseline comorbidities. Is this someone, those kinds of pressures, like OSI of 30, severe pediatric ARDS, is this someone that you would offer ECMO to? Would you put this patient on ECMO? And then how long would you give this person, right? And so this person actually did go on ECMO and survived hospital discharge. So if you are thinking, oh, this is maybe someone that I wouldn't put on, I mean, do you really know? So that's the problem, right? And then this last one here. So again, human metapneumovirus with status asthmaticus. Pressures don't look that horrible, right? Obviously not ventilating very well, not oxygenating all that great. Might have some underlying issues with mild pulmonary hyperplasia, but you know, maybe you would offer this patient ECMO. Seems like he would do okay, right? But this is the one that was a terminal wean for futility. He was on for months, and it was you know, he actually had a terminal wean for futility and then did get an autopsy, and it was very clear that all of his lung parenchyma were really destroyed, and there was no hope for it. And this is a patient that we did reach out to multiple centers to see if anyone would be willing to transplant. He was not a transplant candidate, so that's why there was a terminal wean. So I'm hoping that this talk will kind of give you some key points. So the first one is that obviously lung remodeling and recovery can take weeks to months. We all know that. We know that in respiratory ECMO. When we go on for respiratory ECMO, pediatric ARDS, we know it's going to be a long run. We prepare for that. But there's insufficient data to definitively guide candidate decisions in pediatric respiratory ECMO. Like pediatric lungs have real potential to recover. They, you know, if you're a baby, the group grow new lung tissue, you know, those BPD patients that eventually wean on their ventilators and decan, they have a lot of potential to improve. And so that's one of the things that makes it a little more difficult, I think, in the pediatric world. Decision-making remains individualized and integrates physiology, trajectory, institutional experience. And then the reason why it's so difficult is because, one, there's no prospective or randomized trials in children, which define which patients should or should not be offered ECMO. The existing prognostic models are risk adjustment or benchmarking tools. They're not really decision-making tools. So we don't really have a decision-making tool. The diseases that lead to pediatric respiratory ECMO are very heterogeneous. So you have the infections, but you also have the infections related to comorbid and comorbidities, or sometimes it's just the comorbidities that lead to pediatric ARDS. So you can't really generalize outcomes because it's so heterogeneous. The ELSO guidelines, they really emphasize individual multidisciplinary evaluation rather than very strict numeric thresholds. Those are very gray areas sometimes. And then even the observational registry data suggests survival even in some of those high-risk groups. So patients that are ventilated for greater than 14 days, high OI, and immunocompromised status, there's no absolute cutoff. So is this something that we should be determining? Or do you give these patients a chance? And so that's a difficult question. And I think the only way to really get around this is if you do put someone on for ECMO that you're not sure would have a good survival, chance of survival, then the decision, even if you make it, the communication with the family is the most important thing. So, giving the advice or the letting them know that there are times that you're going to have to decide to take the patient off for futility or for no improvement in their lung physiology. And I believe that's my last slide. Thank you.
Thank you, Norma. We appreciate it. Twice in one day, virtual and in person. We appreciate that. All right, we're staying right on track here. Our next speaker, a physician here at UPMC Children's for oncology. It is Dr. Scott Meyer. Thank you, sir.
Right here.
He's
Yeah.
right here.
Thanks, man.
Thank you.
Hi, everybody. How are you? Thank you for having me. So we're going to talk about ECMO and pediatric oncology and what should be considered. I want to give a special shout out to Tim for helping me think about this and put it together. So thank you very much. So once upon a time, not too long ago, having a malignancy was a relative contraindication for ECMO. And in fact, where I trained in my fellowship more years ago than I care to admit, at a charitable hospital in the South that many of you have seen commercials for and infomercials for, we didn't even offer ECMO because it was not really thought that it was appropriate for pediatric stem cell transplant patients or pediatric oncology patients. So for the rare patient that we thought it might be indicated for, they would go over to the local children's hospital. We did not have any ECMO capabilities. But you PICU doctors are really, really, really darn good at what you do. And the outcomes for kids with malignancy have changed with advancements in critical care medicine. And so that attitude is sort of changing. And I would love to tell you that there is a ton of data to guide decision-making about ECMO in children with cancer. And the answer to that is there's absolutely no data to guide you. And so I'm going to talk a little bit about what is out there. But the conclusion of the papers that I was able to track down was basically that outcomes on ECMO in children with malignancy have improved over the last several years and should be considered carefully. So there you go. Cliff's notes for you. Let me advance the slide here. So here's a beautiful picture of acute myelogenous leukemia because I love pictures of blood cells. The thing that's different about pediatric oncology and adult oncology. And so trying to apply adult medicine logic to this just doesn't work because outcomes in pediatric cancer are way better than outcomes in adults. So 80% of all comers to pediatric oncology will become long-term survivors. That is in contrast to about 25 to 30% of adults with cancer will become long-term survivors. And so that is something to keep in mind. And the improved outcomes are a result of multiple factors. So one, we have improved outcomes in pediatric oncology over the last 30 years through dose intensification. We give kids doses of chemotherapy that would kill an adult, no problems, no questions asked. But because they have really good livers and really good kidneys and other good organ function, we can give them really high doses of chemotherapy and get better tumor responses. Clinical trial access. So about 70% of children will go on a clinical trial in order to treat their cancer in an upfront way, which is very different than adult oncology, which is less than 20%. And so we've made great strides in pediatric oncology because we've given access to clinical trials, and that's really changed the outcomes. And then we've had improved risk stratification and improved supportive care. So the use of prophylactic antibiotics, improvements in ICU care, antiemetics, nutrition, and technology advancements have all led to a massive shift. In 1960, the cure rate, the 5-year overall survival for acute lymphoblastic leukemia was 4%. The most recent study showed us that we are sitting at about 98%. with the introduction of blinatumomab. So we've made massive improvements, and it's for all of these reasons. The flip side of this is, because a lot of our success comes from dose intensification, we have a lot more kids who get organ dysfunction, organ failure, and land in your ICU. And that means that there are more patients who might present with ARDS and need to have consideration of ECMO. So a lot of times people, when they ask me, and I've been asked several times in my career, if I think this kid is a candidate for ECMO, a lot of times it comes down to, well, what is this kid's prognosis, right? And the thing that I want to say is any oncologist that has passed their boards, you spit out a name of a tumor to them and they can tell you what the 5-year overall survival is for it, right? But what we need to remember is that those numbers don't apply to kids that you are considering for ECMO, especially upfront, because those kids would have never been eligible for the clinical trial that you are quoting, right? Now, during therapy, that's a different story. Those kids would be included in that number. But upfront, if you've got a really sick kid that's not received a drop of chemotherapy, and I tell you, well, the cure rate of this is 80% at 5 years, I'm not talking about the patient who presents with like gigantic pulmonary nodules that means that they wouldn't even be eligible for that clinical trial, right? So one thing to keep in mind. But prognosis depends on a couple of different factors because it is important. I don't want to poo-poo it. But there are disease-related factors. So cancer type. Name me a cancer, as I said, I can list you out the 5-year overall survival for it. Whether the tumor is localized versus metastatic. Localized osteosarcoma has a 5-year overall survival about 75%. Metastatic osteosarcoma, 20%. Big difference. Tumor histology, immunohistochemistry, and cytogenetics are all things that we factor in. And then responsiveness to chemotherapy, amenability to surgery, and radiosensitivity are all other factors that sort of lead to whatever the prognostic information I can give you. There are patient-related factors that relate to prognosis. So underlying genetic syndromes. Is this a kid with Leigh-Fraumeni syndrome who is going to get, multiple cancers? You give me the exact loci of the TP53 mutation in Leigh-Fraumeni, and I can tell you with pretty darn good accuracy how long that kid's going to live. Age is another thing. Our older patients tend to have worse prognosis than our younger patients. And when I say older, I mean greater than 12. And then health status outside of their cancer diagnosis. So what are their comorbidities? Just like you consider with PICU patients and things like that, those things are all factored in. And then there's social determinants of health that I don't want to ignore. So the patient's ability to comply with therapy is one and something that I'll talk to you about. Access to care, race, and socioeconomic factors. It's just a fact that white children have higher cure rates than Black and Hispanic patients. And that has to do with a lot of social determinants of healthcare. So data to support ECMO use in children with cancer. I've given you a picture of a nicely wrapped present that is absolutely empty inside because there's not a lot of data to guide us here. But the one paper that I included in a packet to Merit that can be shared with all of you was out of Europe. And they did a meta-analysis of 13 different studies with 625 different kids with cancer who went on ECMO across Europe. And they, of these pooled studies, they had, so first of all, the indication for all of the patients was pediatric ARDS. They looked at all of the patients and there was a 55% mortality rate, which is slightly higher than the average pediatric registry data, which in their paper, they quoted at 44%. If you guys have different numbers, I just got it from that paper. And the range of time on pump was anywhere from 1 to 72 days, and they had very little data on cancer type, presence of remission or treatment in their data pool, which was kind of disappointing because I think those are the things that we would think would lead us and help us to decide who is helpful. And then complications were experienced by about 65% of the pooled subjects, hemorrhage, new infection, and requirement of CRRT or cannula-associated complications. They were all fairly similar to kids who were not did not have cancer when they compared it to the ELSO registry data. And I just want to note that there are the limitation section in the discussion for this paper is about 3 paragraphs long because there's a lot of limitations to using pooled data in this manner. I will say there were some studies that had outsized effect on the data. They actually took those out in a secondary analysis and got the exact same pretty much the exact same numbers. And so I think we can glean something from this data, but I think at the end of the day, it's going to be coming down to a conversation about what's best for a patient. So I think as I was thinking about it, and as Tim and I were talking about it, I think that there's probably 4 different categories of patients with cancer who you need to consider when you're thinking, is ECMO indicated? And I think the first thing to think of is the newly diagnosed patient. Second would be patients who are in remission but are still immunocompromised and on therapy. Patients with relapsed or refractory disease who are having a complication related to their chemotherapy, like a treatment-related morbidity, but not due to their cancer. And then you've got patients with progressive cancer leading to the reason for ECMO consideration. And I think if you separate them into those categories, it gives you a little bit of a clearer space of how I might consider the risk-benefit ratio of offering ECMO or the futility of offering ECMO. I would offer that in the last category, where cancer is leading to ARDS and it's progressive in nature and refractory to therapy, the ECMO is probably not a great thing to offer a patient like that. Whereas patients in the top 2 categories may be patients that you'd be more likely to issue ECMO to. So there's a couple of patients patient examples that I've been asked in my career to think about ECMO for. The first was a 5-year-old little girl who presented with widely metastatic Wilms tumor. Her chest CT had, I'm not exaggerating when I say over 100 different pulmonary nodules, and it's the worst CT I think I've ever seen. And she came in with respiratory failure and had sort of progressed to high frequency oscillatory ventilation and was on 100% FiO2. And the ICU attending said to me, she's getting real close to thinking about ECMO. What do you think? And, I did what any good oncologist would do. And I said, well, the 5-year overall survival for widely metastatic Wilms tumor is 80%. And even with a scan this bad, I think the chances that we could cure her with chemotherapy and radiation are very, very high. And that definitely played into it. She had no other comorbidity. She was an otherwise healthy child. She fortunately did not require ECMO. We started emergency chemotherapy. And that was the other thing is I said, we're going to start chemotherapy and I expect her to respond very quickly to it. And we started chemotherapy that night, the same day that she came in. And she responded extremely quickly to it and did not end up needing ECMO. And she is now a teenager who rides horses and is in regular school and high school and things like that, 10 years out from this thing. The other patient was just 2 weeks ago. I was asked, there a young man who, God bless him, didn't take his Bactrim prophylaxis, has leukemia in remission and has PJP pneumonia and was not ventilating well and prone in your unit. And the question was, if this keeps getting worse the way that it's been getting worse over the last 3 hours, would you consider ECMO for this child? And, my answer to that was, so he falls in that second category, patients who are in remission, but still immunocompromised due to ongoing therapy. And my answer was, at this point, from his disease, there is a less than 2% chance that he will not survive his cancer. And that played heavily in the decision. He also, fortunately, did not go on to require ECMO. But these are the times when I've been asked to sort of consider these things. And that was my thought process as an oncologist talking to an ICU doctor, which brings me to my next point. And I just need to say that this is not based off of data. These are Scott Mauer's opinion. And so you are getting Scott Mauer's opinion. And with some help from Tim. So I feel very strongly that no single person should be the person who is making a decision about whether or not to offer, I'm saying offer first, ECMO. I think that this needs to be a discussion between the critical care doctor, the oncologist, and any other relevant organ system specialist who can help us think about the whole patient and whether or not we think that the risk-benefit futility ratio for ECMO in this patient is in our favor. And I think it helps to think about what category that patient is in, at least for me as an oncologist. The next thing is maybe a little bit into the ethical sphere of things, but just thinking about I say that with an ethicist in the room, thinking about the idea of making a recommendation versus patient autonomy. A lot of times it's easy for us to cop out and say, well, what does the family want? And we'll just do whatever it is that they want, right? I would say that there are very few families that want their child to die. So I think that the decision to offer ECMO is a medical provider decision, and that we have a responsibility to not offer ECMO to patients we think it could harm or would be completely futile in their care. That's my opinion. It may not be shared widely, but I think that it is our responsibility to whether or not to offer something. The decision to consent to ECMO is a parental decision. So in that consent, we should think about the following questions that we need to answer for that family. What is the situation that we are facing? And what is the likelihood that we can get out of it if ECMO could buy us some more time? What is the prognosis for this child, both from their immediate illness, their acute illness, and their long-term illness? What values are leading us toward or away ECMO initiation? And we're going to need parental and caregiver input in order to do that. I would say patient input, but if you're considering ECMO for a patient, they're likely not giving you a ton of input at that point. What is the goal of ECMO therapy in the context of the overarching goals of care? So what is the big goal for this patient, which I think comes down to 4 things: cure, life prolongation without regard to quality of life prolongation with an emphasis on quality of life, or comfort. And how does ECMO fit into that grander scheme of things? And then what are our stopping points? Is this a bridging therapy? A bridge to what? What degree of risk are we willing to accept in putting this child on, and what complications or response would indicate that ECMO is no longer beneficial, and laying that out for families during the informed consent process so that it's very, very clear to them that if we have a major hemorrhage, we're coming off pump, and that it's not a surprise. I will tell you that these conversations are not easy to have, but when I meet a family with new diagnosis, a specific example, a kid with stage 4 neuroblastoma, I told the mom on day 1 that we had at the time, 40% chance of curing her child. And that if he ever relapsed, that was something that I could do to extend his life, but it was not going to be a curable situation. And so 4 years later, when he relapsed, the very first thing she said to me was, "You told me the very first day that you couldn't cure this if he relapsed. Is that still true?" And I said, yes. And he lived 6 more years with therapy and lived very well for that time. But she always knew from that moment that this was something that wasn't a curable situation. Doesn't mean I took away her hope. I didn't take away her hope, but I told her the truth. And I think that we owe people the truth and informed consent. And then I just think that our informed consent should be really clear about these factors. And that's my opinion. And those are all the things that I had for you. And I'm happy to stay and answer any questions if that's helpful. And I thank you for your time.
Scott, there are a couple of things that popped up in the chat.
Oh, okay.
We can have you answer them. And then I think too, when the panel discussion goes, maybe if you guys just lend an ear and see if it's something you want to contribute to once the panel sets in. So the first one is thoughts on candidacy for pediatric patients with HLH primary versus secondary, shock, and MODS.
Okay. Yeah. So HLH. So I think my thoughts on HLH. I think a lot of it depends on, so I did take care of a patient with primary HLH who was on ECMO in the NICU. I think in that moment, what we decided was that this patient hadn't seen any sort of disease modification therapy. The patient was already on ECMO by the time I got consulted and by the time that a diagnosis of HLH had been made. So take that into consideration. Response to therapy, I think, is the thing that I would take into account. We gave this kid therapy right away, and he responded to etoposide and steroids very, very quickly and recovered lung function very, very quickly. It was a newborn. And that kid ended up going to bone marrow transplant as a long-term survivor. So I think I have seen kids with HLH go on ECMO. Secondary HLH is a bigger question, right? So are we able to identify the cause of the secondary HLH? Oftentimes we are not. Outcomes in these kids are incredibly poor if they get to the point of acute respiratory distress syndrome. I would have a very dim view of placing a patient with secondary HLH who is at the point of requiring ECMO in order to prolong their life. I think that the outcomes there would be extremely poor. I'd definitely make that decision in consultation with a critical care doctor, but I don't think I've ever seen a child get that sick and survive from secondary HLH.
Okay, the next question is, how big of a factor is hemolysis on ECMO in a pediatric patient with leukemia or other cancer that can cause red cell destruction?
Not a factor in my mind, and we don't. So, certainly our chemotherapy will suppress bone marrow and will reduce red cell production. I think our ability to transfuse would outweigh that, and I don't think that we tend to run into problems with kids who are critically ill that we can't transfuse our way out of it. I don't recall a lot of problems with hemolysis in the children that I've treated who have been on ECMO. I'll let other ICU doctors indicate their agreement or not with that statement, but I don't see that as a major issue.
Great, thank you.
Thank you.
Thank you. Okay, our next guest, it will be, he was here in person, now he's going to be virtual. It is Burhan Mahmood calling in virtually.
Okay, thank you, Mike. Can you see my slides?
We can see them. Just go make sure you go into presentation mode.
Is that good?
Yes, sir.
Okay, all right. Well, thank you again for the opportunity to talk about patient selection criteria and indications in neonatal ECMO. And Scott gave a very nice talk about all the conundrums and all the issues with when the diagnosis is not very clear. You worry about ECMO complications, and the conduct of ECMO communication with the families is very important. So the diagnosis of severe, let me just minimize it. A severe, potentially reversible cardiorespiratory failure is not straightforward, especially when it comes to babies. And as I mentioned in the talk in the morning, the usual indications for ECMO that have traditionally, historically been around, like pulmonary hypertension, meconium aspiration, pneumonia, they are less and less in the last couple of decades, and we are having more complex patients who are sicker with multi-organ dysfunction who are now requiring ECMO. So it is becoming difficult in those kind of patients to figure out the likelihood of a good outcome. We have a variety of indices, as I mentioned earlier, to identify neonates of the high probability of death if conventional therapy is continued. And timing of referral to an ECMO center is also critical for good outcome. So if there is a center that does not have ECMO support, but there is a patient who is going into worsening cardiorespiratory failure, and the transfer to an ECMO center early is better and can ensure good outcomes. I just wanted to put that out there. And then obviously evaluation of risk versus benefits have to be reviewed and discussed with the family. I showed that slide in the morning. We have the usual cardiorespiratory entry criteria. Most of the babies who come in as an ECMO referral have cardiorespiratory failure. We follow the same paradigm. How bad is the hypoxemia, how severe is the acidosis and hemodynamic dysfunction. And that's been the bread and butter of trying to figure out who to place on ECMO if things are worse from the gas exchange standpoint and from hemodynamic standpoint. I thought this was an interesting criteria that was just reported in June of this year, the oxygen OSI saturation index. I don't know if some of you may be familiar with it. So there can be situations, especially if it's an older infant, not a newborn baby who doesn't have an arterial line, how do you calculate an oxygenation index? Because for that, you need an arterial PO2. So OSI can be useful adjunct to OI for assessing neonatal respiratory failure and could be beneficial when arterial sampling is impractical. So this study that came out of Kentucky Children's Hospital looked at 10 years of data where they analyzed and compared OI and OSI values in the 12-hour preceding to ECMO. And they were able to figure out a cutoff for OSI of about 17. And as you can see from this table, as the oxygenation index started to get worse from 15 to 30, the OSI also increased from about 12 to 17. And they mentioned in their paper that a level in this range of 16 to 18 could be considered as a sign of severe respiratory failure if you do not have an arterial access. So I just wanted to showcase this because, we have so many ways to figure things out when a baby is not getting better. And this was just published a few months ago, about the utility of doing something like this if an arterial access is not possible. So it kind of like adds to the cardiorespiratory criteria for neonatal respiratory ECMO. I showed you these exclusion criteria this morning as well: prematurity, low birth weight, some concerns of congenital anomalies, genetic diagnoses, neuroinjury, metabolic disease, irreversible lung disease. And some of these criteria are absolute. Obviously, if there's a clear-cut pre-ECMO diagnosis of a lethal genetic condition or evidence of irreversible neuro damage or metabolic disease that is not going to have a very long outcome, then obviously ECMO, which is a reversible therapy for reversible disease process, is not going to change that underlying diagnosis. But sometimes it is hard to figure these things out, and ECMO may be used as a bridge while the diagnostic evaluation is being undertaken. And that's where things are nowadays, because we are seeing more and more complex babies who have multi-organ dysfunction with multiple diagnoses and disease processes who go into a crisis. ECMO can save their life while we are figuring out whether they can survive their condition. I'm going to focus for the sake of this talk on these 6 categories. We'll talk about prematurity, low birth weight, lung disease in the context of chronic lung disease, and pulmonary hyperplasia, and in the context of congenital anomaly of renal origin. And we'll also touch base from the genetic standpoint, trisomy 13 and trisomy 18. There has been some recent statements by the American Academy of Pediatrics about that as well. And then I'll briefly touch on metabolic disease. And what I'm going to do is I'm just going to review the literature in the last 10 years of what the studies are showing, because there are no clear-cut guidelines. And different centers have different approaches. But I wanted to showcase what is the evidence out there for all these different conditions. So gestation-related size has historically been contraindicated, for babies who are less than 34 weeks and less than 2 kilograms, that ECMO can be fraught with complications like intracranial hemorrhage and neuroinjury. And morbidity, mortality has been a concern. But some of the latest data and research is suggesting that maybe there is a meaningful survival benefit in these small babies when you put them on ECMO. Studies demonstrate acceptable safety and survival in low birth weight. These are babies less than 2 kilograms and premature infant and units managed on ECMO with survival as much as 25 to 45% in this cohort. So this study, which was published in 2014, and most of the studies that I'm going to show you are a big database analysis from the ELSO, which is the Extracorporeal Life Support Organization. They maintain a registry of data from ECMO centers. So this study looked at patients and neonates less than 30 days from 2001 to 2010. Their youngest age, where they divided the age groups gestation-wise, was 35 weeks. And they compared babies who were placed on ECMO at less than 7 days of age and more than 7 days of age. And you can see a chunk of the patients were less than a week old. And from these graphs, you can see that babies who were less than 35 weeks, they had a greater risk of mortality and a greater risk of intracranial hemorrhage, and that risk goes down with maturity. But I think what's also interesting is that if you look at the mortality percentage, it is little more than 40% for less than 35 weeks, and the risk of intracranial hemorrhage is less than 30%. So is that severe enough to say no to ECMO? Now, again, this study was in 2014, and they only were commenting on 35-week infants, and we are talking about putting patients at 34 weeks. So let's look at the next one, which was published in 2017 out of Michigan, where again they looked at the ELSO registry database, and they reported a 54% survival for a cohort of 29 to 34-week infants. And this data was from 1976 to 2008 patients with an 18% intracranial hemorrhage rate. Intracranial hemorrhage and poor neuro outcome is what we worry about in premature infants, essentially. They reported statistically lower survival and higher infarction rate in babies who are less than 34 weeks at 48% versus at 34 weeks. Big difference, almost like more than half at 22%. There was no difference in the risk of intracranial hemorrhage between these two comparisons. They compared the 29 to 33 weeks and the 34-week gestation. The survival was 58% for the 34-week infants versus 48% for the 29 to 33-week infants. So 48% survival with no difference in intracranial hemorrhage, gives you a pause that, could we manage these babies on ECMO? Obviously, cannulation, putting an appropriate size cannula, as we discussed in the morning, risks associated, the complications associated with an ECMO run in small babies, those are always there. And obviously, each center have their own resources and capabilities to manage these situations. But the paper report concluded that the differences between these two comparisons, gestational age, were modest and may be clinically acceptable. This paper came out in January of this year. It's a very big study, and it looked at the gestational age and birth weight with outcomes, and mortality, and major adverse ECMO complications. Again, looking at the ELSO registry for all neonates. And this is after 2010. The previous study was earlier cohort, so you could argue that the ECMO management is an evolution, and the complication risk may have been higher earlier in the history of ECMO, but this is more in the last 15 years or from 2010 to 2020 range. A total of a little more than 14,000 neonates met inclusion criteria, and they showed that the risk of mortality and unacceptable complication rates are high, and they do go down with maturation. But at between 29 to 34 weeks of gestation, the risk of mortality is 60 to 70%. The risk of adverse events is in that ballpark as well. They also looked at birth weight, and these are patients who had one run of ECMO, and these birth weight and gestation is not the corrected age; it is the gestation at the time of birth. And here again, you can see that babies, neonates who were low birth weight had a higher risk of mortality, and they had a higher rate of adverse events. The overall cohort mortality rate was 39%, and the overall major adverse event rate was 45%. So for the premature infant and for the smaller babies, they were almost double in terms of these issues. So they concluded that decreasing gestational age and birth weight strongly correlated with increasing odds of mortality and/or ECMO-related complications like intracranial hemorrhage. And the highest ECMO mortality rate was in neonates from 29 to 31 weeks and birth weight of 1,500 grams to 2 kilograms, approaching 70 to 75%. So very high. So it gives you a pause. Different studies are showing different numbers, 50 to 75%. The previous 2017 study showed 58% survival. But again, that study showed that the 29 to 33 week infants have a high mortality. So that's why at this day and age, we don't put those babies on ECMO at 34, 33, 34 week infants. Most of the centers between 32 to 34 do consider ECMO in a baby who is in cardiorespiratory crisis, as long as we are able to cannulate them safely. So I just wanted to give you a snapshot of what the literature says of a very pressing question that has been coming up more and more in the last 4 or 5 years. BPD, and talk about lung disease. We talk about meconium aspiration, pulmonary hypertension, pneumonia. I mean, those are all acute, reversible disease processes. But what about patients who are born premature, who are older now, who are big enough now, and who have severe bronchopulmonary dysplasia with associated pulmonary hypertension crisis? So BPD affects about 25 to 40% of the cases. And this graph that you see on the right side we did a study from again from the ELSO registry where we looked at BPD ECMO cases from 2000 to 2023, and you can see there's an increasing use of ECMO in this cohort. 25% of the BPD patients have associated pulmonary hypertension who can go into a PH crisis and with respiratory failure, mostly in the setting of a viral respiratory infection. Diverse phenotypes of BPD make management difficult, not only pre-ECMO, but also on ECMO. Having said that, with this increasing use of ECMO in this cohort, 70 to 85% survival is being reported, which is pretty decent. And it's something to consider in these patients, especially when they're a little bit older and are able to be cannulated. There are a few studies out there looking at outcomes in patients with BPD who are managed on ECMO. I'm just showing you the last 5 years. And they are reporting survival of 70 to 85%. And this one by Hernandez shows they looked at 143 patients. And 128 of them were BPD and 15 had pulmonary hypertension associated with them. And they are reporting very good outcomes with intact neuro status. The 2024 case report is out of South Korea. 2 patients who were successfully managed. They did have respiratory morbidity and required tracheostomy. And this last study that was just published a few months ago out of Emory Hospital, they looked at 19 patients with BPD who were managed on ECMO, and they used veno-venous mode. Emory uses VV for their NICU mostly, so that they felt comfortable doing that. 63% of the patients are managed like that, with a very decent survival of about 79%, with a discharge survival that was coming off ECMO and discharge survival of about 63%. So these are the very sick patients, severe BPD, severe pulmonary hypertension crisis. So again, just wanted to showcase this type of a patient population that we are dealing with in the NICU, beyond the meconium aspirations, beyond the pneumonias and the PPHN, who are maybe never extubated, or they are extubated but always required respiratory support. They have different lung disease phenotypes, and they have a crisis. And should they be put on ECMO? I think one thing that we have to be mindful with neck cannulation, these babies are born early, they may have had central lines, and we may or may not be able to put cannulas in, but you can see in centers who have reported that they are able to do it successfully. We, as part of the Children's Hospital Neonatal Consortium, we actually did a survey across, it was an international survey to the pediatric intensivists and the neonatal intensivists to see how they feel about using ECMO for BPD, and especially if there are comorbidities present. Almost a third said that they will not exclude and they would go ahead and use ECMO. More than a third said that they will, if comorbidities are present, they will exclude if the comorbidities are present. And around 25% would consider baseline respiratory support for ECMO decision. So there is variability in how people approach and how they feel about using ECMO for infants with BPD, despite the data and the literature suggesting very good outcomes. It was interesting that 16% of the neonatologists and about 8% of PICU doctors from the US centers would consider ECMO in BPD, even in the presence of neurologic injury. In contrast, none from the non-US centers, which included Europe and Latin America, they would not use ECMO in that scenario. So again, there is limited evidence. It contributes to knowledge gap and practice variations among intensivists and across centers. But the research does say that the survival outcome is really good. And BPD, may not be as irreversible as we think, and patients may be able to come off ECMO support, and it can be considered in these patients. With respect to lung problems, the other category that we sometimes struggle with is pulmonary hyperplasia. One condition that is associated with this is diaphragmatic hernia, but I'm going to focus more on renal anomalies. CACUT, which is congenital abnormalities of the kidneys and urinary tract, which is a spectrum of congenital anomalies like renal agenesis, renal dysplasia, obstructive uropathies, severe hydronephrosis. All that can lead to underdevelopment of the lungs in utero, and babies can be born with pulmonary hyperplasia with resultant respiratory failure. Incidence is about 3 to 6 per thousand, can be isolated finding or part of a syndrome. ECMO can be used as the survival bridge with multidisciplinary care, but there is concern that when there is intrinsic renal disease, and then on top of it, you have severe pulmonary hyperplasia, survival may be not very good. But some improved outcomes are reported with ECMO management. So the paradigm is shifting a little bit in this disease category as well as an ECMO candidacy. So this paper that came out in 2017, they again looked at ELSO registry from 1990 to 2014. 45 neonates were identified with a history of congenital renal anomalies and pulmonary hyperplasia who were managed on ECMO. And you can see the mortality was very high for patients who had intrinsic renal disease. Babies who had polycystic kidney disease, autosomal recessive or unspecified, those who had renal dysplasia had a high mortality, and they were non-survivors as compared to primarily obstructive uropathy, where the survival was 71%. About 51% of these patients required renal replacement therapy. The babies who were non-survivors, they had greater risk of intracranial hemorrhage. So it seems like that when you have obstructive uropathy, lungs may not be so hypoplastic. And if there is a situation like this, ECMO should be considered. And we do consider it in our center as well because the survival is really good. For intrinsic renal disease, again, there are ongoing discussions in the ECMO world. In the recently concluded ELSO meeting, there was a panel discussion about it, about primary renal disease and the utility of ECMO. And a group from Minnesota, they actually presented 6 or 7 patients who had intrinsic renal disease, who with history of anhydramnios prenatally, who they were able to successfully manage with ECMO support. So not too many patients, but more and more data is going to come out in the future. This paper is more latest, 4 years ago, published in Journal of Pediatric Surgery, again looking at ELSO registry from 1981 to 2016, essentially looking at mortality trends with pulmonary hyperplasia in general. And what they did was they had 5 groups, 5 categories: CDH, renal dysplasia, pulmonary hypertension, and pulmonary hyperplasia, and other obstructive renal disorders and miscellaneous diagnoses. They had about 1,300, almost 1,400 patients. Survival decreased for patients with pulmonary hyperplasia secondary to renal dysplasia. That is what we always worry about. They had no survivors with renal agenesis and dysgenesis and cystic renal disease. And again, this is a very wide time frame from 1981 to 2016, and more recently in the last 10 years, some better outcomes are being reported. And again, they just said the same thing, that obstructive renal disease have a higher chance of survival. And as you can see from this graph, they looked at the 4 eras from before 1990 and 1990 to 2000 into 2010 and 2016. And you can see the outcomes are improving, but the outcomes of patients who have primary intrinsic renal disease, their survival to discharge has decreased. They reported that overall in these 4 eras, there is a trend of improving survival with 41% survival in these patients with pulmonary hyperplasia from 2010 to 2016. More data may come out for the last 10 years now because the technology is improved and the management is improved on ECMO, and we may see even higher survival because clearly the trend is there of improvement in this cohort. The CDH survival, you can see, was only 9% back in the 80s, but then it is now more than 50-60%. These are all ECMO patients, patients who were placed on ECMO support. And especially in the last 5-10 years, ECMO CDH survival is close to 60-70%. A couple of slides about CPR, neonatal CPR in term in premature infants. This paper was published in 2014, 641 neonates. Again, also data of analysis for about 12 years. Overall discharge survival, only 39%. And the reason I'm showing this is, again, it's kind of like showcasing the gestation. And you can see the survival is low for babies who are 34 weeks, 35 weeks. It's only like up to 20-25%. It does go up for the older gestation patients. The risk of CNS hemorrhage is also high as expected in the premature infants. So lower gestation age associated with increased odds of mortality as well as increased odds of CNS bleeding. So despite the many low birth weight units, despite this, many low birth weight units survived to the hospital discharge was a conclusion from this paper. This one was also interesting from 2019, more recent. 593 children were looked at, 70% were less than 1 year. And in this paper, you are seeing a higher survival with ECPR in the neonates. So neonates is the dark graph, and you can see from 2013 to 2014, almost 50% and higher of the neonates who had CPR, ECPR, they were placed on ECMO, they have survival. They don't talk about the neurologic outcome in this paper, but they report an overall discharge survival of about 41%. Worse outcomes were seen in patients with non-cardiac diagnoses, pre-existing renal insufficiency, long duration between CPR and ECMO, and adverse events on ECMO support. That brings us to the genetic side of things. And trisomy 13 and 18, babies with trisomy 21 are managed on ECMO. They have good outcomes, excellent outcomes. But the babies with 13 and 18, there's always a concern that the survival, long-term survival is poor in this cohort, and especially if they have underlying congenital heart disease. There are concerns for neurodevelopmental impairment, associated anomalies, and the quality of life. And that plays an important role when considering potential life-sustaining intervention. So the American Academy of Pediatrics has actually come out with a paper, a statement in August of this year about trisomy 13 and 18. And they mentioned that although exclusive comfort care remains a morally acceptable choice that should be offered to all parents of infants with confirmed or strongly suspected T13 and 18, this diagnosis alone does not justify unilaterally withholding therapies that have prospect of prolonging life or facilitating hospital discharge. So the paradigm again is shifting for something as severe as trisomy 13 and 18, where again the families may want prolongation of life. They are looking at ECMO, centers are offering it, and the question is that what are the outcomes and what are the survival? The concerns are that major structural congenital heart disease is common in these patients who also have respiratory failure. They may technically meet the ECMO criteria, but have underlying life-limiting conditions. Severe neurodevelopmental impairment is expected. ECMO is invasive, resource-intensive, and not curative. So these questions float in the mind of intensivists when they're faced in a situation like this. And for that reason, many will not consider ECMO for trisomy 13 and 18. But there are reports out there, studies are out there where they have been managed on ECMO support. This was a survey. It was published in 2017 where 5 case scenarios were put forth to ECMO program directors in 2015. And one of the cases was trisomy 18. 69% of these ECMO directors said they will not use ECMO due to the diagnosis of trisomy 18. And the 31% who said that they would offer ECMO, they said they would do it if there is a single organ dysfunction and previous successful cardiac surgery as the reasons to do it. There were significant differences in responses between the different specialties. 50% of the cardiothoracic surgeons said that they would offer ECMO support, while the rest of the group of the intensivists, they ranged only from 13 to 16%. So again, out there, most of the intensivists, including the surgeons as well, they would be reluctant to put babies with trisomy 13 and 18 on ECMO support due to concerns of long-term outcome. This paper, again, more recent from 2021, looked at ELSO registry. So that's where all the data is. That's where most of the patients are. They looked at the last 20 years, like from 2000 to 2018. They could only find 28 patients. That's only 0.06% of the entire cohort with trisomy 13 and 18 who were managed on ECMO. Complication rates were very high at 86%, and survival was low in the 40s. The trisomy 13 survival was a little better than trisomy 18 survival. Again, it's a very small number, only 28 patients. They reported that patients with major cardiac defects had a high mortality. Mortality without the major cardiac defects were within range for general pediatric population with trisomy 13 and 18. And their conclusion was that T13 and 18 alone should not be an absolute contraindication to ECLS. So most of the people will think it's an absolute, but that's where the paradigm is shifting, that some of these conditions are not being looked at as absolute contraindication. And as you can see from this table, the patients who had no cardiac anomaly in trisomy 13, the in-hospital mortality was only 29%. And for trisomy 18, it was 38%. But in the presence of a major congenital heart disease, and I showed you in the previous slide, the chances of a major heart disease is high in these patients, the mortality really goes up and survival goes down. Lastly, metabolic disorders in ECMO, inborn errors of metabolism, urea cycle defects, organic acidemias, and all these mitochondrial diseases. They can present in the neonatal period with severe acidosis, severe cardiorespiratory failure, myocardial dysfunction, and multi-organ failure. Diagnosis is not readily available, and the patient is going into a crisis. So ECMO is considered as life support while a comprehensive diagnostic workup is being initiated, including expedited genetic testing. Nowadays, with the genomic sequence testing, it takes about 5 days. So patient is in crisis, you put them on ECMO, genetic testing should be sent on all babies in this kind of situations who are being put on ECMO to look at their outcomes. But diagnosis of the metabolic disorders may lead to a redirection of care or better understanding. To summarize, there has been an expanding use of ECMO to manage neonates and infants with more complex clinical conditions. Patient selection is complicated when faced with decision for ECMO candidacy in such cohorts in the neonatal world. Parental input has increasing impact nowadays. Favorable outcomes are reported for the diagnoses one considered absolute contraindications. Judicious family counseling and careful patient selection is paramount to ensure feasible use of ECMO in patients with complex diagnoses. Thank you.
Thank you. Our next guest in person, Dr. Avu Gazit, will be speaking for the cardiac ECMO indication in controversial subpopulations. Thanks, Mike.
All right. Good evening. So some of the issues that I'm going to discuss have some overlap with what Dr. Berhan just discussed. So I'm going to save you some time here. What I'm going to talk about is kind of mention the overall exposure to cardiac ECMO based on the ELSA registry. Talk about some of the conventional indications and some of the controversial subpopulations that were already mentioned, but I'll just kind of focus a little bit more on the cardiac side of things. So I'm sure you have all seen that. This is true for 2024, and just looking at cardiac ECMO by the end of 2024, as you can see here, there were approximately 66,000 patients, adult patients, who underwent cardiac ECMO with 47% survival to discharge or transfer. As for pediatric patients, you can see approximately 20,000 patients by the end of 24, or ECMO runs by the end of 24 with 56% survival. And for the neonates, approximately 12,000 ECMO runs with approximately 45% survival. So this is what we usually quote, survival rate of approximately 50% for all comers of patients who undergo cardiac ECMO. It's interesting because the number of centers have increased over time. The number of ECMO runs have increased over time, but and technology improved. Our ability to support those patients is much better. But overall, there was really no change in the survival of those patients over the year. These are the general indications for ECMO. Again, this is not rocket science, and every one of you is aware of those. Usually, we look at two major buckets of patients with cardiac disease, those with congenital heart disease, those with acquired cardiac disease, and the indications that are applicable to both buckets. So starting with the patients with congenital cardiac disease, there are different phases where we support those patients. We support them in the preoperative stabilization phase. Examples, for example, are patients with detransposition and the severe persistent pulmonary hypertension of the newborn with the refractory hypoxemia, despite of balloon atrial cetostomy and despite of aggressive medical management. There are, again, the number of patients that are overall kind of discussed in the literature is pretty small. We do have experience with those patients, and it's interesting that if you support them, if you go on ECMO and from ECMO to the OR to undergo a switch operations, some of them can actually separate pretty well from ECMO following the operation. So some benefit there, but more anecdotal or low number overall. Other patients that may benefit from that in the preoperative phase are patients with single ventricle physiology, with inadequate systemic oxygen delivery, patients who basically present in shock, placed on ECMO, and will undergo the operation following that. I'll provide some more specific data on that later on. And then there is the post-cardiotomy support patients, those patients who undergo an operation and cannot separate from bypass, maybe because of myocardial dysfunction related to exposure to bypass, maybe because of residual lesions that are amenable for either OR intervention or cath intervention later on. And then patients who are cannulated in the early or late postoperative phase, those patients that present with a pretty severe low cardiac output syndrome with shock and organ injury that may benefit from going on ECMO during that phase. So I'll provide some data about that as well. For the cardiac disease patients, again, those patients are usually those that present with acute decompensated heart failure. For example, patients who present with the fulminant viral myocarditis and cardiogenic shock. We all know that these patients actually have a good chance of survival. And those patients would definitely benefit from ECLS support, ECLS early on to prevent an organ injury and as a bridge. And we'll provide some information about that as well. Patients with a burnt out cardiomyopathy who presents with decompensated heart failure and shock. Patients with sepsis or cardiac failure and systemic illness also may benefit. And then those indications that are applicable to both buckets, as I said, the cardiac arrest, ECPR, which I'll discuss, refractory arrhythmias, procedural support, and bridge to durable VAD or heart transplantation. So in our community, in the pediatric cardiac community, definitely there is some consensus or equipoise with regards to several indications. Definitely those that are perceived to have reversible cause for cardiopulmonary failure would benefit from that. Those that are perceived to have reversible organ failure, I'm saying perceived because we don't really know whether they would prove to be, whether it would prove to be the case. But we always make an assumption. Again, it's not as Scott said, it's not a single person decision here. It's a whole team that's dedicated to the care of the patients. And as we all know, we're all very opinionated and have strong opinions about everything. So it's going to be kind of a dynamic decision-making process here. Definitely patients that are heart transplant candidate at the end of the day are considered or perceived to be to benefit from that. Now, there are some controversial indications, and as Burhan discussed, the size is important. And there's definitely a lot of controversial discussions about what would be the threshold for futility here, whether it will be less than 3 kilograms, less than 2 kilograms, anywhere in between. As Burhan discussed, the prematurity in the past, the 34 weeks gestation was considered to be basically the threshold for futility. And as you heard before, this is no longer the case. Lethal genetic syndrome, as Burhan discussed, the T13 and T18 were considered to be futile in the past. As you heard before, they're no longer so. And I'll give a little bit more information about the specific underlying congenital cardiac disease related to that and some success. Severe bleeding and severe CNS injury, well, those patients may not benefit from ECMO and actually may be harmed by that. Let's talk a little bit about outcomes in children who undergo post-cardiotomy ECMO support. And this study is based on data from the STS registry. As you can see here, it's a relatively recent study that was just published this year in the Annals of Thoracic Surgery, using data from 114 centers that are under the umbrella of the STS registry between January of 2016 and June of 2021. Those that were included were patients under 18 years of age, so pediatric patients who underwent post-cardiotomy ECMO. As you can see here, we started with about 9,000 patients, and after exclusion went down to about 4,400 patients. And then taking away those patients that were supported preoperatively, we have about a similar distribution of patients in all phases. So about 1,000 patients for the intraoperative phase, 1,000 patients for the early post-op phase. Early post-op is considered the first 48 hours after admission from the OR to the ICU, and then about 1,000 patients at the late postoperative phase, and that's considered later than 48 hours after admission from the OR to the intensive care unit. As you can see here, these are the top 10 index procedures for each one of those categories. And not surprisingly, you can see that the frequency of ECMO support in each one of those phases is highest in the patients that undergo the node operation or single or stage 1 palliation. We have high frequency in those patients that are undergoing a shunt operation, ductal dependent patients, arterial switch operations, aortic valve interventions, TAPVR, transplant and arch interventions. This table outlines the outcomes of each one of those support stages. So you can see here, they divided to intraoperative, early postoperative, and late postoperative. And as you can see here, the overall survival for the intraoperative phase patients would be 57%, 58% for the early post-op one. And then when you look at the late post-op one, you can see a significant decline in survival down to the 42% range. And then they also talk about survival without neurological injury based on the definitions that they use in that study. And you can see here that with the intra-op, the early post-op, you have about 48% such survival, and that goes down significantly for those patients who undergo support at the late phase. Now, what you can conclude for that maybe is that it's better to go on early rather than later. And I think this is what we try to basically do here at Children's, where we are pretty aggressive about going on early if those patients cannot, definitely if they cannot separate from bypass, there's no question about that. But if they basically present with the significant myocardial dysfunction, inadequate cardiac output, systemic oxygen delivery, our usual approach is to aggressively place them on ECMO early, to identify possible residual lesions, to allow for preservation of end organ vitality, and to allow for overall recovery from the exposure to bypass in those patients. Moving on to those patients with acquired cardiac disease who present with acute decompensated heart failure. These are data from the PC4 registry, or the Pediatric Cardiac Critical Care Registry, that was published in 2020. And based on that study, 6% of the children with heart disease requiring intensive care present with acute decompensated heart failure. of whom 16% require mechanical circulatory support. And then the use of VA ECMO, unsurprisingly, is beneficial or undisputed in those patients. There's a lot of advantages that we all are aware of. Ability to support all ages, sizes, intracardiac anatomies, biventricular or single ventricle failure, ability to initiate ECMO very quickly, and availability in most tertiary children's hospitals. Another significant benefit is the intra-hospital transportability of this platform. For those patients who require higher level of care for transplant evaluation, transferring on ECMO is definitely an option. This algorithm highlights the importance of ECMO as a key component of management of those kids who present with acute decompensated heart failure and hemodynamic instability. I still remember even 20 to 25 years ago, we only had ECMO to support those patients. We didn't really have a ventricular assist device of any kind. And we were pretty frustrated about that, but that was the only way to support them. Nowadays, ECMO is considered basically the first key phase of support. Again, because it can be launched very quickly, very efficiently, and support all types of anatomy and physiology. And when you do that and you don't have recovery as expected by their underlying pathophysiology, this is when you start considering different types of VAD, well, whether it's going to be temporary VAD or durable VAD, and to what end and all that. For example, patients who present with cardiogenic shock with fulminant myocarditis is expected, actually may have a good chance of recovery, and as they expect to recover myocardial contractility within the first several days to a week or so. If they don't, then you proceed forward to the next level. Patients who present with, for example, acute rejection with the hemodynamic compromise that you need to support quickly in order to facilitate initiation of anti-rejection therapy. Those patients also, if they respond to the anti-rejection therapy, would recover within a few days and would be able to separate. But if not, then it's a different story, and then you are talking about proceeding to VAD support. Patients who present with refractory arrhythmias would definitely benefit from initial support to protect end organ injury to allow for aggressive antiarrhythmic therapy, which would actually lead to some myocardial insufficiency if you don't support them with this platform. So some benefits from that. Okay, let's talk a little bit about ECPR. I know that Burhan mentioned that a little bit, but I think it's important to mention that in the context of patients who require cardiac ECMO support. Again, this study was just recently published in Critical Care Medicine 2022 and looked at pediatric cardiac surgery, surgical patients who underwent CPR greater than 10 minutes without a return of spontaneous circulation. They analyzed the entire cohort, but they also used a propensity match cohort. So basically matching conventional CPR, 382 conventional CPR patients with 382 ECPR patients within that entire cohort based on their underlying risk stratification. For ECPR patients, the mortality rate was 53%, and the survival odds were two times higher with ECPR in comparison to conventional, with the caveat that those patients had the increased incidence of CNS injury. As you can see here in those graphs, on the left side is an analysis of the entire cohort without propensity matching. On the right side is the propensity match cohort. When you look at the entire cohort, you can see that for those patients who underwent CPR between 10 and 18 minutes, these patients in the entire cohort would actually have some survival benefit for the conventional CPR in comparison to the to ECPR. Whereas in the rest of those timeframes, 19 minutes to 32 minutes and up from there, you can definitely see the benefit of ECPR in comparison to survival benefit of ECPR in comparison to conventional CPR. And then when you look at the propensity match cohort, you can see that even with the short duration of CPR, there's still some benefit, or at least no inferiority to ECPR versus conventional CPR. So again, this day and age, every heart institute that perform high complexity congenital operations, every institute that offers heart transplantation should have the capacity to provide this form of support. Obviously, there's a lot of technical issues related to that, the availability of the team overnight, for example, 24/7, who actually performs that, which is extremely important, but the importance is clearly demonstrated in this study. Buren talked a little bit about the lower weight group, which I'm also going to talk about, but this is just talking about outcomes of infants weighing 3 kilograms or less and require ECMO after cardiac surgery. Let's move on. The selection criteria, other than the weight, were patients with neonates with congenital heart defect that underwent cardiopulmonary bypass operations as neonates, and were currently at less than 7 days postoperatively. The primary study point was survival more than 30 days post decannulation. This was out of CS Much, Michigan. Study was conducted or collected data, analyzed data between 1992 and 2010. During that time frame, they had about 6,700 total number of cardiopulmonary bypass, less than a 3 kilogram baby, and of them, 79 underwent ECMO post-cardiotomy. Eventually, 64 patients were included in the final analysis. As you can see here, the outcomes are outlined here. 31 of those 64 patients underwent elective withdrawal or of support. 33 patients were short-term survival, but of them, 12 died within 30 days. So at the end of the day, 21 patients, so 33%, met the primary endpoint. And if you remember the first slide that I showed about the overall survival rate of neonates after with ECMO for cardiac reasons, which was about 47%, I think, this is much lower than that. However, is it futile? Still, 33% of those patients survive. So I don't think that you can call it completely futile, but definitely requires a significant conversation about that. They did some multivariable logistic regression analysis. And for those patients, the only variable that played into increased odds of mortality was renal replacement on ECMO. The birth weight less than 2.5 kilograms actually did not reach statistical significance. Buren already talked about that, so I'm definitely not going to expand on that. I'm going to show that again just to emphasize what Buren already discussed. And you can see here for the 29 to 32 weekers, you can see that the mortality rate by gestational age is at the 70% range, and the rate of unacceptable complications by gestational age at that range of 30 to 32 weeks is pretty high. But from then on, you can see this monotonous decline in mortality and complication rate. Same thing for birth weight. And again, Berhan already talked about that. The highest risk group is the 1.3 kilograms to 2 kilograms with a pretty high mortality rate and the rate of unacceptable complications. Just to show that, I don't think Berhan showed that, but this is multivariable models that demonstrate the association between association of birth weight and gestational age with mortality only. And as you can see here with these models, with basically what it shows is that the odds of small mortality during or after ECMO run decreased by 18%. Decreased by 18% with a 1 week increase in gestational age at birth, and decreased by 49% with a 1 kilogram increase in birth weight. So again, is it futile? It's definitely extremely high risk. People are actually placing those patients on ECMO. Discussion is definitely valuable in those situations. And then Berhan also mentioned the trisomy 13 and 18. We recently had a patient with a complex congenital heart defect that underwent repair of their complex disease and ended up not being able to separate from ECMO. Initially, we were eventually able to separate this patient from ECMO. The eventuality was death. But that drove some discussion about whether those patients would even benefit from complex repairs, and we didn't even mention ECMO. This, as Berhan mentioned, this is a very interesting study based on the ELSO database that looked at hospital mortality of those patients, and as he mentioned, there were only of 47,000 total ECMO cannulations. These were only 28 patients. What I want to show you is the analysis for the cardiac patients. I don't think Berhan mentioned that. And I think it's actually nice to see which patients were supported and which patients survived. And it's surprising because you can see here that, for example, patients with trisomy 18 who went on ECMO because of infectious etiology and had pretty complex congenital heart defects with DORV and complete AV septal defect, and underwent repair of complete AV canal prior to ECLS and other operations on ECLS, actually survived the hospitalization. Just shows you that, again, talking about futility, yes, no. And other patients with the infectious etiology, PDA, who underwent the repair of PDA prior to ECLS survived here. Patients with neonatal cardiomyopathy who underwent, who decompensated, went on ECMO, underwent atrial septostomy on ECMO, probably to decompress the left side, also survived here. Patients with a hypoplastic right heart syndrome who before ECMO underwent all these procedures there and ended up surviving as well. So just interesting to see that even those complex congenital heart defect patients with this underlying genetic syndrome do survive, which again, based on what Berhan showed, suggests that we should at least look at them and consider them. And similarly for trisomy 18, which I'm not going into details right now. So, in summary, ECMO is definitely commonly utilized in children with heart disease. I think it's a must these days, and every institution that does this, sees those patients, has to have this capability. It is an invaluable support modality for centers caring for those children. There are many indications, as I've shown, And the contraindications are mainly based on individual patient characteristic rather than generalized statements. As you can see, as I've shown with the post-cardiotomy patients, early use before irreversible end organ injury can improve outcomes. Thank you.
Thank you very much for that. Our last speaker in person before we get to our panel discussion, we'll end our day for today after this, is Chris Horvat, and he's going to be speaking about ECPR and out of hospital cardiac arrest. Thanks, sir.
Thanks, Mike. Hi, everybody. I'm Chris Horvat. I know many of you, but for those I don't, I am an intensivist here at Children's Hospital. I also lead our code teams locally, and then I most recently took on the role of leading the UPMC Pediatric Non-Trauma Resuscitation Council. And this is an exciting topic to be asked to speak about because I reflected immediately and thought if I had given this 10 years ago when I was a fellow, we would start and end with this slide because we really did not think of doing ECPR for patients who had experienced an out-of-hospital cardiac arrest. And that's changed, and it's changed a lot really in the last 5 years when you look at the literature. And so today I'll go through a couple cases and just highlight some of the registry data that's come out in the last half decade. And then I'll touch on some clinical trials that came out recently in the last 5 years, again, predominantly in the adult space, but that I think are highly relevant for those of us working in pediatrics. We'll go briefly through some of the current guidelines, recognizing that the AHA guidelines are about to be updated, but aren't published yet. Some practical considerations, ethics, and really just work to set the stage for the panel, I think that's going to be occurring after the break. And I'll do my best to make up some time here as well. So the first case that we'll do here is actually a published one. A 7-year-old previously healthy girl collapses at school, found to be in ventricular fibrillation. Bystander CPR is initiated immediately. The first shock is delivered within 5 minutes via an AED. She remains unstable after multiple defibrillations and is transferred to a specialized ECMO center. Mechanical CPR is maintained during transport, and VA ECMO is initiated 105 minutes after collapse. Coronary angiography is normal, but the myocardial biopsy confirms fulminant myocarditis. She's weaned off ECMO on day 8, discharged on day 33 with normal neurological function. We have some data now from the ELSO registry. This was published just last year, looking at patients who have went through ECPR after experiencing an out-of-hospital cardiac arrest. And so this is looking at data from 2020 to 2023. There were 80 patients identified in the registry. The median age was 9 years. And bystander CPR was performed in only 46% of them, and arrests were witnessed in only 65% of them. Cannulation actually mainly occurred in the ICU in this registry look, which suggests that these were patients who had experienced an out-of-hospital cardiac arrest. ROSC was obtained, and then a rearrest actually occurred in the ICU. 31% had cannulation in the ED, and then the remaining underwent cannulation in some different setting. Survival to discharge, really importantly, was 29.9% in this registry study. And some of the key features that were associated with survival were not too surprisingly shockable rhythm and signs of life in this registry analysis. And then there was a nice, concise, definitive review also published just last year in Critical Care Medicine. And this was, again, looking across the available literature, registries, trials, and otherwise, and identified, again, witnessed arrest, minimal no flow time, shockable rhythms, and a reversible cause, none of which are surprising, as being associated with survival and favorable outcome. And also identified that if ECMO is initiated within 30 to 40 minutes of arrest, in one study that this review highlighted, nearly 100% survival in that one study. So some really compelling literature that has started to come out in the last few years. Of course, there's another case I think that illustrates what goes through our mind when we're thinking about using ECPR in these types of circumstances. And so case 2 is a 4-year-old boy who's found submerged in a backyard pool. The downtime is unknown. Bystander CPR is initiated about 7 minutes after discovery. He's transported to the nearest emergency department. Refractory pulseless electrical activity continues despite PALS or advanced life support. ECPR is initiated 90 minutes after collapse via femoral cannulation. The ROSC is achieved on ECMO. Neurologic exam shows absent brainstem reflex with the exception of spontaneous breathing. He separates from ECMO. Discussion with the parents ensues. Tracheostomy and G-tube are placed, and the patient is eventually transferred to a long-term care facility. So this scenario reflects some outcomes that we see in the registry data as well. This was a retrospective study of 140 children who underwent ECPR for cardiac arrest, finding survival to discharge was 20% for out-of-hospital cardiac arrest population, and 41% for those who were cannulated after experiencing arrest in the emergency department. And after adjustment in that study, patients had a 3.9 fold higher odds of mortality if they had experienced an out-of-hospital cardiac arrest versus not after undergoing ECPR. All right, so with some of the registry data in mind, and I think the tension that goes through our minds is well illustrated by those two cases for these scenarios, let's take a look at some of the recent adult clinical trial data in this space. The first is the ARREST study. And ARREST was a phase 2 single center randomized trial from the University of Minnesota that looked at early ECMO facilitated resuscitation versus standard ACLS in adults with out-of-hospital refractory VFib or VTAC. Patients had failed at least 3 shocks, were on mechanical CPR, and could be transported to the hospital in under 30 minutes. And randomization occurred on ED arrival. The ECMO arm went directly to the cath lab for rapid VA ECMO cannulation and immediate angiography when appropriate. The ACLS arm received guideline-based ED resuscitation. Trial enrolled only 30 patients before stopping early at the first interim for analysis for efficacy. Survival to discharge was 43% in the ECMO arm, 7% with standard ACLS, and the posterior probability of superiority was about 0.99 at the interim. And then really importantly, the 6-month survival also favored ECMO. It was 43% versus 0%. And among survivors, neurologic function improved over time with rehab. Cannulation was fast in this study. It was about 6 to 7 minutes, and really highlights the well-oiled machine that was behind the study. So, in this mature, high-volume program with coordinated EMS, rapid transport, immediate cath lab access, early ECPR, transformed outcomes for a narrow group of out-of-hospital cardiac arrest patients with refractory shockable rhythms. It's an elegant example of how powerful the chain of survival can be, and also a testament to really exploring the new frontier of ECPR in select patient populations. The next trial that came out again in the last 5 years, 2022, was an out-of-hospital cardiac arrest trial in Prague in the Czech Republic. And this was a single center RCT evaluated whether a bundled hyperinvasive strategy that was intra-arrest transport with mechanical CPR, immediate ECPR, and early invasive assessment could improve outcomes in adults with witnessed refractory out-of-hospital cardiac arrest of a presumed cardiac cause. So this was done between 2013 and 2020 over a 7-year period. They enrolled 256 patients between the ages of 18 and 65. And in the invasive arm, patients were transported under mechanical compressions to a center for on-arrival VA ECMO cannulation and coronary angios. The median time from collapse to hospital arrival was 49 minutes in this study, and 66% of the invasive arm patients actually received ECPR. Primary outcome, survival to good neurological function, was 31.5% or 32%. In the ECPR arm, and 22% in the non-ECPR standard strategy arm. Neurologic recovery at 30 days was higher in the invasive group as well at 30.6% versus 18.2%. Major bleeding was more common in the invasive arm. Study was actually stopped early for futility, interestingly, but several key insights emerged. First, neurologically intact survival approached that 32%, comparable to some of the top ECPR registry results. And second, almost all of these arrests were witnessed with rapid bystander CPR, which reinforced how patient selection and system readiness really likely underlied some of these key advances that we were starting to see. There's another trial and a meta-analysis also published in this space. The Inception trial was a multi-center randomized controlled trial across 10 centers in the Netherlands between 2017 and 2021, tested whether ECPR improved outcomes compared with conventional ACLS again. Eligible patients were 18 to 70 years, received bystander CPR, and had no ROSC after 15 minutes of ACLS. The primary endpoint was survival with good neurological function at 30 days, and out of 160 randomized patients, 134 met inclusion criteria. Cannulation succeeded in about 2/3 of the ECPR group. And favorable neurological survival at 30 days, was 20% in ECPR versus 16% conventional. The findings were non-significant though. And so there was a meta-analysis that was ultimately performed that included these trials, arrest and inception in the Prague out-of-hospital cardiac arrest, published in Critical Care Medicine just last year. It says resuscitation, my apologies. And after looking at all of these, this is a Bayesian meta-analysis, and identified a posterior probability of a clinically relevant benefit across these trials of about 0.75, so 3 out of 4 patients benefiting with that probabilistic assessment in the meta-analysis. So those are compelling examples in adult patient population. Still quite distinct, though, for who we encounter in pediatrics, yet venturing into a territory that, again, only a decade ago was really not part of the standard of care at all. The current guidelines, and I'll just review those very briefly here. The AHA guidelines, if you're not aware, are scheduled to be published on October 22nd, the update. So we'll get some new insights pretty soon here. But the current ones from 2020 say that routine use of ECPR is not recommended, may be considered in select patients, pretty low quality data that were available at the time that that guideline was constructed. And again, they're really recommending ECPR for cardiac patients in hospital arrest. And then there was insufficient evidence across the non-cardiac or out-of-hospital arrest patient populations. European Resuscitation Council guidelines from 2021 said use ECPR as a rescue therapy when conventional ECLS fails. It might facilitate things like angiography, rewarming, specific reversible interventions. And for pediatrics, specifically to consider it for ED or in-hospital arrest when reversible causes are likely in committed systems. Very limited role, they said, in out-of-hospital cardiac arrest. And then the International Liaison Committee on Resuscitation also had guidelines in 2020. Again, ECPR is a rescue therapy. It was a weak recommendation, very low certainty of evidence. And the pediatric head of hospital cardiac arrest specifically said insufficient evidence for a formal recommendation. The also guidelines from 2021 said that institutions must deploy explicit ECPR protocols covering eligibility goals and discontinuation criteria. And you can see some of the adult inclusion criteria that were listed there. Pediatric criteria, not yet standardized for out-of-hospital cardiac arrest. All right, some practical considerations that we can infer in the available literature, especially the surge in the last few years. Minimizing low flow duration is important. I think we can all appreciate that, but there are some key enablers as well, like the use of mechanical CPR devices. We now have those available at Children's. Those have stemmed from our perfusion program. We keep those with our crash cart now. Those have been key. Those are key as part of the adult experience, and I think that those are being recognized as key as pediatric programs start to think about venturing into the out-of-hospital cardiac arrest population. And then high volume centers, that really intact chain of survival seems to be essential for generating good outcomes here as well. There are a number of transport and pre-hospital considerations. So a successful ECPR program for out-of-hospital cardiac arrest really extends well beyond the walls of the quaternary center. There are some US programs out there. They are variable in their design. And again, the key there is you got to maintain mechanical CPR en route, identify those reversible causes early, and get medical command physicians involved early on in terms of triaging these patients. Slide, I'm going to call it an obligatory slide on resource allocation and cost effectiveness, because I don't think that this is where the argument often starts to center, and I don't think it should. I think we should be thinking about what sort of outcomes we're able to generate for our patients, not how much these things necessarily cost. The ethics of this, I'll set the stage. Plenty of people with far more expertise than me on this topic are going to be talking in just a moment here, but selection is value laden. There's a whole bunch of things that we should be considering as we start to select candidates with out-of-hospital cardiac arrest for possible ECPR, and it really should not continue without a realistic chance of recovery. And I think that's something we all agree on, but it's much easier said than done. Informed consent and surrogate decision-making, that's hard for ECMO in general, let alone these ECPR cases. The emergent context of it, the real challenge of communicating to families what ECMO is, let alone the tensions that I highlighted earlier that correspond with these out-of-hospital cardiac arrest cases. There's a lot to solve here from a bioethical standpoint. And then we won't go into this in too much detail, but I also need to note this idea of defining death and organ donation and the role that ECPR potentially plays in those scenarios as well. The consensus, of course, is that ECPR should never be initiated primarily for organ preservation. You have to respect the family and patient values, but this is an actively evolving landscape also. So what can we do? Well, I think when we consider ECPR for out-of-hospital cardiac arrest in children, there are some key features of out-of-hospital cardiac arrest that are associated with better outcomes: witness arrest, immediate CPR, including bystander CPR within minutes. Unwitnessed events should probably still be relative contraindications, especially if they don't have associated signs of life. But there are things that are recurrent patterns in the literature, like low lactate, some signs of life, that suggest that there is a patient population who may particularly benefit from this type of approach. And I think within pediatrics specifically, we're going to be far behind in terms of generating large-scale trials the way that the adults have been able to, that are highly enriched with a specific subtype of cardiac arrest. And so we're going to be really dependent on our culture of continuous quality improvement here. And we're going to be looking to our high-volume centers to push the envelope in a really thoughtful way to start saving more lives in a way that is patient-centered and value-centered as well. So with that, thank you. It was pretty neat to talk on this subject. I think we're scheduled for a break and a panel afterwards, if I'm not mistaken. So thank you.
All right, thank you. So that concludes all of our speakers for today. So we're going to take a very quick 5-minute break. When we come back, I'm going to hand the podium over to Holly Fogel, and she is going to be hosting our ethics panel in the back of the room. So a real quick 5-minute break. We're going to get our AV set up, and that'll be our last discussion for the day. But I appreciate everyone's time, and we're looking forward to the panel discussion, and see you tomorrow. Thank you.
So it's just going to start with its discussion on pediatric patient candidates and selection. And like I kept thinking I was going to say whatever now, and I listened to it. Right? So because everything is the use of the word it's like, oh, okay. And so, anyway, so I think right now we just want to see question to them. Like, will they or not, right? This data for adults. Do you want to ask yeah, I think so too, but I think also part of the dilemma is that like you all have someone that one patient and I don't know if that I think we should be. Discussion. Yeah, yeah. But you have an N of one. Yep, we are now. This is all I don't even know. This is where I don't know what to do. This is where I fail, is AV equipment. All righty. All right. Hey, Mike. Is this on? Okay. Okay, thank you. What's that? I kind of prefer to be here, I guess, because as a moderator, I don't really want to be part of the panel. Does that make sense? But you can do whatever. No.
I can't do anything with her until her camera is on.
There's somebody from the University of Michigan. So last year, Mario Castro is the gentleman in the he's the CT surgery in the white coat sitting right here. When he finished, he said he called us. They call us. Yeah. That's really rough.
Can you guys hear me? Fantastic.
Yeah, we can hear you.
Great.
Hi. Hi. My name is Holly Fogel. I am an ECMO specialist and a registered nurse at Children's Hospital of Pittsburgh. We put together this panel today to talk about specifically pediatric patient candidacy and selection for ECMO. I think it's probably a little bit different from the adult world and how things are done there. I also think that one of the things that we kind of gloss over is that our patient population generally does not consent to anything. So when we place these patients in these situations that they're on ECMO and they have long-term consequences from that, that we essentially have consented for them to have like possibly long-term situations and frequent hospitalizations and lots of medications and whatever, which doesn't really happen so much in the adult world, I don't think, if they can consent for themselves. But anyway, what I'm going to start with today is to thank everybody who came and everybody who's participating in the panel. And I want them to introduce themselves. I'll start with the person on our screen. Go ahead, Erica.
That's me. Great.
That's you.
Hi, everybody. Thanks for having me. I regret that I can't be there in person today, but my name is Erica Andrist. I'm from the University of Michigan. I'm a clinical associate professor in the Department of Pediatric Critical Care, and I'm an ethicist by training and interested specifically in ECMO research and end-of-life decision-making, decisional authority and end-of-life decision-making. My current ECMO project looks at how we decide to stop ECMO in children who we don't expect will survive once we stop the circuit, talking to both clinicians and parents who were involved in the decision like that and determining how the decision was made and what factors were important. So thanks for having me today. Looking forward to the discussion.
All right, thank you. And so then the panel that's sitting in the room, if you guys want to just introduce yourselves.
Hi, I'm Alex. I'm an intensivist here, Alex Olszewski, and also an ethicist by training, who's also interested in research around decision-making, around life-sustaining support for critically ill children. I do some health services research in that area, including currently hoping to start some studies with Erica on the topic.
Hi, I'm Tim Kaselitz. I'm an adult cardiothoracic intensivist as well as a pediatric intensivist. Take care of ECMO patients in both settings, but primarily on the adult side.
My name is Jay Malone. I'm an associate professor of pediatric critical care medicine at Washington University in St. Louis. I'm also the medical director of ethics at St. Louis Children's Hospital. I did a PhD in healthcare ethics, and my dissertation was actually on invasive medical technologies, so focused on ECMO. I won't bore you with the details of that document today. We'll talk about more practical things.
Hi, my name is Scott Maurer. I'm a professor of pediatrics at the University of Pittsburgh School of Medicine, and I'm the chief of the Division of Palliative Medicine here at Children's, and I'm also a pediatric oncologist.
My name is Michelle Schaefer. I'm a nurse in the pediatric ICU. I'm one of the clinical leaders, so I'm typically in charge.
And then, hi, my name is Ian Scarberry, and I'm a nurse on the cardiac ICU.
Hi, everyone. I'm Ta Levin-Deknini. I'm the co-chair of the Ethics Committee and Consult Service here at Children's. Thank you all for joining us for this discussion. I know it's end of the day, but hopefully the talks throughout the day have sparked some ethical things that people want to talk about. I know in particular the question of futility was raised multiple times, and that we already were told is something of interest to some of the members here. Holly, I don't know if you wanted to start.
Yeah, go ahead.
Okay. So we thought, as always with ethics, sometimes it's easier to ask people to think about cases that have stuck with them. If anyone on the panel would like to discuss their experience with the case that has resonated with them, we'd appreciate that as a beginning point for our discussion. That's open to anyone.
probably one of the most haunting cases of my career as a palliative medicine specialist occurred in the context of ECMO, and it was a young lady who was on ECMO, had cystic fibrosis, and was status post lung transplant, and was, for a variety of reasons, not going to recover lung function, and was not a candidate for re-lung transplantation, and had been on ECMO for many weeks. I think we're at greater than 50 days at this point. And she was wide awake and talking to people, and a decision was made to take her off of ECMO. And that was a very challenging case for me emotionally and ethically, because she was wide awake for everything. And there was a lot of question about whether the parents wanted to tell her what was going to happen or not tell her what was going to happen. She was 17. And so we had to navigate a lot of those waters. It was extremely challenging, and something that happened, I don't know, probably 6-7 years ago. Still, I think about it pretty constantly. So that was probably my most challenging case on a patient with ECMO.
Thanks for sharing that. I immediately thought of a sort of similar case of an awake teenager, but since you've already mentioned that particular challenge, I also think of a recent case of a child who had persistent air leaks every time we increased the vent pressures. And the reason that this one sticks in my mind is that she was on ECMO for a very long time, and we had a number of division meetings where all of us proclaimed with a lot of confidence that there was no way she was going to survive. She recently walked into our Department of Pediatrics annual meeting and said thank you to the whole group under her own power. So that one's a sort of reminder of maybe epistemic humility, or the limits of our own ability to know how things are going to turn out, even when we feel very confident.
I think I'll share a different flavor of story just for variety. I took care several times over the past year of a 16-year-old girl who had an out-of-hospital cardiac arrest due to what was subsequently found to be congenital long QT syndrome. Prolonged CPR outside and in the emergency department, was ultimately cannulated for ECMO. Spent about 3 weeks on ECMO with multi-organ failure, and then approximately 9 months in the hospital. Placed a trach, placed a G-tube, did not have a significant recovery of neurologic function, but was ultimately able to be discharged home, where she remained for approximately 1 week before being readmitted to the intensive care unit with sepsis, and she remains in the hospital a month later.
A case that came to mind for me was when I had in fellowship. Interestingly, for our discussion about pediatric patients, this was an 18-year-old, a teenager, but a legal adult with multiply relapsed cancer, who would have met a lot of relative contraindications to being cannulated, including that her ARDS and her severe lung injury had been two plus weeks. Ultimately was cannulated onto ECMO, and then ended up being the longest run at our institution. I think one of the longer runs out there, at least in the literature. She was on ECMO for many months, but was able to do so being awake and enjoying time with her family. And so when it was determined that we didn't feel she would survive decannulation, it became an ongoing discussion about sort of how long to support her having this relative quality of life in the hospital on ECMO. And that was a really challenging space to try to find a way to support her goals, her family's goals, and the distress of the clinical team around it.
I think part of the reason that I thought it was important to try to talk about this subject is because of 3 cases most in the last year and a half in the PICU. And I think Michelle Schaefer probably understands where I'm going with this conversation, where they were, I'm sure that obviously it's very difficult to make the decisions to to place somebody on ECMO, but it seemed that these children's, and I know, again, you absolutely cannot have a magic ball to know whether they're going to be okay or not, but it seemed that their overwhelming comorbidities might have excluded them from being cannulated. But that being said, the one patient, I know, I just felt very strongly that it wasn't probably going to be a survivable thing, but she was totally intact and was little, like 6. And I really felt that possibly her outcome, like she would have probably been better to have been able to go home to like a palliative care situation and spend her last few weeks surrounded by her family and her sister and some of the things that she wanted rather than dying in the hospital. That being said, I know that we can't tell, we don't have a crystal ball, that she wouldn't have possibly survived it, but it seemed highly unlikely given the amount of obstacles that she had faced before her cannulation and her disease process that she had. But anyway, Michelle, do you want to speak to that at all?
Yeah, absolutely. And just real quick, Holly, shout out to you because you helped. I know exactly who you're talking about. And I think that you made her hospital experience as close to her home experience as you possibly could. So thank you for that. Yeah, this was a little girl that we knew very well. And I think Scott also knew her as well and had been in and out of the hospital and in and out of the PICU frequently. And we tried everything that we could, intubated, prone, not prone. It was a case that we talked about over and over and over again. And one of the things that has stuck with me is, and Tim brought this up earlier, is how kind of the doctor shopping almost, like it seemed like the one day she was an ECMO candidate, the next day that she wasn't. And I was there one night and we were not going on ECMO, and I came back 12 hours later and she was going to the OR to be cannulated. So that was something that was very difficult for me, because having multiple conversations with this family, I just felt like after that, they kind of lost some of the trust in some of the providers. They seem to only want to hear, I don't want to say good news, but they kind of picked who they wanted to speak to and what they wanted to speak to them about. So that was very difficult.
You know, one of the things I brought up in my talk was this idea of affect heuristic, and having now done this for 5 going on 6 years, both in the adult side and in the pediatric side, it's clear to me that we're actually wrong on both sides of it all the time. Sometimes we put patients on ECMO and they die because of the ECMO when it's not clear that they would have otherwise, and vice versa. Sometimes we withhold ECMO and it's just a statistical fact that some patients that you decide no actually may have benefited. It does seem like emotionally it's much easier to offer and deploy a therapy and versus potentially use a therapy that causes harm, because as a person in the former situation, it's your decision. You're withholding this therapy. It feels like you're removing this last bit of hope, versus in the latter, you almost are placing the fate of the patient in the arms of the machine. And that's makes it a little easier to sleep at night. I don't know that functionally it's actually different. I think in either case, it's a mistake. And it's also just the cost of doing business when you're dealing with such a resource intensive as well as invasive and morbid form of life support. We, on the adult side, we do upwards of 150 to 200 ECMO cases a year. They all come to our unit. On any given week that I'm rounding there, we have between 3 and 6 patients that are on. And despite that repetition and reps, it's still absolutely the case that we're wrong on one side and wrong on the other one all the time, which is why, at least in my talk, I was talking about this shared decision model and not laying the feeling of being the arbiter of life and death at the hands of one single clinician. That simply can't be the way.
That point you made about the sort of withhold withdraw distinction, I think, is interesting and important. And it sounded from your talk earlier like your team are the proceduralists for some of your at least respiratory or VV ECMO. All of them. Yeah. All of them. This caught my attention because there's a bunch of intensivists represented here, but no surgeons. And I have, in my role as an ethicist, found myself a number of times between a surgeon saying, if I intervene, I'm doing something active that could harm the patient, while the intensivist is saying, if I choose not to intervene, I'm making that decision to withhold a therapy that could help the patient. So there's this divide about the perception of the sort of active nature of the decision-making that pulls in opposite directions. That, for us, often creates a conflict.
Yeah, and even though you're right, we are both the medical and the procedural parts of it, we actually experience this dilemma too over in the adult hospital, because oftentimes it'll be a colleague from another service, it'll be a partner outside of our unit that is asking for help. My partner, our unit director, actually calls this tension that he's a military guy. He calls it the courage of the non-combatant. And someone's like, just put them on ECMO. They're gonna be fine. Just put them on ECMO. It's like, okay, but you're not the one doing it. And it's very easy to sort of make that strong case when you're not the one sort of doing the procedure and having to deal with the complications. So yeah, it's a good point.
I wrote some notes down as everyone was talking, and there's some lines I want to refer back to. One, and I think all of us who work in the clinical setting have that experience of plans of care changing as attendings change, and the effect that this has on families. And that made me think of a slide from one of the talks earlier today that said, sorry, contraindications are based on the individual patient characteristics, right? But then your perception of those characteristics, and then getting to this idea of futility, which has been raised in numerous talks today, your perception of futility is your own. It's very rare that we have multiple people who agree on something being futile, unless it's like very obvious, right? So I was wondering if you all could speak to this idea of offering something and where you think futility comes into it, or if there's another way of thinking about what we offer.
I'll answer because I'm holding a microphone, but then I'm going to pass it off and let other people talk. I know a lot of ethicists who call futility the F word. It's a fraught term, I think, in a lot of ways. First of all, it's conceptually ambiguous. And I think what you're highlighting in the question about different attendings having different conceptions of what futility means actually is the problem. When I say something's futile, you have no idea actually what I mean by that, other than I think we're talking about a therapy that we shouldn't deploy, with no more specificity about why that is. So that conceptual ambiguity is a big problem. I think then people use that sometimes, not always, as a sort of semi-paternalistic way of saying, we as a medical team have made the decision about whether this is appropriate or not appropriate, even though many of these decisions inherently involve the quality of life determinations and prospective benefit determinations that are made by the parents. Saying futility makes it seem like, nope, your part of that decision is not important, it's on us. It's also almost always inaccurate in some sense. I mean, as we've seen and talked about today, ECMO almost always can provide at least some temporary benefit. Now, whether patients ultimately survive is a different question, but in terms of declaring it futile for all ends, that's usually inaccurate. And then finally, there are just better terms that exist. If we're actually seeking conceptual clarity, we could refer to things as potentially inappropriate or potentially non-beneficial that, one, allow for the type of humility that I talked about our ability to prognosticate, and two, leave the door open for a conversation with families about what constitutes proportional benefit and burden. I'll stop there and let someone else talk.
I think I'd like to build on that last part a little bit by you had mentioned ongoing conversation, and one thing I think that I'd like to just add maybe as a side note is that sometimes things change because clinical situations change, right? I absolutely agree that sometimes it's attending to attending and one person has an opinion and another person has a different opinion. But for that reason, articulating our reasoning can be important because it may not always be just one person's perception just versus another person's perception. Katie Moynihan has the idea of longitudinal candidacy decision-making. And I think that can be in play here too, because the circumstances on day one of a patient's ECMO candidacy might genuinely be different than the conversation on day 2, day 3, day 4, 6 months into their hospitalization. And so determinations of benefit risk can change over time, and articulating that reasoning can sometimes illustrate the difference between, hey, the situation is clinically different now versus this is just one person with a different opinion from the person who was on last week.
I think that's a great point that extends the idea that using futility may foreclose on that kind of longitudinal decision making by giving the impression that it's futile now, it'll always be futile, instead of conceptualizing a particular patient as having a particular risk benefit sort of balance, a proportionality balance that we all would acknowledge could change over time.
Yeah, I mean, overwhelmingly, the talks today, while the word futility came up, I think it was super clear just hearing all these different talks in different patient populations that the discussion now is sort of what risk benefit ratio are we willing to accept, at least for the patients we even have data for, because then there's also just the situation that we don't for many. But talk after talk was showing these different percentages of survival that are improving. And so it becomes a discussion around what percent of benefit or percent of possible survival are you willing, and by you, I mean hopefully a group of people, including the family in some situations, to take on, which I caught myself saying, including the family. And I think one thing that gets murky, this is also just a side note in these conversations, and one of the speakers today brought it up, I think it was Scott, is that this topic is on candidacy, which I think of as sort of the decision before involving the family about whether to offer ECMO. And so anyway, I just wanted to throw that in there. And back to what I was saying before, I think all of this sort of supports having a process-based approach and having a consensus-based approach, because we're not going to get it right 100% of the time. But we need to have an approach that includes more people and gathers consensus. And as Erica brought up, does it over time as a patient's situation changes. And one thing we haven't talked about, but I think could do better in a lot of institutions, including here, is having those conversations earlier and more consistently.
So I just wanted to, so in the cardiac ICU, because, I'm in the ECMO department and I'm in all 3 of the units, and they operate differently. I don't always see the same ethical dilemmas so much in the cardiac ICU. I think a lot of the ECMO runs are very straightforward. We know that it's due to failure to separate from cardiopulmonary bypass. We know that it's due to their congenital heart defect. You know, that a lot of the times those things are very fixable. But I want to make sure, because I want to make sure everybody on the panel has a chance to talk. And Ian is from the cardiac ICU. So I want to make sure. I think the dilemma that I have, that I've seen the most in the cardiac ICU, and I'm sure Ian has seen it too, is multiple ECMO runs on the same patient. And if I pulled the data, I would say that if you've had been in a short period, I'm talking about a short period of time, I'm talking about in a month, you know, like whatever, if you've had to be cannulated onto ECMO more than 3 times, I believe the mortality in our institution is 100%. That they don't get decannulated and they don't survive to discharge. They certainly don't survive to go home. So Ian, do you have any thoughts on that? Do you have any experiences that you want to relate to that? I think that's kind of where maybe we come from in the cardiac ICU, but if I'm wrong, I apologize.
I understand what you're saying. I just think sometimes in my short couple years of nursing that I've been through, have experienced some ethical problems. I feel like sometimes during some cannulations and things are hectic and families are going through and families get pushed out and talked about. And there's been a couple of deaths that have hit me more being taking care of these patients on ECMO and the risks that go with it. So I think I have seen a couple times where a patient does go on and then go up to, they're seeming to do better, or going up onto the floors, and then all of a sudden some kind of complication or rest, and now they're back downstairs, back onto our floor, and back on ECMO, and they seem to never do as well. But yeah, it's hard.
I think that brings up a good point that I've just been noodling on since we've been talking about this, is just the idea that when we talk about a group of people coming to a consensus and having sort of a uniform way that we're going to approach this conversation with the patient and the family, I think a lot of times the people who are actually doing the procedure, like our nurses and our ECMO techs, are not necessarily in on that conversation. And I think we have to, I worry about asking someone that's not been part of the decision-making process to carry out something that they may or may not be comfortable with. And I think that it's an often overlooked group, because I spend a lot of time talking to bedside nurses and ECMO techs about what is going on and how they're doing emotionally with providing this level of care, when there is a lot of controversy about the appropriateness of or whether or not it is indicated or beneficial at this point. And so I think when we think about sort of like no one person should be making the decision, I think there should be multiple different disciplines in that room. I'm a palliative care physician, so of course I think that, but like, I think it would involve an interdisciplinary approach to think about appropriateness in these sort of gray cases, because it sounds like there's clearly green light cases, clearly red light cases, and then there's these yellow light cases where the indication for ECMO is not clear. And those cases are always going to exist.
You just brought up another benefit for having a formalized ECMO selection process. No, it's a really good point, Scott. I think, one of the benefits of our process is we actually do a fair bit of education to our nurses, our perfusionists, and other ancillary support in the CTICU about exactly what we're doing. We don't necessarily involve them in the clinical decision-making, and I think they're actually quite thankful for that. But what it has led to is an understanding of what that process is, and then trust in the physician team when we do make decisions that this went through this process, this patient was properly vetted, and this therapy is being offered appropriately. And and I appreciate that trust that they do seem to put in us when they're carrying out these tasks. And when we're wrong, I think that the accountability has to be there too, right? I have at least a dozen cases where these kind of gray zone fence cases where if I look back at them, at the decision that I made along the way, you can probe them and figure out, assuming it's a bad outcome, this is where I went wrong, or this is where we went wrong. And then we have a formal review process, and they're invited to that too. And then you learn and you try to improve. I think when this becomes really tricky in kids because nobody wants to admit to themselves that they made a decision that hurt a child. I mean, really any human, but I think there is a little bit. It's like the way that I talk about pediatric ECMO is like it's actually a lot like adult ECMO, but on steroids because of all of the additional emotion that comes in for better and for worse. And that's part of the reason why we're having this panel, of course, is because these issues are very emotional and very, very, very challenging.
I think including nursing, the ECMO specialists, the RTs, I think it would help decrease some of the moral injury because there are nurses I have watched walk away from the PICU because of some of the things that have happened. I also mentor, and I have gotten phone calls and text messages 1, 2 o'clock in the morning from some of my nurses that are just really struggling. So I think including them in that process, whether or not necessarily the decision making, but just being part of the overall process will really help.
Transparency. Yeah.
So I'm gonna make a comment. I know you guys were talking about moral injury and working hard in this ICU and multiple ECMO runs, but the reality sometimes I feel like sometimes we lose the context because if we don't have ECMO, these programs, the mortality will 1,000 high. And, I came, before coming here to a program, I practiced, I used to leave kids in the OR because I couldn't separate from the cardiopulmonary bypass. And they die in the OR, and they die, some of these kids in the ICU without not having a support. So, and that's why at times also give you, to practice the ECMO, they give you the false hope of ECMO, then you overuse the ECMO. And at times you can argue that we can overuse the ECMO, and we can have some of the complication of ECMO. But at the end, to have the mortality that low, that's all that effort to that. And I understand that at times it's hard to see these kids that we go back, chest open, bleeding, washout, and sometimes that's make this job tough. But at the time, it's important, and I think for these CICU nurses and everybody, see those kids when they come back, because only the cardiology team is the one who see when they come back to clinic, not all of us. And I understand sometimes in pediatric it's more difficult, the decision making than the adults. And the third one, a lot of these decisions, it's very rare. I'm not gonna say always, it's very rare that to be a unilateral decision to go on ECMO, it's most a consensus decision. Yes, I mean and that's why the beauty to practice medicine in a hospital like that, But at the end, it's like everybody, what is our experience? Yeah, and at the end, that's what we practice medicine because we practice every day by day. Yeah. So, and all of us, we have our cases that at times we regret going on ECMO and we should leave it on. But at the time we mature through the years and sometimes through the years get more experience. So
I will say just from the ethics consult numbers, the consults that we get about ECMO are always from the PICU. We have not had one from the CI. And I think if I'm just thinking about the cases we've had recently, I think some of that is that most of the cases that we get consults on in the ICU are moral distress on nursing staff. And often it's for children who are previously healthy. And something happened that's unclear. So a recent case was a child that was found down at home. It was an infant. No one knows for how long they were placed on ECMO. emergently in the ED, and then they came up to the PICU. And so I think some of the moral distress may also be related just through our own experience of what the underlying cause was. So it's different when it's a baby in the CI that has a known cardiac history than it's a previously healthy infant that we're trying to piece together what happened, right? I think that also shapes how we think about the decisions, interactions with the families, and how we then talk to the families about options.
Holly, we have a question that came in the chat. It says, it's asking, can we touch on what protocols are in place for a patient that is DNR that becomes asystolic? As an ECMO specialist, sometimes I find it difficult to be the one to turn off the machine when the plan was not to withdraw care.
So the patient is already on ECMO? Is that what they're saying?
That's the way I'm taking it. It's a patient that's on ECMO.
And they become asystolic and they are a DNR?
Yes.
Okay. So, I mean, theoretically, if they're asystolic on ECMO, they would still be supported. So that might not be a problem for that particular patient. So we wouldn't necessarily have to do anything unless their asystole is coming from the fact that they've just herniated or something in their head, and you have to do all those evaluations in order to find out whether they are still going to be able to be on ECMO. I mean, that's what I am interpreting. Like, does somebody else have another idea about that? Am I thinking that through clearly? Yeah.
I just don't know that I understand the question.
Yeah, I mean, yeah, that's what I was just like, yeah. So, I mean, that's what I would say is if they became asystolic on ECMO, unless it was a congenital heart problem, that it would probably be a neurological problem, and that you'd have to do all the proper testing to find out what that is, and then find out whether they remain they should remain on ECMO based on what has just happened to them.
Yeah, I think sometimes what gets a little confusing here is thinking of like, it sounds like in this case, like maybe non-escalation instead of DNR language. And just thinking about DNR is, I always remind people that DNR is not a goal, it's an order. And thinking about, I'm wondering if the idea of this question is something has happened while on ECMO and a decision is being made where it doesn't seem like ECMO is it will be beneficial in the future. And then thinking about how we react in that situation when maybe the family's not quite on board with coming off pump. But we've made a determination that perhaps the child will not be able to come off pump successfully.
Correct. I mean, I think
that's hard. That's a hard situation.
No, it's terrible. Right? And I think, I mean, we have had where there's been some catastrophic problem, and actually, unfortunately, the family doesn't really have any choice, where we literally are just walking in and saying to them, we have to take them off. And we have had that happen. Certainly in the PICU, when there's been some major neurological problem and they have to go to get their craniotomy, and we have to take them off of ECMO. And unfortunately for the parents, they don't have really any choice in that matter. So it's very difficult.
Yeah, I think there's a lot of challenging conversations around the time when you have a patient on ECMO. You now think it's unlikely they'll be able to decannulate and survive. You've likely, as a team at that point, deemed them no longer an ECMO candidate, but they're on. And so I think there's a lot of things to think through there around sort of how their end of life might look, or what we think will probably be their end of life, and how to guide the family through it. I know one odd way that came up with actually the patient I brought up who was on for such a long time, and the team was trying to work through sort of setting limitations but supporting goals of care. People brought up this idea of like, well, if the circuit goes down, do we say we won't put it back on, and how does that look in sort of navigating supporting a family, which I found very challenging and tricky as sort of a line to set. But anyway, those are some of the like ethical lines that I think can be really hard when you're towards the end of the life on ECMO, and B, maybe the team and the family have different ideas about sort of what the end of the patient's life might look like?
I mean,
Yeah, I think that there is a lot of moral distress that happens when the writing's on the wall, so to speak, and a patient is not going to survive. Obviously there are cases where, like you said, having some epistemic humility is a very, very real thing. But when the writing is on the wall and the family isn't necessarily aligned with understanding that at that point, this is actually something that we deal with quite a bit in adults, because a lot of them are awake and they have a tracheostomy and they can interact with you. I have found through mistakes and experience that the best approach is not to think about it as a time-sensitive thing. So being honest and truthful. So basically saying that this process, this disease process, that you will die from this, or your loved one will die from this. It's not a matter of if, but when and how, and then allowing the time necessary to go through the process of grieving. We almost never have to put a timeline, like we're going to stop the pump, or we need to do this in 3 days or whatever. It's just not the right way to handle it in my experience. Again, that comes from making mistakes, and then all of a sudden your alliance with the family becomes injured or destroyed. But I have not found that being truthful about what is happening does the injuring. It's typically pressuring the family to make decisions to withdraw in the time frame that you think is appropriate tends to be the issue.
Erica, since you're focused a lot on the end of life, would you like to speak to that as well, or?
Yeah, I would say I would consider myself a student of this question and not an expert in it, because it is certainly a very difficult one, and one that I hope with the project I'm working on will have some ideas and guidelines about what might work and what might not work. But even then, I don't think I'm going to come up with all of the answers in the next few months. That said, I would say a couple of things. One, I completely agree about timeline, like what's an emergency and what's not an emergency. And even in this example that's been put in the chat, like if they're asystolic but completely supported on ECMO, we have a bit of time to figure out what the next best step is. And there might be different opinions on what is a reasonable amount of time, but we may or may not have to walk in the room the second the monitor goes flat and say, okay, we're done here. So figuring out as a team what the approach is with the family, figuring out with the family what the next best step is, I think is a totally reasonable thing to take some amount of time to do. And then the second thing I would say is, I think that in my experience, and I think my initial foray into this question of stopping ECMO, I would say we all have families in our mind that stick out, right, as having been very opinionated in a way that was against was not in alignment with the recommendation of the medical team, and that certainly happens too. But I also think, in my experience, most families actually don't want to be responsible for making the choice to stop. And it is very common for families to actually see it as a blessing of sorts when that choice is taken out of our hands, and may even be portrayed as not anyone's active choice, right? If a patient's heart stops on ECMO, then it's not necessarily my choice as the doctor what's going to happen next either. Like, death is both a social construct and a biological reality, right? And so how we convey who's making active choices and what is actually what the patient is showing us, and how can we avoid making it sound like this is just something that we have decided and are making active decisions about, when actually the patient is showing us what is happening or what is going to happen, I think can be a useful strategy.
Okay. So I think we probably should wrap up to conclude, because it's we've already gone over, but it's hard to have ethical panel discussion with 8 people and not go over and have it in 30 minutes. So anyway, so I think
there is one more thing that popped
Yeah.
up in the chat, Holly, and I
Yeah,
just
go for it.
want to at least read it and see if we can maybe get a quick answer. So we're not leaving anything unanswered before we close for today. And the question is, we are opening a major cancer center this year. What is the biggest or most frequent ethical consideration that you have run into as a clinical team?
Scott?
What was the last part of it, Merritt?
What was the last part, Merritt?
It says, what is the biggest or most frequent ethical consideration that you have run into as a clinical team?
Well, I think it's, I mean, to be quite honest, I think it's about what we've been talking about this entire time is when is ECMO indicated? And I think the issue is that, especially in cancer, and I'll just speak with regard to cancer because that's the question, this is evolving, right? And as I said, in my portion of things, 15, 20 years ago, people wouldn't really consider this modality of therapy for children with malignancy. And so I think it comes down to selecting the right patients that you think would benefit from this therapy, being honest with people when you think it will not benefit them. And then what we've been talking about in this panel is this sort of gray zone where where things are not clear. I think being honest with families up front about if we're going to embark on any sort of therapy, whether it's ECMO or chemotherapy or radiation therapy or surgery, I think we, in cancer especially, I try to be as honest and upfront with people before we embark on that journey. These are the things that will let us know that the chemotherapy is beneficial. These are the things that will let us know if it is causing more harm than good. The same thing is true of ECMO. And I think, dovetailing on what we were just discussing, if we think of stopping criteria, things that let us know that ECMO is no longer beneficial, and we say those things as well as we can up front, when those things occur, the family is expecting that that is the next thing that will happen. I would not give cisplatin to a patient with refractory relapsed leukemia because I know cisplatin will not help them, correct? The same is true of offering mechanical ventilation or ECMO. If you think it will not help them, it's not something that you should offer. And so I think as you're building your cancer center, which I think is really awesome, build your cancer center, it's gonna be amazing. You're gonna help a lot of people. And you will run into cases where kids get really sick. And I think I would think of kids in those categories of, is this a newly diagnosed patient? Is this a patient who is in remission and is having a treatment-related morbidity event? Is this someone with relapsed refractory disease and is really sick because we have given them a lot of chemotherapy in an effort to extend their life? Or is this someone who is their indication for ECMO is progression of their cancer, and recognizing that we're unlikely to help a patient like that, and being honest with yourself and honest with families as you move through those things, I think will go a long way as you build your cancer center. I don't know if that's a good way to answer that, but it's the best I can do.
All right. I'm just going to turn this over. I'm sure Mike just has a quick announcement, but I want to thank everybody who responded to me and helped me to form this panel. I really appreciate everyone's opinions as we move forward. Thank you very much. And thank you, Tal.
I say thank you for Holly putting this together in the panel, and especially the people who came in from out of town to help with the panel. Same place, same time tomorrow. We're looking forward to it, and excited to see you all tomorrow morning. And our virtual guests as well behind us. Thank you.